इससे लाइव कर दिया।
हाँ नहीं वो छोड़ दो ना, मैं गड्डी में पूछ रहा हूँ।
चलो ठीक है।
आ गया, मैं आ गया।
बिलाली
यार फ्लैश पूरी नहीं है।
पैच कोड देखे इसमें नहीं है।
इसकी
एसडीए टू एसडीए की छोटी पैच कोड
नहीं है, एक भी नहीं है।
हाँ है,
क्या हो गया?
ठीक है।
बड़ी साइज की है कोई?
बड़ी साइज की भी कोई नहीं है।
ये रखी हुई नहीं क्या
फुल साइज की बोला।
लाइव करने की नहीं कैमरा।
नहीं लाइव नहीं, मुझे क्या हो, ये लैपटॉप लेना है।
चल ये मैं ही दूँ। अच्छा वो छोटी
या बिला आगे बैग में देखिए, टमाटर का पड़ी है तो ये बड़ी है तो
ये क्या बता रहा
ये
था?
एक्स्ट्रा था। ये कैमरे का आगे ये पड़ा हो गया। कौन सा कैमरा लगा है यहाँ पे?
X70
कौन सा वाला लगा है? पीला वाला बैग वाला है या फिर दूसरा है? पीले बैग वाला है
हाँ पीला वाला
में है या आगे कुछ है? नहीं इसमें नहीं है। चार्जर नहीं है, बैग आ रहा है हमारे गैस में है।
तो ये कैमरा चेंज हो जाएगा। लैपटॉप से ऊपर वहीं से होनी है।
हाँ लगेगा या उनसे वगैरह। हाँ तो डायरेक्ट ऊपर लैपटॉप लगा देंगे, कोई इशू नहीं। हमारा लैपटॉप वहाँ लगा रहेगा, अगर वो बोलेंगे हम निकालेंगे और केबल लगा देंगे, कोई इशू नहीं। अभी सेटिंग कर देंगे, अभी लैपटॉप लगा दें फिर आप देख लीजिएगा जो बता दें। अच्छा ठीक है जी स्टार्ट है।
ऑन करे, स्विच ऑन करे।
ये हो गया।
Assalamualaikum and good morning, ladies and gentlemen, esteemed guests and conference participants. A wholehearted welcome to you all at WFNS educational course. सही आ रही है आवाज?
जी सर ओके
ओके।
कॉल आई मेरे पास, कह रहे क्या मसला हो गया था दिल्ली का यार।
ये बिल्कुल आ रही है।
हमारे पास ऑप्शन है बढ़ाने की, बढ़ा देंगे आप। असल में नाड़ी थे वहाँ पे। तो कह रहे हो डिले क्यों आ रहा था, क्या हो गया था, मुझे पता नहीं क्या हो गया।
क्या डिले भाग रहा था?
कह रहे कार्ड की दे रहे हो ना।
फिर हम बता थोड़ी बता रहे।
नहीं वाकई कॉल आई थी वैसे होगी। कह रहे कार्ड की दे रहे, कार्ड नहीं हो शाम को दिए थे ना कार्ड।
हाँ तीनों कार्ड मैं बताऊंगा।
मैं शाम के पास कार्ड कह रहा चलो सही है, उसको सेंड करना, उसकी कॉल आ रही है।
है
पौने आठ हो गए। जिम्मेदार की क्या मैं बोलूं?
बोलो ना, यही तो बोलने के मौके होते हैं।
शायद
यही तो बोलने के मौके होते हैं। बोलो
7:05 से खड़ा हूं, 7:05।
7
देखो रात को फोन कर रहा था कि मोबाइल ले लो।
तू गाड़ू, मैंने कॉल करी, तूने फोन काट दिया।
दानिश तुम यहाँ तो बहुत बोलते हो, वहाँ भी तो बोलो ना, कुछ कमेंट्स में बात करो।
वो चाचू का बेटा, चाचू का बेटा, चाचू का बेटा।
वहाँ की तो कमेंट्स बात करो, अभी आएंगे तो बढ़ गई
यार इन्होंने ये बनाया स्पेशल, उसके लिए ग्लासेस बनाए, ऐसे कुछ 3D ग्लासेस बनाए। 3D बनाया ना ये देखो।
Hello. Hello, test. Hello. Hello, test. Hello.
Assalamu alaikum and good morning, ladies and gentlemen, esteemed guest and conference participant. A wholehearted welcome to you all at WFNS educational course held at Liaquat National Hospital and Medical College. I am Dua Fatma from 3rd year MBBS Liaquat National Medical College, your host for the day. As we gather to explore the latest advancement in neurosurgery, we will look forward to insightful discussions and collaborations that will shape the future of our field. Kindly ensure your mobile devices are set to silent mode during session. Let's start today's session with the recitation of Holy Quran, for which I would like to call Dr. Hafiz Kabir. Please come on stage.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم ألهاكم التكاثر حتى زرتم المقابر كلا سوف تعلمون ثم كلا سوف تعلمون كلا لو تعلمون علم اليقين لترون الجحيم ثم لترونها عين اليقين ثم لتسألن يومئذ عن النعيم صدق الله العلي العظيم.
Jazakallah. I am honored to introduce our moderator for this session, Dr. Nicole Peeve and Dr. Francisco Costa. Dr. Nicole Peeve is the co-chair WFNS Innovation and Technology Committee, consultant neurosurgeon, spinal surgeon at Kingsbridge Private Hospital, UK. And Dr. Francisco Costa is the head of Spinal Surgery Department of Neurosurgery, IRCC Foundation Neurological Institute, CBESTA. So kindly take the session.
Thank you very much. It's a pleasure to be here and to open these days with the spine section with my friend Nikolai. First lecture is by Corinna, that is online. I don't know if the connection is open.
I'm here. Can you guys hear me?
Hi, Corinna.
Hello, how are you?
Nice to meet you. How are you?
Good to see you too, Francesco. And good to see you.
You have to unmute.
Hello, great to see you guys. Can you hear me? Can you hear me?
One moment that we have some sound problem. Just the time to solve the connection problem with the microphone.
Can you hear me?
Corinna, try
Can
to.
you hear me?
Okay, perfect. You are online.
Wonderful.
Welcome.
Thank
So,
you.
It's a pleasure to introduce you and with your first lecture in an interesting topic that is the role of wearable technology in spine surgery using Apple Watch.
Wonderful. And can you see my slides?
Yes.
Okay, fantastic. And they're showing up in the correct presenter mode?
Yes.
Yeah. Okay, great. Thank you, Francesco and Nikolai and Salman. I really appreciate the invitation, and I'm sorry that I couldn't be with you in person. And I'm speaking to you from California. I work at Stanford University, and I'm very excited to share with you the results of our first randomized clinical trial using the Apple Watch in spine surgery care. So I know that pretty much everyone in the room knows that spine disease is a very common problem, both here in the US where I practice and also worldwide where all of you are. In the last 3 months, over 70 million US adults had back pain, and in the United States at least, we spend hundreds of billions of dollars every year treating patients with spinal conditions. We do over 1.5 million spine surgeries in the United States, costing us over 50 billion US dollars every year. Here, spine surgery can be extremely expensive, up to $100,000 a case. And as I'm sure many of you know, there can be pretty mixed results, especially when we're doing spine surgery for degenerative conditions. 1 in 3 surgeries may not completely relieve pain. And here I'm showing you one of our most famous American spine patients, Tiger Woods, who has now had 6 spine surgeries for spine conditions. So I would argue that we don't really have a good way for tracking our spine patients, okay? We have surgeon opinion. They come to see us. We see them for a couple of minutes. Their x-rays look good. We say they're doing well. In the literature, we publish a lot with patient-reported quality of life questionnaires. So we call these PROMs or HRQOLs. And these are basically the alphabet soup at this point that riddles our literature: ODI, NDI, SF36, EQ5D. And then we do have some functional performance tests, for example, a timed up and go test, a 6-minute walking test. How far can you go in 6 minutes? But the reality is that these aren't necessarily done in real life, and they aren't usually done in most surgeons' clinics. We currently aren't using any technologies or wearables or remote monitoring in spine surgery on a regular basis. So I would argue that these questionnaires and these surveys are the old way of doing things. They're subjective. They're how patients say they are doing after surgery or before surgery. They're cumbersome. They take a lot of time for patients to fill out. And we really only see how they're doing at one fixed time point, as opposed to seeing how they are doing in real time. So I argue that technology and wearables can provide us with objective data on how patients are actually functioning that's rapidly available and telling us how they're doing in real time. And so that's what really inspired me to do this Apple Watch study focused on objective tracking for spine patients. Before our work, there was actually very limited work in objective tracking for spine patients. Here's some work coming from Ralph Mobbs, who's a neurosurgeon in Australia. And back in 2016, he published a descriptive report of one patient who underwent a TLIF, wore a Fitbit for 1 year postoperatively. And you can see this graph here on the right, tracking his average daily steps. The patient's steps decreased slightly immediately after surgery, and then improved to an average of about 5,000 daily steps. His same group has done some more work. They looked at 30 patients who underwent spine surgery and wore a Fitbit for 7 days before surgery and 3 months post-op. And what their main findings was that the daily steps increased after surgery, as you can see in this bar graph here on the right. But they actually didn't find any correlation between these subjective PROMs that we currently use as the gold standard to monitor spine surgery outcomes and patients' daily steps. So our group did a preliminary study a few years ago now using a low-cost accelerometer called the Mi Band, and we had 30 patients who underwent spine surgery who wore this for a year after surgery. Interestingly, we found a little bit different from Ralph Mobbs' groups that daily steps after surgery went back to their baseline, but they actually didn't improve. So patients were not walking more 1 year after spine surgery than they were before surgery. And like Mobbs' group, we didn't find any significant correlation between subjective PROMs and daily steps. So this leads us to think, okay, what's happening here? I mean, should we be relying on these PROMs? Should we be relying on daily steps or other objective measures? What's the right way for us to really track our patients? So this prior work, really before 2020, when I started the Spine Track study, was based on small patient groups, really basic data. So primarily looking at daily step counts. People haven't done thorough analyses of exercise time, stand time, speed, heart rate variability, all of these other measures that we're now able to get with a bunch of consumer wearables. There weren't sophisticated statistical analyses that were looking at postoperative recovery profiles, and no one had ever done a large study using the wearable that in the United States has the largest market share, which is the Apple Watch. So that's why I started the Spine Track study, which is the first randomized control trial looking at the use of the Apple Watch in spine care and elective spine surgery care. We built a Stanford HIPAA-compliant app in order to obtain all of the data from the Apple Watch for our patients who participated. And we enrolled a total of 200 patients in this study. The goals of our study were to look at whether or not using the Apple Watch before an elective spine surgery was feasible and helpful for both patients and surgeons. We wanted to see if subjective and objective Apple Watch measures improve after spine surgery, because there's been some conflicting data shown from a few other groups as well as ours. And this in particular is important because we know that a lot of our spine patients can have significant anxiety and depression that come along with chronic pain when they're undergoing elective spine surgery. And so it's really important for us to really untangle the difference between the subjective and the objective. Also, as we begin to collect this objective data, we actually don't know what's expected and what's normal for patients with spine disease. So we need to start defining this. We need to figure out whether the objective measures correlate with the PROMs that have been the gold standard to date. Figure out if we can better characterize postoperative recovery profiles after elective spine surgery to help guide patients in their recovery. And then ultimately, the holy grail to create a new improved metric that combines objective and subjective data to better track our patients after elective spine surgery. So as I mentioned, we enrolled 200 patients in this study. Patients were eligible if they were adult patients who were undergoing elective spine surgery amongst 5 neurosurgeons within our group. They were randomized 1-to-1 to an intervention group or a control group. The intervention group received an Apple Watch, which they wore for 2 to 6 weeks before surgery and continuously for 1 year after surgery. We collected all of the health data from the Apple Watch via this study-specific app that we built and developed. And then patients and surgeons would receive progress reports at each follow-up visit, which was standardized at 6 weeks, 3 months, 6 months, and a year. They also completed all of the standard PROM surveys at their preoperative and postoperative visits. And the control patients only did the standardized PROM surveys as a comparison. They did not have access to an Apple Watch or any objective data or progress reports. These are an example of some of the, for those of you who don't have Apple Watches or iPhones, this is an example of some of the data you can get from the Apple Watch, including total steps, distance traveled, flights climbed, stand and exercise time, heart rate, and heart rate variability. And what we're looking at here is a sample intervention patient and what their progress report looks like when they come to the clinic visit at 1 year after surgery. So this patient had an L4 to 5 TLIF. You can see here their results for the subjective PROMs. This includes the SF36, EQ5D, the ODI, and the PROMIS. And you can see overall that compared to before surgery, their responses improved very significantly, and everything is now in the green for them. And in terms of how they did objectively, so this patient wore the watch for 409 out of 434 days that they were tracked after the study. They wore it for over 17 hours a day. You can see that their weekly pain scores decreased significantly over the period of the study, and their daily steps also increased very significantly after surgery, as well as distance traveled, flights climbed, as well as standing time. So this is a patient who's really improved significantly, both subjectively and objectively after their surgery. Here's another patient who did not have such a good improvement. This patient underwent a 2-level decompression laminopharaminotomy. You can see that before surgery, they had a lot of their PROMs were in the red, and they did improve, but they still have a lot of sort of mediocre PROM responses. And you can also see that when you look at their objective data, so they had very good compliance with wearing the watch over 91% of days and over 12 hours a day. Their pain scores still remained in the 5 to 6 level, and their daily step counts stayed fairly similar compared to preoperatively. So you can clearly see a very different recovery profile for from one patient to another, both based off their subjective as well as their objective Apple Watch data. And here you can really see that well visualized between the patient who's clearly improved at the top and the one who has kind of stayed middling after their surgery. So looking at the goals of our study, is using the Apple Watch before and after elective spine surgery feasible and helpful for patients and surgeons? We can see here, these are the demographics of the final patients that were in the group, including average age, BMI, gender. You can see our race distribution, as well as the distribution of surgeries, which included both cervical cases as well as thoracolumbar cases, both with and without fusions. So most of our patients were new adopters. The majority had not used an Apple Watch or other wearable device for tracking their activity before the study, and the majority had not used even a phone app for tracking their activity before this study. Despite this, we found that there was actually really great compliance. So on average, patients wore the Apple Watch for over 84% of their days since enrollment, which was more than a year, and for over 14 hours a day. And we can see here that 85% of patients were either extremely satisfied, very satisfied, or somewhat satisfied with using the Apple Watch in their spine care. And greater than 90% stated that these activity tracking reports were either extremely helpful, very helpful, or somewhat helpful to them in terms of tracking their data at their post-operative visits. And when they asked them specifically what they found the most useful, they stated that it allowed them to track their progress following surgery, understand their activity, keep them accountable, and set goals for improvement and understanding their health after surgery. We saw that Apple Watch patients have a better understanding of their post-operative recovery as compared to control patients, and that this activity data helps surgeons better understand their patients' post-operative recovery. So when we compared the Apple Watch patients on the left to those control patients on the right, the Apple Watch patients were more likely to say that their doctor understood how well they were doing after their spine procedure. And surgeons responded very positively with 95% either strongly agreeing or agreeing that the Apple Watch summary data helped them understand how their patient is doing after surgery. Next, we looked at whether or not subjective and objective Apple Watch measures improve after spine surgery. So I'll go through these very quickly, but overall, we have improved subjective outcomes. Here are pain intensity, ODIs, the personal care questions for ODI, walking ODIs, all improving, sleeping, social life, sex life, physical functioning on SF-36 is improving over time, as is SF-36 social functioning and SF-36 pain scores. But then we get to the question, so now we're collecting all of this objective Apple Watch data for our patients. We know how many steps they're taking a day. We know what their heart rate is, but what's actually normal for patients with spine disease and what's normal for a post-operative patient? So how are we going to interpret this objective data that we're collecting? So one of the sub-analyses that we performed was a sub-analysis of our preoperative baseline data. And the goal was to establish a daily activity measurement gold standard for patients of a certain age and sex who had lumbar disease. So we looked at a subset of our patients who had underwent spine surgery for lumbar degenerative conditions. And our goal here was basically to establish, just like we have Z-scores for defining osteopenia and osteoporosis relative to normal controls and relative to a reference population. We wanted to do the same thing for daily step counts for patients with lumbar spine disease. And we normalized them to a reference population, which was many thousands of patients who had Apple Watch data from the Michigan Predictive Activity and Clinical Trajectories in Health, or IMPACT study. So we looked at 65 of our lumbar spine patients. You can see here their distribution of age, gender, BMI, working status, and the reason for them having surgery. And you can see here that we found that their activity levels, not surprisingly, vary significantly by age and gender, with the highest step count in the youngest males and the lowest average daily step count before spine surgery in the older females. We found significant correlation between their daily step counts before surgery and the PROMs, including ODI, shown on the left here, and SF36. Here, we also found a significant correlation with the EQ5D, VAS, and the PROMIS physical functioning, which is shown on the right. So we use this to develop new gender-adjusted standardized disease scores for lumbar spine disease patients. And we stratified patients into categorizations of severe, moderate, mild, or no impairment based off of their mean step counts. So on the bottom right here, you can see that a patient with lumbar spine disease has no impairment if they're doing an average of over 11,000 steps a day. Mild impairment is in the 5,000, moderate is in the 3,000 daily steps, and severe is less than 1,000 daily steps. We did and you can see that this new activity performance classification correlates well with the PROMs, including ODI, SF36, EQ5D, and PROMIS. We did a similar study with our cervical patients. We have 30 patients here, and you can see their demographics. Once again, we were able to establish a similar performance classification, and note that these are different mean step counts because this is a different patient population with different pathology. But once again, now we have some objective step counts as compared to normalized controls, so we know how our patients are doing before surgery and what's normal versus impaired. And that's shown here. Similarly, we have this new activity performance classification for the cervical patients that correlates well with PROMs, including here the NDI and the SF36, EQ5D, and PROMIS. And then one of the issues is if you're running a study like this, you want to know how many days do you actually need to monitor data, because it's expensive to give the patients these watched to track it. So in one of our sub-analyses, we also wanted to establish the minimum number of monitoring days that we need to reliably estimate and predict observed variance in real-life physical activity for our pre-op spine patients. So you can see here that step counts were fairly consistent across their preoperative days. And keep in mind here that on average, we were looking at patients for 2 to 6 weeks before surgery. So we found a minimum of 2 days of wearable step count data was needed to estimate about 90% of the variance in their weekly physical activity, and 4 days of data needed to explain greater than 90% of variance for their 2 weeks of step counts. So we've established some of the first age and sex-adjusted standardized scores for real-life physical activity for patients that have both degenerative lumbar disease and cervical disease using our Apple Watch step count data. We're able to stratify their activity into activity performance groups that correlate well with subjective PROMs. And we hope that this type of standardization can enable clinicians and researchers to compare activity levels between patients who have lumbar or cervical disease and normal controls to help set very specific physical activity treatment goals for their patients. And while preoperative step counts remain relatively stable and that we can get good prediction models with 2 or 4 days of data, we do need longer activity monitoring to account for various variance in step count over a longer time frame, and in particular when we're looking at their postoperative recovery. So we have some great grants and a lot of smart people who are working on some of the later goals of the spine track. We have been applying some recurrent neural networks and other advanced machine learning techniques in order to better understand the postoperative data and these postoperative recovery profiles. So stay tuned for a lot more exciting work coming from our group. And I hope that I've convinced you that this is a really, really exciting and promising new way for tracking our patients using this objective data. And there are many, many people who have worked on this project. And I want to acknowledge our clinic research coordinators, research lab members, my PhD collaborator on the analysis side, Dr. Hahn, all of the spine surgeons at Stanford, as well as our APPs for allowing us to enroll their patients, as well as Stryker and Stanford Neurosurgery for seed grant funding. And this is my email address as well as my personal cell phone if any of you want to send me messages via email or WhatsApp. And then for those of you who are able to come to the United States or able to come to one of the spine section meetings, we're so lucky to have, I think Francesco came last year and a few other members of WFNS. Our next meeting will be in February in Tampa, Florida. Thank you very much.
Thank you very much, Corinne. Really interesting study. I don't know if there is any question on, yes, there is some question.
I have a question.
I have a lot of questions, but...
Hello.
Corinna, I wanted to ask you, you mentioned that it's expensive to give Apple Watch to your patients, but what you're tracking maybe can be done with some other wearable technology, some other watch that is cheaper. Have you had any thoughts about that, or you think Apple is crucial?
Yeah, so I don't necessarily think that the Apple Watch is crucial. What I would say is that running a study like this is very expensive, especially at Stanford, and primarily because of the cost that we have to do for the app development, keeping things HIPAA compliant within our platform, and then also paying a full-time research coordinator to follow up on the data. So right now we aren't in a phase where, I know we've kind of talked about this, but unfortunately we aren't in a phase where I can just give you a product and an Apple Watch and then we have something where you can instantly get the data and use it. You know, it's really at this point a research study, and that's the part of it that's expensive. It's only a very small fraction of the budget for this research project, which is now over $500,000 US, but only a very small fraction of that is the cost of the Apple Watch itself. The main cost is really like, how do you have it integrated into a system so that you're getting that data into your electronic medical record system so that you can use it? I think with regards to what wearable to use, there are a ton of wearable devices that have a lot of opportunity. You know, we tried the Mi Band, which is a low-cost accelerometer. The reason that I had ended up settling on the Apple Watch when I started this study now over 4 years ago was just because it was actually the number 1 consumer wearable in the US, and we have pretty good penetration, especially here in the San Francisco Bay Area. We have a lot of iPhones, so because we could only enroll patients who had an iPhone in this study, right? So we wanted to we had relatively good penetration, and there was a good platform for that, but there's not really a reason why this has to be an iPhone as opposed to a Garmin or a Fitbit. There's always a debate about getting the information from your phone, you know, because there are some studies where they're actually just tracking daily step counts from the phone. You can imagine that the phone is probably not as accurate as the watch. So that's why I really did want this study to be based off of a wearable on the patient as opposed to a phone. But, you know, people have their phones with them more and more. So there are a lot of people who are doing some pretty interesting research, just getting the data off of someone's iPhone or off of their non-Apple phones as well. So, you know, I think the simple answer is it definitely does not need to be the Apple Watch. The cost of doing a study like this, unfortunately, only a small portion of it really is the cost of the wearable. But if you are sort of thinking about, you know, how do you actually, you know, transform this in the long term into having this be part of standard of care, you do have to balance sort of the cost of the hardware as well as the cost of the software.
And my other question after you answered this is, I understand the cost mainly comes from organizing the research, not the technology you're providing to the patient. Have you had any thoughts on outsourcing this to the insurers? Because what I see in UK is that some of the insurers, or majority of the insurers, they are very keen to have some feedback information from the patient and to know what's happening pre and post operatively. They are very keen for us to report on registries or different feedbacks. So I'm thinking that the insurers actually might be interested to do the work for you. Have you had any thoughts about that?
Yeah, I mean, I think there's a lot of potential opportunity, there's a lot of potential opportunities. I had actually participated in like a Stanford biodesign program that we have where they talk about sort of commercialization. So, I think the first thing is that you have to show that this, which people we haven't really shown yet. We have to show that this data is, other than just the intuition that, yeah, it makes sense. We want to know how our, if we're doing quality of life surgery to improve function for our patients, it makes sense that monitoring their daily function in real life would be better. But we actually first have to prove that, that this actually matters. Why should we even care about how many steps they take per day? Does it actually correlate with subjective PROMs? Is it better than PROMs, right? I think we have to sort of prove first that there is a value add. And then I think there's many different paths towards commercialization. It's not necessarily my forte, but I think there could be interest from industry, both some of the companies like Medtronic or Stryker, as well as definitely from an insurance perspective. In the United States in particular, I mean, yeah, we have a requirement from CMS now to participate in a registry. All of these registries, cost money for us to pay people to put data into them. So some type of remote monitoring could end up, taking on that role. But it does, once you sort of prove at least some utility of it, you do end up needing a big company, whether it's an insurer, a medical device company, to put a lot of money into actually building that infrastructure to make it into a product that people can use. And I have not gotten to that step yet.
Okay, thank you. We have time just for one question from the audience, then we have to move on.
Thank you, Dr. Karina, for the wonderful talk. I have two questions actually. The first one is, did you only include the patients who were already scheduled for spine surgeries? And second, do you think your tracking of these variables in those patients who are initially given conservative treatment for spinal problems could help them in any way in devising their future management plan?
Yeah, great questions. So in this particular study, we enrolled patients who were planning to undergo elective spine surgery for degenerative disease. So they had to be undergoing surgery to be enrolled in the study because we were looking at them pre and post operatively. And we had one group, so both the intervention group, meaning the Apple Watch group, and the control group, both of them underwent surgeries. And obviously, by virtue of having the Apple Watch, we didn't change what surgeries they were going to have. The surgeons made the decisions that they made, and did whatever surgery they thought was best. But I do think that what you're getting at is really, really important, right? Because a lot of our patients, especially for degenerative spine disease, undergo a lot of conservative care beforehand, right? And so one of the questions that, one of the things that really, inspired me to do this was that after surgery, patients come and, they like ask me, okay, so, obviously we have a whole spectrum of patients, right? Sometimes I operate on a 22-year-old, Division I Stanford athlete, who literally is going to go back to doing some of the most intense activity, and so he at post-op day 7 is asking me, like, is it bad to run? Whereas I have the 85-year-old patient who is maybe taking like 700 steps, daily, for a year after surgery. And so to me, the patients would be asking about their activity limitations before and after surgery. And it feels so wrong that we give both sets of patients kind of the same general things, right? Like, so their goals aren't going to be the same, right? And so that was one of the things that really motivated this, this normalization for spine disease and cervical disease patients, because we really want to know, like, what's normal, I think it's popular for people to say 10,000 steps a day is normal, but 10,000 steps a day for a 95-year-old is not normal, right? And also 10,000 steps a day maybe for a 40-year-old who is, working full-time in front of a desk is also maybe not normal, right? So there's a lot of differences. But I think you're right in that having this, when you have this data, and you are getting it and you're getting feedback in real time about how you're doing, it can also be helpful for patients who are undergoing conservative treatment. It can also potentially tell us who's failing conservative treatment, right? So we've sent them for PT, we've sent them for a bunch of epidurals, and they're still only walking 700 steps a day and they're a 35-year-old, a 35-year-old man. That's probably not right. That may be a patient that we want to intervene in. And I think it can be used to help us create like very specific goals for physical therapy. But we just need more and more data in order to know what's normal and what the goals should be, And so this is a first pass at starting to get some of that data. But you're right, it would be really, really interesting to have it for conservatively treated patients as well.
Okay, thank you so much, Karina. Really interesting research, and we thank you for your great presentation and for answering these questions. We have to announce now the next speaker of today's talk, which is again you. So please carry on.
Okay. I didn't know if there was someone in between me. Okay, great. But I'm doing a different topic. I'm going to talk about robotics in spine surgery.
Great. Please carry on.
Okay, great. So I'm going to talk about incorporating robotics into simple and complex MIS cases. Give me 1 second here. Okay. Can you see my PowerPoint?
Yes.
Okay, beautiful. So first question is, why should we use robotics? So I argue that they can enable us to capture patients who are seeking less invasive MIS surgery. They can help us reduce radiation exposure to patients as well as potentially surgeons and OR staff. The goal should be to produce procedural consistency by automating trajectory alignment, and they can and should enable us to promote preoperative and intraoperative planning so that we can really have ideal screw and construct placement for our patients. So that's kind of the big picture of what the goal is that we're really working towards whenever we think about robotic platforms. And I would argue that navigation is really the critical foundation for robotics. First and foremost, navigation guidance enables us to place pedicle screws with the highest accuracy and the highest precision possible. And that's important because bad things do happen, okay? Despite excellent freehand screw placement by expert spine surgeons with decades of experience, bad things can happen to our patients when we place these screws inaccurately. And when we've done a meta-analysis looking at overall screw placement accuracy, we see that there is an incredible increase in accuracy of screw placement when we're using freehand technique in cervical, thoracic, and lumbar spine as we go from freehand to fluoroscopy to navigation. So basically liken it to a GPS on your smartphone, right? I mean, who would use a paper map or a compass nowadays when we have a GPS in order to get around? We found that CT-guided navigation was the highest accuracy as compared to freehand and fluoroscopy in a meta-analysis of over 50,000 screws. And interestingly, robot-assisted screws had the highest accuracy in the thoracic spine. So the first surgical robot for neurosurgery actually dates back to the 1980s when they used the Puma surgical robot to position a needle cannula for brain biopsy. And within spine, going back to the 1990s, one of the spine surgeons at the Barrow Neurological Institute in Phoenix, Arizona, Curtis Dickman, used the ASOP robot, which is a thoracic robot for thoracoscopic spine surgery. And really, he was mostly just using it as a holder. And we're all familiar with the Da Vinci surgical system, which is by far the most commonly used robot in surgeries across the world at this point. There have been millions of Da Vinci surgeries that have been performed, but obviously it's not used within neurosurgery or spine surgery in particular. So in the spine world, we had the Israeli company Mazor that developed the first spine-specific robot, the Spine Assist, in 2004. They were bought by Medtronic, and now it's been through many iterations, including to the Mazor X. But even into the late 2010s, there were pretty significant limitations of the spine robotic technologies, including inaccurate registration, requiring mounting to either the patient or table. The first spine robots were only placing K-wires. They weren't placing screws. So you would just have to tap and place screws, fenestrated screws over a K-wire. They would lead to increased operative time, and these initial ones were also not integrated with navigation technology. So that's where the Globus Excelsius robot came into play and was trying to address some of these limitations. I'm also going to add here that I'm not a consultant for Globus. I don't have any conflicts, except that I did do my spine fellowship with Nick Theodore at Johns Hopkins, who is the inventor of the Globus Excelsius robot. And you're going to see some images and description of our work from that experience. I also want to be very explicit about the fact that all of these spine robotic technologies that we're talking about really are cobots. So you can see the effector here, and the surgeon is still the one that's doing the drilling and putting in the screw through the robotic arm. Okay. And that's really important, especially when you're considering, in the United States, when we develop new technologies, we take them to the FDA and you have to get FDA approval. And it's much, much harder to get FDA approval for something where the robot is actually doing it, as opposed to something where it's a cobot that's helping guide the surgeon through the surgery. So I have friends who are not in medicine who ask me, oh, do you use robotics? And when I say yes, they say, oh, so you're going to be replaced. And I'm like, you know what? I'm pretty confident that I'm going to have a job, for the next several decades, because I see where these are going, but they still are cobots. They can't do everything independently. So these new robotic technologies are mounted to the floor instead of the patient or table. They have more rigid end effectors that allow surgeons to tap and place screws, not just K-wires. And super importantly, they're integrated with either 2D or 3D navigation in real time, either with pre-op or intra-op CT scan registration. The Globus one in particular uses 2 patient-mounted reference frames, because any of you who have done any type of navigation know that one of the issues that can happen is you can have poor registration if you accidentally move or dislodge your reference array. So this is a video that we put together from one of the first cases in the world using the Globus Excelsius robot. I think it's a nice way for you to see what the robotic workflow is like. And this is from an open case, and then I'll talk later about how we can apply this to MIS cases. And I'm just gonna play it, and can you guys let me know and confirm that you're able to hear?
This is a case of a 75-year-old gentleman who has previously undergone 3 lumbar surgeries with decompressions from L3 through L5. There is evidence of instability and loss of sagittal balance. He's an excellent candidate for a revision decompression from L3 through S1 with pedicle screw instrumentation and correction of his deformity. These surgeries can be challenging, especially given a patient's history of multiple prior surgeries. In this case, we will be placing robotically assisted pedicle screws with the usage of Excelsius GPS robot. Robotic workflow allows the surgeon to use 3 different imaging paradigms: preoperative CT with intraoperative registration utilizing fluoroscopy, intraoperative CT, or intraoperative fluoroscopy. In this case, the patient is positioned prone on the Jackson table to allow usage of the intraoperative CT scanner. After positioning, instruments are registered to the infrared camera, which is placed at the foot of the bed. At this point, we will be placing surveillance markers in the dynamic reference base. A single fiducial is placed in the left posterior superior iliac spine, which serves as a surveillance marker and alerts the surgeon should the fiducial array become disturbed. This is a critical component for assessing accuracy in real time. The dynamic reference base, or DRB, is placed in the right posterior iliac spine. The ICT, or intraoperative CT registration device, is attached to the DRB. This is a temporary fixture that needs to be seen in the medical image when the intraoperative CT is used. The patient is then carefully draped, making sure not to disturb the ICT or dynamic reference array. A cone beam CT is then obtained, and the data set is transferred to the image-guided robotic system. The drape is then carefully removed with caution so as not to disrupt the DRB. At this point, we plan screw trajectory by dragging and dropping phantom screws onto the robotic workstation. Planning all 8 screws in this case takes about 3 to 4 minutes. Since we are doing an open case, careful planning of the screw trajectories allows all screws to be placed within the confines of a single incision. Screw trajectory can then be checked by scrolling along the axis of the pedicle to ensure that each screw has the optimal orientation. Once this has been completed, the robot is draped and brought into the surgical field. As the robot is brought into the field, it displays that its positioning is capable of accessing all the planned screws. The robot is then stabilized to the floor. The end effector on the robotic arm is then registered, and screws are selected as the robot navigates to the pre-planned trajectories. The robot is deployed by selecting a trajectory on the screen and then depressing a foot pedal. Verification of accuracy is visualized on the screen, and real-time image guidance is used to watch the drill follow the plan. Given the extreme rigidity of the robotic arm, there is no need for K-wires or tapping. Holes are drilled and the screw is placed directly. There is feedback on the monitor given if the drill should skive. There's also constant monitoring of accuracy with warnings given should the reference frame move or the robot become inaccurate for whatever reason. After all the screws are placed, verification is performed with additional imaging to check screw placement. The decompression is then completed with facetectomies and correction of lordosis. Final correction is achieved with rod placement. The usage of robotic assistance can be invaluable in open cases with abnormal anatomy or in all minimally invasive cases where screws can be placed accurately without the need for excessive real-time fluoroscopy.
Okay, so you get the point. That shows you the workflow for the intra-op CT. And so what I will say is that the robot is much more useful now with a preoperative CT and an intraoperative fluoroscopy workflow, which makes it a lot faster. So we were really lucky, got to work on some of these early robotic publications looking at the first few cases with the Globus Excelsius. So these were the first 5 cases that were ever done. We use them primarily for a few level lumbar degenerative cases. You can see our overall EBL, and importantly, you can also see our fluoroscopy exposure was much less both for surgeon and staff as well as the patients, even with intraoperative O-arm spins for using the Excelsius than compared to MIS traditional fluoroscopy. We saw that over 95% of the screws placed in these first 5 cases had good screw placement accuracy as measured by the Gertzbein-Robbins grade A or B. And you can see overall, when we then looked at the first 26 cases, we compared the robotic assisted cases to the freehand cases, and we found half of the EBL and as well as lower length of stay by on average about 1 day for our patients that underwent surgery using the robot. We also wanted to see how accurate our actual trajectories were versus the planned trajectory. And you can see here that when we were looking at these 8 pedicle screws placed in 2 L4-5 fusion cases, we had very, very minimal screw tip deviation, mean tail deviation, and mean angular offset. So it was really good in terms of what we planned to do and what we actually accomplished with the robot when we looked at that. So what did we learn early on from some of these first studies using this particular robot? We learned that robotic screw placement is feasible and safe, that screw accuracy is high, and our planned trajectory versus the actual trajectories are very similar. And then I think one of the main things that people always ask is, how easy is it to get this set up? How does it affect your operative time? And what we did find is that operative time is higher at first, as you can see here on the right in this graph. The blue dots are the robotic cases as compared to the red line, which is freehand, and the operative duration for these cases. But as the number of robotic cases increases, you can see that the operative time does decrease. So as you gain experience, your OR time does continue to improve, and within a reasonable number of cases can actually get quicker than freehand cases. But robotics, I think, is really important and really mostly exciting beyond just thinking about some of these open fusions like that I showed you in the video. The preoperative CT workflow that uses intra-op fluoroscopy instead of needing an intraoperative O-arm spin is much more efficient. And it's great for screw placement in MIS cases. This is a really, really nice operative video that I would direct you to, published by Laura Snyder, who's a friend and colleague at the BNI. And she shows the workflow for a really nice MIS T-lift cage using the intra-op fluoroscopy. And this is just a great example of the Globot. And you can also use it in some more complex cases. So here's an example of a place that we used it in order to place some more complex screws. So these are, S1 transdiscal screws that go from S1 across the disc into the L5 vertebral body for a high-grade spondy. And this was an example where we were able to use the Excelsius robot in order to place a screw in this trajectory. Navigation and robotic technologies can streamline, accelerate, and improve screw placement. They can lead to some decreased cognitive and physical workload for the surgeon, but it is important to consider that the setup, especially for the robotic platforms, can be pretty extensive. There is a learning curve, and it is really important to have a consistent team, including your nurses and OR staff, to set it up in order to get past that learning curve so that you do achieve efficiency in the operating room. So in conclusion, I'd say that I personally believe that navigation is becoming the gold standard for spine surgery and spine instrumentation. Robotics in conjunction with navigation, importantly in conjunction with navigation, is a powerful emerging tool. The current spinal robotics are useful for navigated screw and inner body placement, and there are good preoperative planning platforms now with multiple different companies, both for open and MIS cases. This increased competition that we're seeing from the different companies is exciting because it's really accelerating technology development in this area. And future robotic versions are already starting to incorporate navigated drilling and decompressions. They're also going to incorporate navigated osteotomies and rod bending technologies like Bendini. So there's a lot of excitement, I think, for some of the new spinal robots that we're going to see in the next few years. A big shout out to the team at Johns Hopkins, where I did my fellowship, where we did this work with this particular robot, as well as my team at Stanford. And thank you very much for listening.
Corina, many thanks for a great presentation. We don't have so much time, but I cannot hold myself, and I'm going to do a comment question. So I started using the same robots in one of the places where I work. I haven't done many cases, but I have done some cases, and the way it stands is if I do a single level, non-complicated T-lift with the robot, it takes over 2 hours because of setting up. And if I do it with the old traditional way with the C-arm, it takes me less than an hour and a half. And then the other thing is, with the technique that I have developed, the last time I revised the screw was in 2017. Furthermore, I was speaking to Hamid Abbasi, who is in Minnesota, Minneapolis. I don't know if you've heard about him. He's promoting the endolift procedures, and he has done hundreds, thousands of them already. And he was telling me that he dropped completely any sort of navigation, and he's still working with the traditional C-arm. He's using actually 2 C-arms on AP and lateral position. So don't get me wrong, I still plan to continue using the robot and to develop it, but anyway, I want to hear your comment on what I said.
Yeah. So I think that I mean, what I would say is that, especially in the United States, I think that navigation is becoming the gold standard. So yeah, there may be some people who are still very headstrong about. So I think you're right. You can do it faster with the C-arm. But the reality, at least in the medical legal climate in the United States, is that when we have such readily available navigation platforms, when there's so much data that shows that the accuracy of screw placement is higher with it, and you practice in a place where you have access to a navigation platform, you are going to be very hard pressed to defend yourself in the one time. I mean, yes, one time in 10 years, but if you do have a screw you need to revise, you're going to be very hard pressed to defend yourself in the United States for why you didn't use the navigation platform. The reality is that many cases are more straightforward and you don't necessarily need it. But once you start to use, so I use navigation routinely in every single one of my cases. The more you use it, one, the better you get at it, the better your staff gets at it. You use it for the easy cases, then you know when it can be off and how to troubleshoot it for your harder cases. And it's a problem for training because we have, it's you can't you need to also understand the anatomy in order to do the to do navigation well. And so we have a a time right now where our residents are coming through. And so when I was training, I pretty much did everything freehand with a tiny bit of navigation. So I wasn't like super adept at the nuances of navigation. I started out in practice, 5 neurospine surgeons. I and the other junior spine guy were the only ones who used navigation. Now all 5 use navigation in almost all of their cases, maybe just not for a few of their lumbar fusions, but otherwise pretty much everyone is routinely doing it. So we've definitely seen that inflection point, I think, in the United States with regards to navigation. So kind of speaking a little bit to your second comment about the surgeon, and obviously this is still debated and we talk about it all the time and we have nice and friendly debates. Robotics, I think, is more complicated. We definitely have not gotten to the inflection point, in my opinion, where robotics it's definitely not the standard of care. And I don't think we've gotten to the inflection point where the value add of the current robotic technologies adds that much more over a navigation platform, because it still has so much more baggage of the setup and the time compared to using, another platform, whether it's Stealth or any other, Stealth 7D or any other sort of CT guided navigation platform. So I think it will continue to improve. I think we're probably maybe looking kind of over the next within the next 5 years or so, we might become closer. 5 to 10 years, probably, we will reach that point where it does have more value add. But right now, yeah, in many cases, it may not be as efficient. And I think in particular, comparing to freehand is one thing, but comparing it to navigation may not really have that much value add right now.
Thank you very much, Corinne. Really impressive your communication. Thank you very much. We have to move to the next session. So thank you, and we close this session on spine.
Great. Thank you guys so much for having me.
See you soon.
Bye.
Bye-bye.
Dr. Nicolo Beeve will be our next speaker. Dr. Beeve? Yes.
Sorry, I have another program, so. What's your topic, Nikolai, so I can present you? Okay. So, we move on with another communication spine, and Nikolai will show his experience. Thank you very much.
Good morning, sir. Can you tell me the topic of your speech?
Yeah.
Okay.
So it's a bit of a change of the program, and I'm thankful for the organizers for changing that to accommodate my topic. No, I think this is as part of the program, but there were some changes in the program. But there is another topic that I have to present tomorrow, but I might be presenting today as well. So thank you so much for that. Yeah. Okay. So we don't see it. Okay, we see it now. So I'm going to talk to you about the transforaminal endoscopic approach for discectomy, decompression, TLIFs, and what would be the considerations how to start if you haven't started that. This is what you can do with the technique that I'm going to be talking about. It's quite impressive. This is not yet my work. This is courtesy of Hyung-Sung Kim from South Korea. I started doing this, but not as extensive as these pictures, but that tells you what you can do with the technique. So I'm going to present to you, this is one of my first cases. This was basically a young 49-year-old, slim, very active woman, marathon runner. She was not possible to run anymore because of back pain and leg pain, bilateral leg pain with radicular pattern. You can see the MRI scan, single non-complicated grade 1 listhesis, L4, L5, clearly the reason for her symptoms, and that's what I have done. Endoscopic TLIF approach, endoscopic TLIF procedure, which went well. She was up and about the same day, and she was discharged the same night, and she's doing well. So I personally feel hopeful about this technique. That technique, this case, having on mind that is one of my first cases, took me a little bit more than 1 hour, which is already a significant improvement of what traditionally I would use, which is minimal invasive TLIF, which will take me roughly about 1.5 hours. So if you want to start that, there is different ways to start it. Of course, we were discussing, if you remember yesterday, what is the best way to start a new technique, and the best way to start a new technique still remains to go for a fellowship somewhere, to dedicate 1 year of your life to a new technique, to do a good number of cases, and to establish that new technique in your center. But unfortunately, that is not always possible. If you're in the beginning of your career, you're still quite flexible and possible to dedicate 1 year of your life and go somewhere. But if you are like me, already well within, it's very difficult to drop your life, to drop your work, and to go somewhere for a year. So there is alternative to that, and I'm going to talk to you about this. So apart from the fellowship programs, you can have cadaveric courses, you can have online courses, you can have online resources, you can go for a short-term observership and fellowships, and you can have invited faculty that come and help you. And if you combine all of these things, then it might be possible to get away without a dedicated fellowship. So you have a complex problem. The best way to do that is to crack this problem to a little bit of simple problems. And so I'm going to try to demonstrate that to you. So if you think about this technique, what's important is to have a very good understanding of the surgical anatomy, to have a very good understanding of the X-ray anatomy. And that's why I put here injections. And if you're doing spinal injections, that is a very good way to learn the X-ray anatomy. Previous experience is always is a good thing to have if you were doing before something that is similar to that, or if you have parts of this surgery that is involved in another type of surgery that you're doing. That's always very beneficial. Patient selection for whatever technique is important. And if you're starting new technique, that's even more important. You have to be very careful what patients you're selecting, because if you select the wrong patient and if you have a disaster in the beginning, that will scar you from the very beginning, and that will not allow you or it's going to be very difficult for you to continue. Team selection and support faculty is also very important. And if we manage to achieve all that, just go and do it. You have to just be brave and go and do it sometimes. But when I speak brave, please don't take it wrong. Don't take me that I am encouraging you to be responsible. No, you have to be brave, but you still have to be responsible, and you have to do things only when you're really prepared to do it, when it's something new that you haven't done many times. So if we are talking about anatomy, we spoke about the anatomy, and I'm going to just mention to you, this is the anatomy that you really need to be familiar with in order to start that technique. This is where you normally would see your disc herniations, for example, and most of your work in lumbar spine will be in that area. Rarely we do far lateral discs. And then usually what we do is we have to do this kind of bony work here in that region. Significant part of the work for a spinal surgeon will be here in that region. And we are mostly familiar with that kind of work here, work in that region here, and doing that kind of bony work. Unlike the traditional open approaches that we do, when we consider doing endoscopic transforaminal work, we have to be we are going on the other side of the facet, which is completely different with completely different trajectory, completely different way you start perceiving the anatomy. So you will need a little bit of experience with that. Cambin's triangle is the fundament of the transforaminal approach. You have to familiarize yourselves with the concept of the Cambin's triangle and the Cambin's approach and the Cambin's space. So this is how it looks like. This is the area that you will focus when you're doing transforaminal work, and understanding the anatomy, detailed anatomy of the neuroforamen is of utmost and crucial importance. What I want to start with is, and I will not be tired in any time to continue repeating that to you, is that your lower end plate is your best friend. So you have to, whatever you do, if you're doing transforaminal, transcambens work, you have to stay as close as possible to your lower end plate when you're doing your approach. And the fundament of that is this picture. You can see that because of the oblique course of the nerve, if you stay close to the lower end plate, you will enter safely in that area here, in that small hole here, and then using sequential dilation, you will displace that nerve root. Instead of, if you are not staying close to the lower end plate, when you start docking your instruments, which is the first steps of your surgery, you will dock your instrument on the nerve root. So just imagine if you are close up, because of the oblique course, you're very likely to dock your instrument right on the nerve, and then that's it. You start with disaster and you will continue with disaster. So the other thing that I mentioned to you is when you are considering to do endoscopic or minimal invasive work, you really rely on radiographic anatomy. So you have to have very good understanding on the radiographic anatomy and how this is projecting, how your anatomical structures are projecting on the X-ray. So you have to have the good understanding on that. And the first step of understanding the X-ray anatomy is to know how to take reliable pictures. So this will be your number one priority. And your number one priority is to understand how to take a reliable picture. And reliable picture is very important because this is your eyes. You don't have the anatomical landmarks when you're doing minimally invasive or when you're doing the endoscopic. You have X-ray landmarks. And if these X-ray landmarks are misleading, then it will have a disastrous surgery, and then it will not be possible to do it. So when you're doing this type of surgery, you have to be very careful, and you have to be militant to your radiographer to give you true lateral and true AP X-ray. Always make sure that you're getting true lateral and true AP and true lateral. So talking about true AP, what is true AP? This is an X-ray that you see your object of interest, in that case, the end plate being a line, not being an elliptical shape here. So this is a bad end plate. This will mislead you because you don't know which one is front, which one is back. It's very difficult to judge here, but when it's line, it doesn't matter. So if you would like to follow an end plate, your end plate should be a line. It should not be elliptical. So this is true AP. And the other thing is you have to be well centered in your neutral position. So you have to see the two pedicles equally distanced from your midline, from your spinous process. This is what a true AP image is, and this is very important. If you don't get that, you're going to have disaster. Same thing is for the lateral position. The good true lateral image is the image that you see your object of interest, in our case, the end plate as a line, not as elliptical. And the other thing is, still, despite the modern imaging intensifiers are improved, you have to try to follow your object somewhere in the middle of your screen. Otherwise, there is still aberrations around here, so that still misleads you. So if you're following an object, make sure it's in the middle, and make sure that this is on a true lateral and true AP. So the other thing is, but that's very important, this is how you start your surgery. So you start your surgery with the incision of the skin. And while if you're doing the open surgery, you can do the incision a little bit up, a little bit down. If you are not really happy with your incision, you can just open a little bit more. With the minimal invasive, and especially with the endoscopic surgery, you can't do that. So your surgical planning is of utmost importance. So where you put your skin incision, because the skin incision is very small with the minimal invasive surgery, and with the stap, and it's a stap incision with the endoscopic surgery, is even more important. You have to put your incision on the right place, because you don't have much of a wiggle space there. And so that is, when I started in the beginning doing courses for transforaminal work, they were teaching me that if you're at L5S1, you have to do 12, 16 centimeter offset. If you're at L4, L5, you have to do 11, 14 centimeter offset. And I was not possible to understand how, if somebody is 60 kilos, will have 12 to 14 centimeter offset, and somebody who is, let's say, 120 kilos, again, will have 12 to 14 centimeter offset. So I was reading about that, and I developed this, and I read this technique on this system of the three colors. So basically, what I do is I take on lateral, true lateral, remember true lateral, I take X-ray that will mark me my supraspinous line, and then my suprafacettal line, and on lateral, this is the green zone where I will start my stab incision to approach the foramen. So you have to be in that green zone to be possible to safely approach the neuroforamen. If you're in that blue zone, it will be too lateral, you'll not be possible to get in. If you're in that red zone here, you're going to get in the abdomen and you're going to injure abdominal organs. So you don't need to remember numbers. If you follow that, that's what I do for the last years, and that's always working well for me. So this is something that you can apply easy. This is again on another projection. You can see here that's an axial image. You can see the blue zone, you can see the red zone, and you can see the rational. If you stay in the red zone, it is likely that you will safely enter the neuroforamen and it will do the job. If your object that you want to address is more laterally, obviously your trajectory has to be more steep, so you have to stay closer to the blue zone. And if your object that you want to address is more medially, then obviously you have to stay closer to the red zone. So this is the way I apply these three colors. And then it comes to starting with with the first step of your transforaminal access is going to be always docking the starting needle on the right place. And this is where you have to start docking your needle. So usually you start docking your needle at the tip of the superior articulating facet of the lower vertebra. This is what you see on lateral. On an AP, you're just about to enter the neuroforamen. This is the first step of any transforaminal approach that you have. So if you stay closer to the pedicle, remember I told you and I showed you the anatomical rationale behind that. If you stay closer to the pedicle, it is very unlikely to damage the nerve. That's the rationale. So remember, the end plate, the lower end plate, is your friend. And then you have to always think about the 3D awareness. You have to be always aware of where the tip of your instrument on two projections, AP and lateral. And this is how you advance your needle, and this is the landmarks that I follow. So on AP, you have to see that when you are docked properly, on AP you see that you are not medial to the medial pedicular line here. This is the line that goes tangentially on the upper and lower pedicle. And then on lateral, you have to be on the posterior vertebral line. And this is how it looks like on a model. You are just on the disc, just laterally to the dura, but not inside the dura. So you have these three lines here that you can follow. The medial line is the red line that you should not be crossing when you're finally docked, and then on lateral again you can see that. So I will show you now a few wrong dockings. So this could be a wrong docking or it could be a right docking. You can see here that you're slightly more medial than the medial pedicular line, but here on lateral, you can see you're past the posterior vertebral line, so that means disc. You're inside the disc. If you're doing inside-out technique, discectomy, this could be okay. If you're doing TLIF, endoscopic transforaminal TLIF, this could be okay. But if you're doing just outside-in technique, this is too deep. So this is very wrong. You can see here on the lateral, you are just about in the posterior vertebral line, but here you're too deep. You're nearly in the midline, so that means you're inside the dura. If you're inside the dura, you're going to damage the dura, you're going to have disaster. So this is very, very wrong AP lateral projection. So be careful if you see that picture. And this could be also very wrong because here you can see that you're just about the medial pedicular line, but here you're too deep. So likely here you're in the abdomen, so you can damage abdominal organs. So then the next step of that approach will be you introduce over the needle that I showed you, you put a key wire and then you start sliding your instrument. You're sliding your cannulas, you're sliding your dilators, and you follow basically the same rules as with the needle. So you have to follow on AP and lateral, and you have to follow the same landmarks, which are X-ray landmarks. And this is your endpoint. This is how you have to dock your instrument, and then you remove your dilator and you start doing your work. I'll skip that. So this is where you stop if you're doing if you're doing discectomy. This is the picture that you have to see. You're docked, you can introduce your working cannula and you start doing work here, taking disc decompressions. But if you want to continue further, if you are doing this TLIF procedure, you basically continue further, introduce your dilator further in the disc, And later on, you can introduce the working cannula. And this is it. Once you are introduced to your working cannula that can pass a cage inside the disc, the rest is easy. This is the approach that, this is the crucial part of your surgery done. After that, there is different instruments that you can use to prepare your disc. Now there is different companies that provide that, and it's easy to prepare your end plates and to introduce your disc. So previous experience, I know I'm way past my time, so I'm just gonna say a few things and I'm gonna finish. Injections, I mentioned to you that injections are very important. They were very important. I do quite a lot of injections in my practice. And they are very important because I had the good understanding of the X-ray anatomy, a good understanding how to take true AP, true lateral. So if you are not doing injections, it's a good diagnostic tool in the hands of a spinal surgeon. And also that will train you well to understand your X-ray anatomy. So start doing injections as a first step of your preparation for endoscopic or minimal invasive work. Previous experience, I had good experience with endoscopic, with minimal invasive TLIFs, so that also helped me. So this is the way I do the injections. The traditional way to do, let's say, transforaminal injection is you go 4 centimeter offset and you use a relatively short 9 centimeter needle to do transforaminal block. What I started doing is I started doing this long 15 centimeter needle, and I do roughly the same trajectory as transforaminal discectomy. And that's beneficial for my trainings, that's beneficial for the training, for the patient as well. So if I have really stenotic foramen, if I use that long needle and with the steep trajectory, I enter the foramen in 100% of the cases, while with that trajectory, that might not be possible. So you have good result of your injections as well, and you're training the trajectory. Endoscopic experience is very important. Scrub team, anesthetists, radiographers, very important as well. Patient selection. Your first patient will be somebody who is young and fit, ideally L4, L5 level. You would not select this kind of picture for a first case, or you would not select L5S1 because you will have iliac crest and you'll be struggling. And finally, I want to tell you a few words about the radiation. That one of my first cases that I did, this is the radiation exposure I had. There's quite a lot of exposure. That will drop significantly with your experience, but you have to learn how to protect yourself with, and you have to learn the radiation protection. And thank you so much. Sorry, I'm running late.
Thank you very much. Good. Probably we have time just for one question.
Well, the most endangered structure will be the existing nerve root, but you will have also, you can be theoretically, not theoretically, but also practically. You can be too medial and you can endanger the traversing nerve root, you can endanger the dura. If you're too steep, you can get inside the abdomen and you can, you can damage your kidney, you can damage a bowel, you know, you can do a lot of, you can be very naughty, you can do a lot of things.
Thank you very much.
Okay.
So we can move to the next section now. Okay. Thank you very much.
One more cable, sorry.
Thank you, Dr. P, for the amazing talk. And thank you, Dr. Costa, for moderating this session. We move on to our next session, which will be on endoscopy, skull and tumor. It will be moderated by Dr. Abu Zergungur from Turkey and Dr. Sabino Luzzi from Italy. I would request them to please join us on the stage. Thank you, sir. The first speaker for this session will be Dr. Mahmoud Qureshi, who will be speaking on the brain anatomy of the skull bone. Dr. Qureshi, if you could join us on the stage.
Thank you, Salman, for your invitation and your whole team. You're always amazing. And we always look forward to the next course that's going to happen in Karachi. You've enticed us, you've spoiled us, and you really give us a wonderful, wonderful occasion to meet with individuals from across Pakistan and, of course, across the globe. So thank you so much. So I was asked to speak on the bony anatomy of the skull base, and I do hope that it will be enlightening and also useful for our young upcoming neurosurgeons and residents. So I come from a place reasonably far away, not as far away as Mexico, but I come from Kenya, where I am the fourth generation from a grandfather who left this land in 1910. So I do have connections with this place. The skull base is approached by neurosurgeons using the microscope and the endoscope. And when you look at the two, you will see that there is obvious differences in the clarity and the anatomy. What you see on the left is what you would ordinarily see from below using the microscope endonasal anatomy. On the right is the endoscopic endonasal anatomy. And quite clearly, if you can familiarize yourself with both, then you're going to have better outcomes. So understanding of the skull base starts with understanding the middle skull base. If you can, it is the key to your becoming aware of what lies ahead when you're doing procedures in the skull base. So the sphenoid bone is the cornerstone of your skull base. This is the classical anterior view of the sphenoid bone. That gives you the body, and the lesser wings, that's your body of the sphenoid bone. You have your lesser wings here, you have the greater wings, and you have the pterygoid processes. So that is your cornerstone that you must become very familiar with. And here we see the various components of the skull base, the sphenoid sinus, which is traditionally the area that we enter when we're doing pituitary surgery. You've got your lesser wing, you have your greater wing, you've got your pterygoids, the medial one, the lateral one, and you have your foramen rotundum. So this is essentially the cornerstone that you need to familiarize yourself with. This articulates with the frontal bone anteriorly, with the temporal bones laterally. Are you coming to punish me for something? With the temporal bones laterally, and with the occipital bone posteriorly. So the cornerstone, which is the sphenoid bone, articulates with these frontal, temporal, and posterior bones to give you together, forming the whole skull base. So then there are the various views that you must become familiar with. There is the planum sphenoidale, where both the lesser wings come together. There is the anterior clinoid processes. There is the tuberculum sellae, the chiasmatic sulcus, the sellar floor, the dorsum sellae with posterior clinoids, the carotid sulcus laterally on both sides, and laterally important is the foramen orifice, which is the rotundum, the ovale, and the spinosum. So essentially, these are the key elements of the sphenoid bone that you must familiarize yourself with and be very aware in terms of where these bony landmarks lie and where the foramen that are key lie. This is a slightly more detailed view. That's your anterior clinoid process there. You have your tuberculum sellae, the sphenoidal jugum, and your chiasmatic sulcus, where your indentation of the chiasm is. This is the sphenoid crest. On its anterior wall articulates with the voma, which is the midline reference during our procedures that we do through the transsphenoidal approaches. So again, an overview I'll skip this next one because it has more detail than we would want to see, but this is useful. This is the endoscopic endonasal anatomic view of the planum sphenoidale, the sellar floor, and the clivus area. So when you're going endoscopically, you want to be aware where the pituitary stalk is, where the sellar floor is, where the clivus is, where your optic protuberance, that's your optic protuberance on either side. This is the optico-carotid recess. As you keep drilling or dissecting, you need to be aware where these are. This is your paracella segment of the carotid. So when you're looking at your pituitary stalk, the sellar floor, you need to be aware where the carotid protuberance is in the paracella area, equally where the carotid protuberance is lateral to the clivus. So this is the paraclivus protuberance of your carotid. The vessels are in this area, the endoscopic endonasal anatomy of this anterior skull base. The superior part of the nasal septum has been actually removed in this image. So that's your anterior ethmoidal artery indentation, your posterior ethmoidal artery indentation. You've got your orbits on either side. You've got the cribriform lamina here. You have your planum sphenoidale, which we described earlier on the earlier slides, and you have your sella torsica in this image. You dissect further, you take off some more bone, you begin to see where the chiasm is. You see the pituitary stalk right there. The pituitary gland is in that region. Your clivus is here. And then this is the floor of the sphenoid sinus, as you've dissected more. And that's your soft palate coming into view. The paracella segment of the internal carotid artery, that's your paracella, and your paraclival carotid artery is in this region. We carry on further. In this one, the neurovascular structures of the left side have been exposed after opening the bony surfaces over the sella. So you see this in more detail. This is your internal carotid, paraclival segment of your internal carotid. Your paracella one and your where is that? This is your paraclival internal carotid. That's your paracellar internal carotid. You've got your foramen lacerum. You have your gland. The Gaussian ganglion is right there. And then that's where is located your abducent nerve, your V1 of the trigeminal nerve, the V2 of your trigeminal nerve, the V3 of your trigeminal nerve, and the superior orbital fissure is in this region as you continue drilling very gently, one would hope. So again, the endoscopic endonasal view of the superior third of the retrocrival area is exposed here, revealing the neurovascular structures after that bone has been removed. So we've got the paracellar internal carotid segment, the paraclival internal carotid. You've got your oculomotor third nerve coming into view here. So this is now tiger territory where all the vessels and your arteries and the nerves are, so one needs to obviously be very gentle during the drilling procedure. Endoscopic endonasal view a little more. So this is what you see after you've dissected more, including the basilar, the vertebral, and the spinal arteries, the ICA, and the abducent nerve. I'll rush through here. And again, more detail as you continue going further in to see the optic nerves, the chiasm, the internal carotid artery, the pituitary stalk, and the superior hypophyseal artery. And then you obviously go further in and begin to see more detail of your vessels. So in summary, the cellar and the paracellar region are the most common regions reached by us as endonasal endoscopy surgeons. The nasal, paranasal, and skull base bony landmarks and the vascular of this region is of paramount importance, and one must spend time learning about it in the cadaveric lab. And it's important in achieving successful skull-base surgery via an endonasal approach. Always plan your approach well in advance. Look at your scans very, very critically, your MRIs, and of course, neuronavigation is now a blessing in this sort of situation. So the take-home message is that endoscopy has enabled views of structures such as the planum, the clivus, carotid, optic bony protuberances, very different from the well-established microsurgical view. The pathology in these regions is approachable through, which was approachable only through invasive transcranial surgeries, can now be operated and removed safely via endonasal route. Over the last decades, an interchange between evolving approaches and new technologies has taken place, allowing even more approaches to become standard approaches. However, it requires you to spend time in anatomical dissection labs to familiarize yourself, relearn your anatomy before you even proceed towards the operating room. And it is essential that one becomes familiar with these endoscopic skills, endoscopic anatomy, in order to avoid complications and manage your patients through these approaches well. With that, I thank you very much.
Thank you. Thank you, Professor Holt, for this beautiful, wonderful lecture. Any question from the audience? Do you have any question? No questions.
I think we'll move on to our next topic. Our next speaker is Dr. Serdar Kahraman from Turkey, who will be speaking on hybrid approach for glial tumors. Dr. Kahraman.
Good morning. Thank you for having me in this conference. So I want to talk about the hybrid approach for glial tumors So first of all, hybrid means the composite of different element sources approach which provides the better than individual things. And when we come to the hybrid surgery, in terms of the hybrid approach, it means the reproductive cross between the technological devices in operating room and also conjoint imaging and diagnostic technology during the surgery. And also the other part of this hybrid approach is the multidisciplinary collaboration with the other disciplines. So advantages of the hybrid surgery, which is including the improved patient outcome in terms of the more convinced surgeon and team, short anesthesia and surgical time, low complication rates, short hospitalization, minimize approach-related injury, and also radiation safety. That means overall lower cost of care. So what about the hybrid surgery in glial tumors? It means the maximal safe resection in glial tumors. We have the minimized craniotomy, iatrogenic cerebral injury, minimized morbidity, minimized complication, maximized Karnofsky score, and minimized residual tumors. And also it provides the convenience for adjunctive therapies. So what we have in hybrid neurosurgical operating room, of course, we have some kind of radiological tools in terms of the open MRI, ORM CT, neuronavigation, and also conjoint images. And if you are doing the kind of spine and carbon fiber radiolucent operating table, and also it's very important to have the optical filters for microscope with the fluorescent and also the IC. And also you can use the neuroendoscopic assisted approach to see the hidden zones with the microscopes, and you should have a frozen pathology and also intraoperative multimodal neuromonitorization. So this is the arm CT, you can use it with the frameless stereotaxy, real-time imaging, and update for neuronavigation. And of course, you can do the frameless stereotactic biopsy instead of the frame stereotaxy, and you can do it stereotactic craniotomy, stereotactic transsulcal cortical incisions, and you can use it to understand the simple cortical mapping with MR tractography merging with the neuronavigation. So this is the very short video about the navigation. Everybody use it nowadays. So you can easily determine your tumor where is, and then you can plan your incision and also craniotomy according to your navigation plan. So the other one is the fluorescent microscope. It's very useful to differentiate the tumoral tissues between the tumoral tissues and the normal brain tissues. And also you can do it the real-time fluorescent cerebral angiography if you need it. And this is the very short video about the glial tumors. So we can do the transsulcal incisions with using the neuronavigation. This is the fluorescent microscope view of the tumor. You see it's very, very easy to differentiate the tumoral tissue with the very yellowish color of the fluorescent, under the fluorescent microscope. This is the glial tumor you see. And of course, you can see the vascular structures under the fluorescent microscope with using the fluorescent administrations. And then at the end of the surgery, this is the normal microscopic view. And we are removing the glial tumors after supramarginal resections. This is the final check of the tumor bed. And you see still we have some fluorescent flourishing in there. So we are removing the last part of the supramarginal part of the tumor with using the aspiration. And this is the final view of the operation site. And this is the postoperative first day MRI of the patients. So if you look at the literature, you see we can have almost 100% resection in high-grade gliomas with using the navigation and also the fluorescent microscope together. That means we have a very
good cost effectiveness in terms of the maximal safe resection of the glial tumors. So other part of the hybrid approach is the stereotactic cranial biopsy. If you have a suspected radiology and if the patient's over the 70 years old age, and the patients may have a low Karnofsky score, and you can see the multicentric location or butterfly pathology, and if you have a deep and eloquent areas pathology, and then you can go for the stereotactic cranial biopsy. Nowadays, we are using the robotic stereotactic cranial biopsy instead of the hands-on stereotactic biopsy. And this is the 57 years old female patient. She had a headache and weakness. PET-CT showed no primary lesions. MRI showed that the suspicious multicentric brain lesions, metastatic or glial tumors. And this is the stereotactic biopsy samples confirmed by the administering fluorescent sodium with the operating microscope. When you taking your biopsy with the stereotactic biopsy, and then you can check it under the fluorescent microscope to make sure about the your correct pathological samples. So this is the glioblastoma after the stereotactic biopsy results. The other one is the INOM, intraoperative multimodal neuromonitoring. It requires a strict collaboration with the anesthesiology. We are using the IV anesthesia for saving the amplitudes during the surgery. And also the other important thing is that the temperature of and hemoglobin level of the patients, and you should have a consultant neurologist at least online, not in the operating theater. We can do the motor evocute potentials and somatosensorial evocute potentials at the same times. We record the baseline amplitudes, and then we can see the threshold values. And of course, we can have a false positive or false negative values. So in terms of any problem, you can check the temperature of the patients and hemoglobin level of the patients, and also ask your anesthetist if it's deep anesthesia or not. This is the very short video about the intraoperative neuromonitorization. You can have a technician in your operating theater, and what you need, whenever you need, you can ask from the electrophysiologist to perform the MAP and SEP, and then everything is easy for you. And the other component of the component of the hybrid approach is the multidisciplinary team meeting. And we have a neuro-oncological board in our institute, and we are performing the OECI, ESCO, and NCCN guidelines to discuss our patients, and that means we have the evidence-based decision-making for our patients, and we can have a kind of decisions about the patients across the surgery, biopsy, or the further investigations, or the other kind of new approach to new treatments. So this is the very basic molecular pathology for the glial tumors, and we can divide the IDH wild type or mutant type. And now you know if you have a IDH mutant type, and then you can have a astrocytoma CNS who grade for instead of the glioblastoma. We are calling as a astrocytoma grade 4 nowadays. So this is the 60 years old male patients, and you see this is the surgery, very short video for the surgery. After removing of the glial tumors, and of course we are using the navigation, neuromonitorization, and also the fluorescent microscope during the surgery. And I can do it a little bit faster. This is the fluorescent microscope again. You see the final step of the surgery. And this is the post-operative first day control MRI of the patients. And the pathological result was the IDH wild type, MGMT negative pathology. And this is the postoperative 4 months of the patients, and this is the postoperative 14 months of the patients. You see some recurrence in there, and so on, but neuro-oncological board is about the pseudotumor progression. That's why we did not anything for the patients. So neuro-oncological board is providing the very beneficial for you. We are using the response assessment criteria. This is the RANO criteria, which means we are assessing the tumor size in the T2 weighted and flare sequences. We can see the progression or the patient's needs as steroids. And also the other important thing is the clinical presentation of the patients. We can see the pseudo progression, particularly in early period in MGMT positive patients, but we can see the radiation necrosis at the late periods. We can see the pseudo response, and also we have to assess all kind of clinical presentation with the advanced imaging techniques, which is including the perfusion, MRI, diffusion MRI, spectroscopy, TREM, and PET-CT. This is another example. You see the preoperative MRI, postoperative first day, second months, and 6 months, 7 months, 8 months. You see the tumor progression, but on the other hand, you see the perfusion MRI bottom sides, and you see there is hypoperfusion in there. That means you can assess, you can discuss your patients in the neuro-oncological boards, and then this is the pseudotumor progression, and you should do nothing. And the other advanced imaging technique is the TREM. This is you can easily differentiate the tumor in terms of the necrosis or tumor. If you see the red color, that means the necrosis. If you see the blue, and this means this is the tumor. So basically, in recurrence of the glial tumors, we are using also NCCN guidelines, and in also low grade and the high grades. And what is the difference between the low grade and the high grades? Usually, the stereotactic biopsy is preferable in the low grade recurrent tumors instead of the high grade tumors. So the other technology is the stereotactic radiosurgery. It's an outpatient procedure, treatment time almost within a seconds. You can do it hypofractured. There is no sedation, no restriction for daily life activity. But we are now we have to aware of that the stereotactic radiosurgery plus chemotherapy can cause a myelotoxicity, and also immunotherapy can cause a very severe complications in terms of the CNS hemorrhage, gastrointestinal bleeding, bowel perforation, thrombocytopenia, proteinuria. So seems to lead a high risk of the severe toxicity, and on the other hand, does not seem to change the outcome in terms of overall survival. As a summary, multidisciplinary approach is essential in glial tumor surgery, and you have a strict collaboration with the neuroradiology and also molecular pathology. And treatment and follow-up approaches including the stereotactic biopsy with the tumor board decisions. Maximal safe resection is crucial. Hybrid surgery is very useful to remove this kind of tumors. Radio and chemo, immunotherapy and GS targeted therapies is nowadays very popular. And also the last game changer is this stereotactic radiosurgery for the glial tumors. Thank you very much for your attention.
Okay, thank you. Thank you, Professor, for this exhaustive and beautiful lecture about how to use all kinds of tools and technology in intraaxial tumors, especially high grade. Thank you so much. Are there some questions from the audience? Yeah, just one. Nikolai, please.
You mentioned that was that a technician or a doctor who is doing the intraoperative neuromonitoring is online?
Yeah, online, yes. We have a technician in operating theater, but on the other hand, our consultant neurologist can see our amplitudes during the surgery within his room, yeah. If we have any problem, we can directly call him and then ask please check the amplitudes. If you see any problem, please let us know.
Thank you. Any other question? No questions. Okay. One more?
One more.
One more from where? Okay, sorry.
Sir, thank you for the beautiful topic. I would like to ask one question. Sometimes we see patients with a pseudo progression and significant mass effect. So what do you recommend for that patients?
Sorry, I couldn't understand. If the patient has a very severe mass effect?
Patient has a significant mass effect and that is secondary to pseudo progression, not the recurrent tumor. So what do you recommend for in that case?
You mean that the pseudo progression or radiation necrosis?
Radiation necrosis.
Yes, sometimes we can have a tumor board decision for the radiation necrosis in case of the very severe mass effect of the radiation necrosis. Yes, true.
Okay, thank you. You are on late, so it's time for the next speaker.
Thank you, Dr. Karaman. Our next speaker is Dr. Atha Inam, who will be speaking on the impact of classification on glioma and recent advances. Dr. Atha?
Good. Ji, Assalamu alaikum, good morning, and thanks to Dr. Salman Sharif is not here, is he? Huh? Oh, up there, okay. Thanks to Salman Sharif and the organizers over here for arranging this thing and for inviting me. So, you know, this is not monkey sees, monkey does, okay? This is neurosurgery where you deal with brain tumors. So pay attention because it's a constantly changing field and it's not just going and taking a tumor out. As a good neurosurgeon, you need to understand all the basics and all the things associated with the tumor surgery. So we will talk about that how this molecular pathology, the CNS5 WHO classification has changed the landscape. So the WHO guidelines, you know, before it started, this was back, you know, in the earlier, last century or before that, we would look at autopsy specimens and see this invasive and non-invasive kind of tumors. Non-invasive, invasive kind of tumors and wonder what these mean really. And then it was in 1926 when Bailey and Cushing, they published the first histopathological details of that, which led to two different kind of tumors understanding, and then that led to low-grade glioma and high-grade glioma. And you know, Kernohan and all those things your name was familiar with, that came in there. And then since that 1926, over the last 50 years, from 1979 till up until now, there have been many guidelines for classification of different tumors has happened over the last at least 6 of them. And from the first edition, 1979, which was the first grading of CNS tumors, GBM was not included in it, interestingly. Things have changed, even histochemistry, radiological descriptions have come into play, and multi-layered approach composed of integrated diagnosis, histology, grade, and molecular data. And then finally, we have come to the 5th edition, which is 3 years old now. It talks about complex histopathological and molecular approaches to establish a final pathological diagnosis and grading. So these are the 2 papers, if you guys are interested in understanding a little more about it. So, you know, Cynthia Hawkins and, you know, this group, they are pretty into it.
and Noreen Mushtaq, she works with Cynthia Hawkins regularly on pediatric brain tumors. Stephen Feister we are working with for building up the consortium, and Patrick Wen has been helping us a lot in brain tumor setting things up in different part of the world. So if you look at those, like at the new classification, you will come across that there are a lot of new recognized tumor types that are coming up, and then some names have dropped off. So I'm not going to go into details because I don't have enough time for that. But notice that the ones that we knew very well, astrocytoma, glioblastoma, oligodendroglioma, they are not just as such. And their words, IDH mutant, and the speaker before me mentioned all this thing. So these are the things that you have to understand and remember that. 1p19q was, for example, being used, but then it's become part of the diagnosis. The classifications, few things that have changed. So astrocytoma is now grade 2, 3, and 4, whereas oligo is only grade 2 and 3. Glioblastoma is always grade 4. And the numbers have changed from Roman numericals to Arabic numericals. So that's standard now. So don't use those Roman numericals. The main things that came into this was that there are, as I showed earlier, adult type diffuse gliomas. We are talking about not astrocytoma only, we're talking about astrocytoma IDH mutant, oligodendroglioma IDH mutant, and 1p19q co-deletion. So that's how we are the words you're using. The pediatric type gliomas, the high-grade gliomas, they have also gone a significant reclassification. So this is important to know because your treatment, so when you see a tumor that comes to you, you get an MRI, you don't know what type it is, right? So in most of the cases, it still says the same as a neurosurgeon. You're going to go and resect it, biopsy it, whatever. But then when it comes to the pediatric type tumor, these diffuse high-grade gliomas, you need to think about it, what are the possibilities. So one of the most common one that's coming up is the AS3K27 diffuse midline gliomas. In this case, we don't see the glioma on both sides, but typically they would present on both sides. Typically they present in the pons, and this is what we used to call as pontine glioma in the past. So this is some of the typical pictures that we see in these in this H3K27 altered gliomas. And that is because the AS3K27 is one of those histone protein modifications. So I'm sure you guys know about the epigenetic modification, right? So there are histone modifications, there's methylation, there's acylation, and the microRNA, which is the new thing now, and it is going to actually come up as one of the most important things in epigenetic modification. So remember this H3K27 these are the ones that you can only do a biopsy. You don't want to do more than that. And the treatment for this thing is, again, radiation has some effect, chemotherapy, maybe temozolomide. There are some other biologic agents as EZH2 inhibitors are being used. And then there is another one which is similar to that, but it's on the cerebral hemisphere. That is H3G34 altered gliomas. They lend themselves better for surgical resection. And the third one which is coming up is the CMMRD, which is basically a constitutional mismatch repair deficiency. Now those ones may have other tumors in the body, and you don't want to use temozolomide, but they can be resected safely. So, so these are some of the molecular tests that have come up, and this is becoming a problem in Pakistan, for example. We can't do all these tests. It's only a couple of years ago that the IDH tests and ATRX have started, even though ATRX, maybe Shaukat Khanam does it at AKU, we sometimes do it, sometimes don't. 1p19q is a different test. It's a FISH test. You don't do it like a molecular test. It's not immunohistochemistry. You actually take the chromosomes and you, in a special way, you look at the fluorescence in those chromosomes. So, but then the third promoters and all the others, MEB1, MEBL1, and all those, we are not doing those. So our understanding of the molecular epidemiology landscape in Pakistan is very sketchy because of the lack of these certain tests. Nevertheless, this is a picture which was shown to you in the previous one also. So this is a sort of a practical guideline. So you have a diffuse glioma. Now that's another, I sort of disagree with this term diffuse glioma, which we can talk sometime later. Anyway, if you see a glioma, and the diffuse is the more common gliomas, there is IDH1 wild type, or mutant. Now the mutant, you would think that mutation is gonna cause, make it worse, right? But the mutant, the wild type, the IDH, it has the gene and that protein molecule that actually helps these cells to grow, providing them nourishment. So the mutant type that does not do well in terms of survival, and that's why these are the lower grades. The wild types are the high grades. So if you have wild type IDH1 mutant, wild type IDH1, it automatically becomes glioblastoma. It typically has these features. Now, a long time ago, when I was a resident, we would look at the necrosis, and anything that had a necrosis was no questions asked. That was a GBM, but that's not the case anymore. Things have changed. So it's the IDH1. There is still some issues. So you will find some tumors which have necrosis and microvascular proliferation and things like that. And it's an IDH, not wild type, it's an IDH mutant. So the problem is, in these cases, you would like to go for a molecular testing, and that's an important aspect, because with the molecular testing, you can find that whether it's really the wild type or not, that there are some different subtypes in it, which we call as non-canonical presentations. So you look into that. If you have IDH mutant, in most of the cases, you look at the ATRX, which we don't do so much over here, but then TP53 mutation. And if that's the case, then it's an astrocytoma. If the ATRX is retained, and this definitely confirms that 1p19q co-deletion, and it's expensive, maybe 25,000 or so rupees, but this is worth doing, because then you can clearly categorize. A lot of times you don't see those typical fried egg appearance on histopathology or chicken wire appearance that people talk about. So it's always good to get this 1p19q, because then your treatment for the brain tumor is going to change. So remember that part, okay? And then if there's a confusion, then you do the molecular testing. So the canonical molecular tests that they're critical for defining tumor types is IDH mutation, 1p19q, MGMT promoter methylation, we don't do over here. TERT, not very common. EGFR amplification, we don't do. H3K27, sometimes we do, sometimes we send it out. So these are some of the tests, and it's becoming mind-boggling for a neurosurgeon, because neurosurgeons typically have less brain than other specialties, but still, it's worth trying to remember these things. I'm a neurosurgeon too, so look at these things like FISH and all that thing. The non-canonical molecular tests will include ATRX loss and T53 mutations. So it's a GBM. It typically looks at GBM. You will have a P53 wild type, not much staining. You will have an IDH wild type, which means not staining. So when it stains, this horseradish peroxidase stain, that is usually when it's a mutant type. And ATRX is retained in here. The Ki67 or the MIB index is 30%. So that's no question asked. This is a GBM. Oligodendroglioma, it looks like that. It may be astrocytoma. But then if you see that it's a GFAP positive, that's okay. And there's IDH mutant in there. And the Ki67 is less than 10%. And ATRX is retained. Then it looks more like a oligodendroglioma. And then you want to confirm it with a 1p19q. So a WHO CNS5 classification basically helps or has redirected us in treatment of these tumors. So if you have oligo, IDH mutant, 1p19q, you give our radiation therapy with PCV. I'm going to digress just for 5 seconds. We did the Pakistan brain tumor epidemiological study, and it was very disturbing to find out that about 60% patients, they had surgery and there was no follow-up on those patients, whether they received radiation therapy and chemotherapy. That is a very sad state of affair in Pakistan. We do surgeries and then we let them go. We don't really care about what's happening to those patients. So maybe for some people this doesn't really have any importance, but you do surgery on a patient, you take care of the patient, you follow them up, and you see how they are treated further. So anyway, so oligo is basically a radiation therapy with PCV. PCV is used more in India. We typically use temozolomide, but it's more expensive. PCV has more side effects, but they respond very well. So again, I'm not going to go into details, but just to let you know that you take it to tumor boards and you discuss things with histopathologists and medical oncologists. This is just too much information for you to retain. So the clinical implications of 321 edition, basically it has given us a molecular data But then the issues are that the integration, especially affects the classification of adult type and pediatric type, so we need to understand that. The problem is that that the diagnosis that we made in the past so many years, we based our treatment based on that diagnosis, and that has changed. So the landscape has changed. So you were targeting in a certain way, looking at a certain target, and the landscape changes. Now that's not going to work. So you have to readjust. So so that's what the problem is, that the most evidence on the adjuvant treatment of gliomas was generated in the clinical trials conducted when traditional histological criteria were the basis of enrollment. So that you need to be aware of. And then the other problem with this is that this is we published recently that the challenges in implementing this classification in LMIC like Pakistan. We looked at all these tumors, and there was a problem because we can't do those tests. And if we do apply those tests in our lab, then there was a significant change in the diagnosis. So we might be treating tumors wrong, and so that's another problem, and that's something that we need to look at. Patrick Wen sort of echoes the similar things that we can't just like quickly change things and address them right away. So anyway, from a century ago, from 1926, we went to all these classifications and then molecular data, but now the things are changing into metallomics. So as I mentioned to you, epigenetic changes, one of the methylation of those promoters is a very important aspect, and metallomics. So I predict that metallomics is going to be the main classification in the next decade. This IDH and all those things are going to go away. So we are working with Stephen Feister, building up the consortium on metallomics across the world, to and getting some data from different parts of the world. So this is going to be new classification. The other thing is, we are not complete in this classification. Fifth classification is not good. Because, for example, this is something that I proposed, a novel classification of low-grade glioma. In the CLS5 classification, all are treated as one. But that's not true. I mean, each one of you as neurosurgeon, as a trainee or as an attending, have seen this thing, that the low-grade gliomas can be circumscribed and can be very infiltrative. So we put forth this classification of CLGG and ILGG. The interesting thing is that not only is the post-operative drop in KPS is different in these two. So orange is the infiltrative and blue is the circumscribed. The survival curve is different. And most interesting, the microRNA analysis that we are doing on all our brain tumors, as I said, microRNA is going to be one of the most important epigenetic factor in future. We find that there's a significant difference in the microRNA. So this 29B and 21.3P, so few microRNAs, there's a significant difference. That means these are different tumors, and we are lumping them together, just like we were lumping tumors together 30, 40 years ago. We are still lumping tumors together. The problem is this paper is coming from Pakistan, so no one is paying so much attention, although I'm talking about it, because, again, if it comes from North America, Gora land, with Gora accent, then it automatically gets attention. That's the sad thing about this state of affair in neurosurgery. Is heavily biased. Anyway, so this is an important aspect, CLGG and ILGG. So remember that, how molecular, and then, so circumscribed lower grade gliomas and infiltrating lower grade gliomas are radiologically distinct groups with separate prognosis, surgical experience, and associations. And now, since this is a little difficult to distinguish, so what we are running is we are working on the AI-based algorithms and training them. So undergoing machine learning for classification of these lower grade gliomas based on their 3D shape, and we have had some excellent results on that one. So anyway, so to conclude, number one, their multi-layered approach has come in. Molecular information is important. Role of surgery has not changed a whole lot. The biopsy and maximum safe resection still stays the same, mainstay, but in some cases you have to think about only a biopsy, just like I mentioned in H3K27 ones, right? The midline gliomas, which you will see on the MRI. The treatments, based on outdated histological criteria, so clinical trials are also based on those, so that needs to be relooked again, and the problem is resource constraints. So LMICs and all those places are not so good in that. So one thing is that WHO CNS 5 remains a work in progress, needing refining therapies and diagnostics to align with molecular classifications while addressing global inequalities. You know, it's very difficult for me to read. A lot of people just read the slides, I can't. Anyway, so thank you very much, and I'm open to questions through email or through other sources. Thank you.
Thank you. Thank you so much. It's a nice presentation. A question from the audience.
Assalamu alaikum, sir. Wonderful talk. Sir, one small question, or might be a practicality question. Our usual practice is to resect tumors, follow the patients for the biopsy, and then when it comes out to be in case oligodendroglioma or grade 2, then refer them to our radiation or something like you just mentioned in the slide. If it comes out to be oligodendroglioma, refer them through radiation therapy. Why not? Can this be a practice that we take biopsy instead of doing surgery in the first place? If it comes out to be oligodendroglioma, then don't do surgery at all. Refer them to radiation direct straight away.
So you know, if you look at, there are different ways of looking of dealing with it. I mean, Ugi Dufau, right? Have you listened to Ugi Dufau's lectures? He does not like radiation at all. So if it's an oligo grade 2, and if you have done a good resection, then you don't need any chemotherapy or radiation therapy. So if it is an oligo grade 2, but it was very infiltrative, you resect as much as you can, you seem to have a little difference in the response to radiation chemotherapy. So maximum safe resection is still the mainstay in even low grade or high grade. When it comes to their molecular diagnosis, then you decide whether you want to do temozolomide and other things or not, and what is the dose of radiation that you're going to give. Because for grade 4 versus grade 2 and 3, the data is coming out at different grades of radiation. So that comes out later. But then if there's none left in the post-op MRI, which should be done within 72 hours, then there's no need to do those adjuvant treatment. Does that answer your question?
Yes.
Okay, thank you.
Thank you.
Thank you.
All right. Thank you.
Is there another one or no? Okay, it's time to go ahead. Can we continue?
Yes.
Okay.
Thank you, Dr. Athaynam. Our next speaker is Dr. Abuzer Gurgur from Turkey, who is going to speak about supracerebral approaches.
I would like to thank Salman Chef and all organizing committee to invite us. I am happy to be here. And I will talk about the supracerebral approach and its valence. I have nothing to declare, but I have a big team behind me. And the data which I will use coming from Wotan collection, the studies which we made in Wotan Lab and Neurosurgical Atlas, and our publications. And we keep publishing articles about the supracerebral approach, and videos are from our cases. I am lucky because I learned the anatomy from Professor Wotan, and the approach, the surgical approach from the Professor Ture, who is expert in this area, because I feel very lucky about that. When we talk about the supracerebral approach, there is variant like a median, paramedian lateral and extreme lateral, and also supracerebral transtentoral approach. When we go laterally, you have a long way to the midline structures, but you will have a direct view to the midline structures because of the cerebellum vermis. And we use perimedian or paramedian craniotomies, not midline craniotomies in this approach, because if you use the midline craniotomies, you must use midline approach, and Vermeer bridging veins must be sacrificed. Because of this, we use the paramedian or paramedian approach. And we are looking from the superior. You can reach most of the structures upper above the tentorium and below the tentorium with this approach. And mostly this approach performing to the pineal gland. Also, you can reach these midline structures with posterior interhemispheric approach, but in posterior interhemispheric approach, you must retract the occipital lobe, and you can have visual deficits. Also, subtemporal approach is an alternative to the supracerebellar approach, but also you need retraction of the temporal lobe, and also you can experience with the visual deficits. Which structures you can reach where the supracerebellar approach to the superior surface of the cerebellum, and midline structures like pineal and brainstem structures, the superior collicle, inferior collicle, trochlear nerve, and also we just published the trochlear nerve schwannomas, which we approach the supracerebellar approach. But below these structures, it is better to use a lateral approach because of the awareness, and also you can reach the brainstem and third ventricle via the pineal approach, and tentorium, tentorial meningiomas, and the thalamus, especially pulvinar part, and the branch of the P2, and mesial temporal lobe structures. And these are the structures we can reach where supracerebellar approach, thalamus, brainstem, superior surface of the cerebellum, and mesial temporal lobe structures. And also you can reach the vascular pathologies related with the P2 and Galen venous system. And when you open the tentorium, you will reach the supratentorial structures like P2 branch, mesial temporal structures, and sometimes you need a temporal cut to reach the thalamus. We are looking from the superiorly, and this is tentorium, hippocampus. If you want to reach the mesial temporal structures like hippocampus and the P2 branch, you must cut the tentorium. And also, you can reach the middle fossa structures with a supracerebellar approach. And when we open, we always face with the bridging veins. And also, we did a study about the locations. And when you go laterally, as you see, you have a direct weave to the midline structures, and also a lower part of the brainstem. And this is the main weave which will reach the in midline structures. Also, you can combine with the retrosigmoid approach to for example, like epidermoid tumors or chordomas, you can combine supracerebellar approach with retrosigmoid approach. And these are the structures which you can reach with this combination. And also, this is Galen venous system and the branch of the P2. And when you go laterally, you can have a direct weave to the midline structures and like pineal and the third ventricle. And when you open the tentorium, you can reach the supratentorial structures. This is the parahippocampal gyrus and P2 branch. And endoscope always help you in this kind of approach. As you see, we are going supracerebral, and this is pineal. And with suprapineal approach, we are going to third ventricle, massa intermedia, and foramen magnus located superiorly. As you see, anterior commissure. And also at the end of this presentation, I will show a case which I show. Also, position is important in this kind of approach. Which kind of position you can reach: prone, sitting, semi-sitting, and lateral position. As you know, in sitting position, there is a risk of venous embolism. This is the prone position. You can use a Concord position, and semi-sitting position, but you have a risk of venous embolism. You must have a good anesthesiology team. And also, we just described a position, a dynamic lateral semi-sitting position. We can change the angle of the table during the operation to avoid venous embolism. As you see, we start in this angle, then change the table angle during the operation to gain a sitting position. As you see, if there's a problem, we can lower the table angle and continue to operation. And also, this is the semi-lateral semi-sitting position. You can use. This is one of my last case to which we performed the brainstem glioma. And you must know preoperatively all venous variations, as you see now, and also bridging venous anatomy. It is important to preserve all these kind of veins. And these are the structures you can reach via supracerebellar approach or tentorial surface and supratentorial surface, brainstem, and midline structures like pineal and the third ventricle. And recently, we described a technique to preserve bridging veins with Professor Ture. As you see, we cut the tentorium and release the vein and can continue the operation. This is from laboratory. This is the bridging veins. We cut the tentorium with preserving its drainage and continue the operation. This is one of my cases. This is the bridging veins. And we must protect it and cut the tentorium. You must be careful to protect the supracerebellar structures like the occipital lobe. But after cutting the tentorium, it will be released and you can continue your operation without damaging any veins. Because of this, it is important to know all venous and arterial structures before the operations. Also, Professor Sabino will talk about these technologies. And I will show some cases which we did and the 3D anatomy. Our craniotomy, paramedian craniotomy, and the structures which we can reach via the supracerebellar approach, the hippocampal gyrus, and the midline structures, pineal and brainstem structures, and also the thalamus, and also you can reach the contralateral approach. As you see, when you go laterally, you can have a direct access to the midline structures. I will show some cases, a thalamic cavernous malformation with this dynamic lateral position. After opening the craniotomy, we perform a small incision to release CSF from cisterna magna and dissect the bridging veins from the tentorial and the cerebellar surface. And with the help of neuronavigation, we reach the pathology and remove without damaging any structures. This is the postoperative view and postoperative vein. This is the postoperative MRI. And also midbrain pathologies you can reach. This is the cavernous malformation. Dissecting the cerebellar bridging veins. And after describing the anatomy, we can reach the malformation via translateral mesencephalic sulcus. And this is the postoperative view. And also, most of these approaches performed to reach the pineal region. As you see, you can have a direct access when you go laterally and can remove the tumors. And also P2 aneurysm, you can reach this area. As you see, you can put clips after proximal contour, and also temporal meningiomas, especially T2 meningiomas. This is the preoperative, and also I only want to show the postoperative view. This is the postoperative view. And also you can reach the third ventricle via this approach. After removing the pineal tumor, we put an endoscope. The patient has already had a shunt, and this is the both foramen Monro. We are looking from the posterior. And we will look to the lateral ventricle, as you see, and the shunt catheter. And also our laboratory, we are doing these kind of 3D models. You can reach via Neurosurgical Atlas and our website, all these structures. And you are welcome to come our laboratory in Yeditepe University. And I want to thank all my friends. And we are waiting you to Meningioma Society meeting in May 8 and 11. And all, again, I want to thank all organization committee. I had a wonderful experience in Karachi. Thank you.
Thank you for this beautiful presentation to Professor Gungur. Any questions from the audience? Okay. Good videos, especially the last one.
Excuse me, sir. Excuse me. I have one question.
Yeah.
You have mentioned in one of your slide, it was a mid-brain cavernoma, and you approached through why the lateral mesencephalic approach. What craniotomy and which approach you use for such lesions? For mid-brain cavernoma.
Brain cavernomas.
And it was approached by a lateral mesencephalic approach. So what is the craniotomy and approach you use?
I use paramedian craniotomy, and supracerebellar approach. Yes. Oh, I didn't understand the.
It was a case of lateral. It was in one of your case. You mentioned the midbrain cavernoma, and yes, you said that it was approached via the lateral mesencephalic corridor. So, what was the craniotomy, and what was the approach how you approached this?
I prefer to use supracerebellar approach, but I think there's no approach you can reach this kind of lesions because it is lower for the subtemporal and posterior interhemispheric approach. I think this is the only way to reach this kind of lesions. Supracerebellar approach with paramedian craniotomy.
Any other questions?
Yeah. For a lesion in the mesial temporal lobe or near the parahippocampal gyrus, would you prefer the supracerebellar approach over transsylvian approach? Because we recently experienced a patient, he had a lesion in the mesial temporal
If
lobe.
the lesion locates the anterior part of the mesial temporal lobe, I can prefer the Transylvian one. But if it is located to mid or posterior part of the mesial temporal lobe, I prefer to reach with a supracerebellar approach.
If that lesion is just abutting the brainstem almost, so would the supracerebellar approach be helpful in that? Or would the Transylvian be safer for the same lesion if it is extending almost to the midbrain?
Because I prefer supracerebellar approach because with supracerebellar approach you can preserve the optic radiation. Because in Transylvian approach, you will have a risk of visual deficits. But with supracerebellar approach, you can preserve all optic radiation.
Any other questions? Okay. We'll proceed with our next talk, which will be given by Dr. Sabino Lussi, and his topic is Interoperative Augmented Reality Fiber Tractography Pearls.
No other questions because we need just 1 minute to fix the problem of the computer. I'm joking. Okay. Okay, it should be okay now. Okay. Thank you. Perfect. So, thank you so much. And the first thing that I want to say is a big thank you to my best friend, Professor Salman. Thank you so much. To Professor Zileli also. And just a consideration about World Federation of Neurosurgery. I see now in front of me lots of old but also new good friends. So it means that World Federation of Neurosurgery and neurosurgery put people together. And I'm very happy about this. Yesterday we had a beautiful night all together. And thank you so much for this beautiful, beautiful opportunity to all of you. Thank you. I want to start before my lecture to say thank you once again also for my mentors. With the first guy on the left side, I spent almost just a little bit less than 16, 17 last year. And my training in microneurosurgery, I had lots of beautiful person that I have to thank you. And this is a picture I briefly went when I was in Brazil with Professor de Oliveira that passed away a few years ago. And this man changed the life of everyone. And this man also, I'm staying in contact with this man every day, every week, because he's a mentor for me and for Professor Gungor also. And this is another giant that totally changed my life when I was there in Professor Al-Mefti's skull-based lab. I learned so much from him, especially for technique of skull-based surgery. And when I was very, it was 1 year ago, I spent lots of time here in this beautiful lab, and Professor Gungor is the director still now of the lab, and my advice for young neurosurgeons is to go there and to do what I did in this lab and to learn the basics of neurosurgery, microneurosurgery, and especially brain anatomy. And I have the opportunity to see also Professor Ture working. That was amazing and shocking for me to see his surgery, positive way I mean, because he's very, very truly master. And I also had the opportunity to see for the first time in my life the true microscope of Professor Yashargi that is still there. And Professor Ture always, every day, use this kind of microscope in his routine surgery. And this is beautiful family. And this is my second family, my second home. And I go back and forth from Istanbul because, as I told you already, microneurosurgery brings people and put people all together. Thank you so much. It's time to go ahead, and the topic of my lecture for today is how to use the intraoperative augmented reality fiber tractography in my routine practice. When we talk about the augmented reality, we talk about something that today we use every day. But there are lots of confusion in terms of augmented reality, mixed reality, virtual reality, whatever you want, but they're totally different aspects, because augmented reality is just for the most tangible, probably, part of the so-called extended reality. You don't need any visor, you don't need anything. It's just a technique that is able to enhance what you see and what you touch in your surgical field. So it is very easy to use. And lots of people started to use in the past. It's not a novelty. Augmented reality in brain tumor surgery. Augmented reality is not only about DTI, that is one of the topics that I am going to talk about, but it's also fluorescein, the tracer, beautiful videos that my colleagues show it to you in the very early morning, ICGs, another form of the augmented reality, everything enhanced. Something that is in the surgical field can be considered augmented reality. I will focus on a specific aspect, that is how to use DTI, fiber tractography, in my practice. DTI can be used in 3 different aspects. The first one is the planning, execution, and also postoperative assessment of residual connectivity. Planning, it's not a novelty. Even in neurosurgery, we use DTI for planning since from 10 years or probably more, to choose our best trajectory to our target. And this is one of the most recent articles that I published, where I show it here how to use intraoperative, how to use preoperative augmented reality, because based upon the level of displacement, and I will show you some video of the corticospinal tract, I will choose when I want to go from transprecentral sulcus, direct transgyral, or transpost-central sulcus approach, depending of what tumor, how the tumor affects the corticospinal tract. And very important, because we always have to keep in mind that decisions are more important than incision, but also we can use DTI for execution of surgery. Until a few years ago, it was a sort of futuristic, toy, a sort of something that was not tangible. But now, today, we have level 2 clinical, trials that already showed how to use augmented reality and how this, technique can affect and can impact in a positive way the extent of resection and also the progression-free survivals, as I will show you, of these tumors. And DTI can be used also for postoperative assessment of residual connectivity, because we have to be critical of how invasive was our surgery. This is the setup in the OR. This is my old OR. Now I moved to another hospital, and this is the surgical workflow of the augmented reality. We just have, some monitors, and the images of DTI are injected directly into the microscope eyepiece. This is a critical point. You can use augmented reality while you're watching your surgical field and while you have everything under control. And this is just an example where or how you can use augmented reality from the beginning of your surgery. Okay, nobody needs this kind of technique just to target your craniotomy, but for young people, it can be useful sometimes to project, your tumor and to affect and to check intraoperative where you are and where the tumor is. And this very good way also to develop what Professor Rotten called the see-through X-ray vision about, to choose your best way and your best approach to the target. But I want to show you some of my cases, sample cases that I also published. This is a huge post-central gyrus glioma here. And these are the relationship, as you see, with corticospinal tract, that is not so difficult sometimes to endanger the corticospinal tract. So I used the augmented reality for this tumor, just for the beginning, to see the tumor where it was, and it is a superimposition in the color shape of the augmented reality. Like you can see the relationship between the tumor, especially in the depth of the tumor and the corticospinal tract. And for sure, this is another form, as I told you, of the augmented reality, that is ICG, that is here, fluorescein. And I always like to use ICG in the pre-op and post-op to check the residual patency of the flow into the bridging vein after my surgery, because I want to be as much conservative as possible. As you see here, augmented reality and intraoperative DTI is a technique that can be used not only on the surface, but even in the depth, because according to the adjustment of the focus, you have, deeper visualization of the corticospinal tract. Apart from this and apart from technology, the basic principles of brain tumor surgeries are always the same: transsulcal, transcisternal approach, because I want to stress this concept for especially young people. The invasiveness of any approach is not just in the size of skin incision on the craniotomy. The concept of the invasiveness of the approach lies in how you are respectful of the anatomy. That is the main concept. So no way for this kind of tumor, this is my humble opinion, for keyhole, minimal invasive. You have to be sometimes maximal invasive on the bone, but minimal invasive of the brain. And the only way to learn this is to go to the lab and to learn anatomy. And also, sometimes when I send my first paper to the journals, they replied to me, okay, this is a good technique, but it's difficult to use in the depth, okay? For example, in this case of insular glioma. This is the proof that it is not true. This is a video showing you an insular glioma here, and I use the augmented reality here also to track, front-occipital fasciculus and in the depth of corticospinal tract. Another special, note, I want to stress the concept I never use for just a single insular glioma transopercular approach, because insular glioma is a paralimbic tumor, so you don't need to violate neocortex, you don't need to remove healthy brain to go there, absolutely. And another, my humble concept, you don't need awake surgery for this kind of tumor, because you have, to choose the right position, and this is just terminal transcavian approach. You have just to master this kind of view. And as I told you, I always like to use augmented reality in terms of ICG, fluorescent, whatever you want, to maximize the extension of my resection of the tumor, and this is the the early post-op assessment. But after starting to use this technique, we just did some cases, and after 1 year, I asked to myself, but can augmented reality can take advantages in terms of maximal safe of extent of resection of brain tumors? And we focus on the lines, and we were the first group probably to publish the first series of augmented reality and the clinical implication of the augmented reality in brain tumor surgery. We started to focus and make the point about the supratentorial tumors, especially here. And we use, I was the first one, along with my mentor, start to use this kind of technique in every kind of tumor, frontal, center, parietal, wherever you want. And I found better post-operative nanoscore, but just a little bit better, a greater extent of resection, and better progression-free survival. For sure, this technique is not able to affect the natural history that is very dismal of these tumors, but maybe because of a better understanding and the orientation of the corticospinal tract and the other fiber tracts, we can be more effective in terms of extent of resection. More recently, I put the accent especially of the M1 tumor. As you see here, this is a small tumor, but this is very challenging, because when you perform this reconstruction, 3D reconstruction of the surface, we can see that this tumor totally split the corticospinal tract in 2 halves. Was anterior and posterior, so this is a perfect case for direct transgyral approach, because I want to be minimal invasive, as less invasive as possible for this very critical and challenging tumor. And this is another video here when I show you, this is exactly at the level of the motor strip, zone 2 of Magil, as they say. And this is a tumor that is, despite the fact that it is small, there's close relationship to the SLF1 and 2 and corticospinal tract. And okay, I just finished and I don't want to take too much time. This is the last video. Okay, here, and as I told you, this is the shot before surgery. just to check the patency of the vein before surgery, and for sure this technique has another advantage. You can combine this technique, especially with this kind of tumor, with neuromonitoring. As I show you here, at the level of the surface, you can use monopolar, bipolar, whatever you want, cortical strip, whatever you want. And this is a mixture of different forms of augmented reality, ICG, fluorescein, 5LA. You can use also augmented reality in awake surgery patient, but you know, a transsulcal, transcisternal approach, you can do everything with just 1 centimeter, 2 centimeter, or transsulcal. This is before and after ICG. And this is a critical assessment of postoperative residual connectivity in this kind of tumor. And we publish also the results of the use of the intraoperative augmented reality for primary brain tumors, primary motor strip tumor. We compared 34 patients in the intraoperative augmented reality fiber tractography versus 31, and I found lesser intraoperative seizure here because we use neuromonitoring in all the patients, a better 3-month post-op nanoscore and a better motor score, and also, once again, just a little bit better progression-free survival, this kind of technique that validate our routinely use in our practice. What about the future of microneurosurgery? The future of microneurosurgery is super bright, super bright. And another important reason for this is the implementation of technology. Now this is no more futuristic place. We are already working on this kind of project. This is a clinical application of 7 Tesla MRI. This is what they call ultra-sharp DTI. And we are starting to introduce this kind of DTI in our clinical and routine practice. And with this kind of DTI, we have to know very well the anatomy, and we have to, we have to do before approach surgery, we have to do better anatomies before to go there. So my advice to all young people, once again, is to go to the lab because we have to be ready for this. Thank you so much for your attention.
Sabino, any questions from our audience? I couldn't see.
Professor, I have a question. It was a wonderful presentation.
I don't see. Where is?
Here I am.
Oh,
sorry. Can you raise up?
Yeah.
Sorry. I lost because too much light here. Sorry. Yeah.
It was a wonderful presentation, and I want to ask, what's your experience about the anterior skull-based tumors like giant pituitary adenomas, craniopharyngiomas, which we have to go for transcranially because they are mostly invading hypothalamus, and mostly we have to leave a sort of tumor to avoid hypothalamus, and we don't know actually when we are operating where we have to stop a resection. So I think this DTI can help us to locating or relocating our anatomy. Have you any experience of that?
Okay, your question is about the use of DTI. Okay, let me tell you that, when you talk about skull-based tumors, you talk about extraaxial tumors. When you talk about extraaxial tumor, my personal and humble idea is the fact that you can use augmented reality to go there, ICG in the endoscope and everything. But DTI has a limited role for meningiomas, because to be honest, I don't have experience. For me, it makes no sense to use, intraoperative DTI, at least this form of augmented reality for extraaxial tumors. You can use different form of augmented reality. I repeat, ICG, not 5LA, but fluorescein, because sometimes they use fluorescein shot even for vascular neurosurgery. You can use every kind, but not for extraaxial tumors. You just can use this kind of technique to plan your craniotomy, but I do believe that it has no role. Neurovascular surgery is a different story. Sometimes you can use, when you talk about, for example, cavernoma surgery is brain surgery. So you can use
the intraoperative DTI to plan your corridor in cavernoma surgery. Yeah, for cavernoma surgery, I did lots of cases there. But this is my humble opinion. For extraaxial tumors, it makes no sense. It's better to know your approach and to study your corridor. Yeah, this is what this is my humble, personal point of view, but nobody, probably in the future, it could have a role. Okay, thank you.
Thank you, Dr. Luzzi, for that wonderful talk. Also, thank you, Dr. Gungar, for moderating this session. We move on to our next session that will be moderated by Dr. Okay, we'll take a coffee break first and then we'll move on. Thank you. We'll see you in 15 minutes.
Professor Pascal is one of my best friends. So you are in Wisconsin now? You did your fellowship there. Okay. I saw him. Webinar now. I arranged this week with the Steve was from Roma, so a few days ago. I love him. He's one of my best friends. One of my heroes.
यहीं से बताओ 188 ऑफलाइन पे आ रहा है नहीं बताना ऑडिटोरियम है ना हाँ हो गया कनेक्ट हो गया नहीं कनेक्ट हो गया पासवर्ड नहीं आ रहा है हाँ बता रहा 1880 105 229 प्रेजेंटेशन खोल दी मैंने अगली वाली स्लाइड शो करें हाँ नहीं सही है
ये प्रेजेंटेशन इसी सेशन में है अब जो से स्टार्ट हो रहा है तो वाली है आपके पास दिमाग में शायद सेंड की है
नहीं सर अभी तक नहीं आई
और दूसरा ये कि पॉइंटर और वो स्लाइड को आगे भी ये पॉइंटर
ये स्लाइड चेंज
स्लाइड
यहाँ से नेक्स्ट होगा ये देखो
यहाँ से पीछे होगा ये नीचे वाले से नेक्स्ट होगा पॉइंटर ये
जी ये
प्रेजेंटेशन पूरी करवा दीजिएगा मैं
ये वहाँ मालूम कर लें यहाँ तो नहीं पहुँचे
Thank you everyone for joining us. I would request all the people to take their seats. Moving on to our next session, that will be moderated by Dr. Tariq Khan and Dr. Ahmed Ali Shah. I would request both doctors to please join us on the stage. Our first speaker is Dr. Kashif Sultan from Pakistan, who's going to speak on the topic of horizons of advanced monitoring in management of severe TBI. Dr. Kashif.
Bismillah ar-Rahman ar-Rahim. Salatu wassalamu alayka ya Rasulullah. Dear colleagues, my distinguished seniors, especially Professor Salman Sharif, for this wonderful WFNS course and conference, and giving me the opportunity to talk about the most neglected area of the neurosurgery, which definitely is the head injury. We are moving towards the new horizons of advanced neuromonitoring in management of severe traumatic brain injury. It's a revolutionary era of STBI management, which has been neglected for long. I think we must move swiftly from the basics of the head injury, as we all are well aware about it, about the traumatic brain injury, and the Monroe-Kelly doctrine, and the pathophysiology of intracranial pressure, significance of the intracranial pressure. As we all know about the normal ICP, that's 5 to 15 millimeter of mercury, and currently it's decided and there's a consensus that we need to start the treatment of the raised ICP above 22, which was previously 20. But still the normal range is 15. So what are the causes of the raised ICP? As we are all well aware about it, we need to move forward to have some more time to discuss the advanced management. Okay, let's talk a bit about the management of TBI. The only highlighted area is the last one, which is advanced cerebral monitored therapy, and the all other written above are which we are all doing in our units on regular basis. The prophylactic hypothermia and hyperosmolar therapy, CSF drainage, ventilation therapies, anesthesia, and steroids, which are not being used now, nutrition, infection prophylaxis, DVT prophylaxis, and the seizure prophylaxis, decompressive craniotomies, and all surgical options which we all know about them. Let's move to the advanced cerebral monitoring. What the advanced era is now doing. Advanced cerebral monitoring includes ICP monitoring, cerebral compliance monitoring, cerebral oxygen monitoring, cerebral temperature monitoring, and the last one is the cerebral microdialysis. If we closely look at this slide, the first 4 are related to directly or indirectly to the cerebral perfusion pressure. If we monitor the brain, the traumatic brain, with all the above 4 gadgets, we can manage the perfusion pressure. And the last one, which is recently been added to the armamentarium of the STBI management, is the cerebral microdialysis, which basically helps in understanding the brain chemistry. So if we want to manage the state of art, the traumatic brain injury, so we need to have a good control on the cerebral perfusion pressure, and we must know about the brain chemistry. I think we had previously talked in the PSN sessions and in different workshops about the ICP monitoring and cerebral compliance and brain PTBO and maybe the brain temperature, yes, but we need to move forward towards the cerebral microdialysis. In today's talk, we'll discuss the different aspects and importance of the brain chemistry. What happens to the brain chemistry when the brain is injured? And we'll come to know that only maintaining the perfusion pressure is not enough. We need to know about the brain chemistry as well. If we don't, then our management is not up to the mark. There was a very precious study which was called as the TRIP trial, done by the Randall Chestnut. And Randall, in 2014, I think, he recommended that ICP monitoring is almost of no use. So all the trauma people were scared that what will happen now. But then another recommendation came from Randall that we didn't mean that it's not important. We mean that only ICP monitoring is not enough. So we need to use all other gadgets. We need to know about the compliance as well. We need to know about the PTBO as well and the brain chemistry. If we do have all the armamentariums in hand, then we can help the STBI patient. How is it placed? It's very simple. We can deploy it stereotactically. We can deploy directly the catheter. We can deploy it with the neuronavigation in the perilesional area. And then after the catheter placement, perfusion is done, and then sampling, and then simply monitoring. We place the catheter in perilesional area with intraoperative CT or the navigation-based. Here you can see the white pump, and the white color, the yellow one is the ICP monitoring catheter, and the white one is the cerebral microdialysis catheter, which is attached to the perfusion pump. This is the monitor, and here you can see the monitoring of glucose, lactate, and lactate to pyruvate ratio as well. Okay. CMD analysis is how it's done. It's let's move forward because it's a long topic itself, that how it happens. We started with ICP monitoring in 2014 at Allama Iqbal Medical College, Jinnah Hospital, Lahore. And in 2020, we added up with the brain chemistry analysis as well. So we started with the ICP, then in 16, we added compliance monitoring, then PTBO and temperature in 18. And in 2020, we started the local chemistry. So currently, we have done 90 patients with all the gadgets, and we do have 1,400 something samples, which we shared in the last CMD symposium in University of Cambridge. And we have launched an online portal at the University of Cambridge in this regard. So anyone who is doing the CMD, they can share their samples of brain chemistry on that online registry at the University of Cambridge. So method of placement, I have already discussed it. Let's move. This is our data, a short slide about the data. No time to discuss them. So let's discuss the key benefits of CMD. Why do we do it? Early detection of secondary brain injury, even earlier than the raised ICP. So once ICP is raised, deterioration in secondary brain injury starts. So early detection, treatment guidance, monitored treatment efficacy, and avoiding cerebral leukopenia, and the prognostic information, and identifying the seizure activity. Let's discuss two of them. Okay, there's a case. A middle-aged man starts deteriorating neurologically with mildly raised ICP and borderline compliance. A 45-year-old diabetic presented with road accident. GCS was 9, pupils were bilaterally equal and reactive. Initial CT shows diffuse brain injury with generalized brain edema. He was hemodynamically stable, MAP was around 80, blood sugar was 270 milligram per deciliter. Initial ICP was 21, which dropped to 14 after just a mannitol infusion and head elevation. First lactate value was 2.7 millimole per liter, and glucose was 2.4 millimole. On the day 1, ICP fluctuated between 14 to 24, and cerebral glucose and lactate remained around normal ranges. GCS improved from 9 to 10 after 24 hours. Then it started deteriorating on day 2 and dropped to 7. What was the cause of this deterioration? So I will repeat. ICP was okay, MAP was good, and patient was having a normal lactate, was having a normal pyruvate, lactate to pyruvate ratio was fine, everything was okay. Electrolytes were monitored, they were fine, and a repeat scan was also normal. What are the two probable causes? Okay, to save the time, number 1, there must be something with the glucose, the cerebral glucose. And number 2, the subclinical seizures. So what do you do with the subclinical seizures? We need to place the invasive electrodes of EEG to detect them, or we do have something in hand with the brain chemistry. So these are the two probable causes, the glucopenia, the cerebral glucopenia, and the second one is the subclinical seizures. So now we have cerebral glucose was 0.78 and the glutamate was normal. So what happened to this patient? This patient was a diabetic patient, and as we all know that after trauma, when a patient enters into the ICU, in a surgical ICU, any surgeon, not only the neurosurgeons, any surgeon will give the first direction to the residents is have a good optimal blood sugar control because it's a trauma. What happened to this patient? He was having 270 milligram per deciliter blood sugar, and then optimal control was done and the glucose dropped to 100 milligram per deciliter. But as we all know, after a traumatic brain injury, what happens to brain? Brain enters into a hypermetabolic state. When brain enters into the hypermetabolic state, the glucose use significantly increases. And having a lower glucose levels, even which look normal, 100 or 120, but for brain, that's not fine. So we need to keep the blood sugar a bit high. So as peripheral glucose was in normal range, 100 milligram, but the cerebral glucose dropped to 0.78. So what we did, we just started increasing the glucose levels and we kept it around 160 milligram per deciliter. And the cerebral glucose improved. The CMD showed that glucose is now at 2 millimole level, and then patient starts improving. Why I ruled out the subclinical seizures? Because the glutamate was in the normal range. Always remember that when we do have a head injury patient in the ICU, these two things must be monitored. The subclinical seizures, we never know. A repeated scan is okay, no seizures detected, but patient starts deteriorating with everything is normal. These are the two probable causes, and both of them need a good cerebral chemistry analysis. So if there is a higher glutamate levels and every other thing is normal, I usually start the anti-epileptics with a higher glutamate, because as we all know that glutamate is the excitatory for the brain, and the GABA is the inhibitory. So when glutamate is high, there is a probable this may be a probable cause in generating the seizures or even the subclinical seizures. So glutamate in this patient was normal, and the only thing which we saw was the glucopenia, the cerebral glucopenia, which was managed and patient started improving. So strict control of blood sugar is mostly opted in trauma, and which was done in this patient. And subclinical seizures. We always use anti-epileptics when there is a higher glutamate values. Glutamate is excitatory and GABA is inhibitory in this scenario. So goals of monitored management of STBIs, ICP, directed therapy, maintain the CPP, which we didn't talk today, and the cerebral glucose monitoring to avoid the cerebral glucopenia, seizure control by predicting the seizure activity pre-handedly. If glutamate is high, start the anti-epileptics, and cerebral oxygen optimization. These are the three important things. Cerebral perfusion pressure, number 2, the brain chemistry, and number 3 is the PTBO. So take-home messages: when central nervous system is insufficiently monitored, it leads to the grave consequences. Thank you so much. I'm here for any question. And thank you so much. And I must appreciate two personalities, Professor Naveed Ashraf and Professor Tariq Khan, and I'm lucky enough that he's sitting here. He's the man behind the trauma, and he's the man behind the advancement in trauma here in Pakistan. And I must be thankful to Professor Asif Bashir, who is really working a lot in Punjab Institute of Neurosciences to establish a good and at most advanced trauma unit there. Thank you so much.
No question. Thank you.
Thank you, Dr. Kashif. Our next speaker is Dr. Sabina Luzzi, who will be speaking on the topic of strategic approaches to trigeminal schwannomas, anatomic and volumetric corridors.
Okay, thank you. Thank you so much once again to everyone, and it is my personal honor because this is my first Congress, maybe when I can share my new affiliation. I come from this place, I was born in the south of Italy, but now I just moved to this beautiful island. We were talking about yesterday with Professor Costa about this place that is very astonishing. And I come from this place. This is in Sardinia, Italy. It's an island. I risk to be isolated, but I want to be isolated there because it's a good place. And this is my new university, University of Sassari. University of Sassari is very nice. It's one of the most ancient in Italy. And it's a university of 600 and half. And this is a huge list of facilities that we have in that university, especially for young neurosurgeons that want to come. Thank you so much for your great interest in intraoperative DTI. We are just establishing an Erasmus training program here in Sardinia. You can apply. We have lots of facility. We have accommodation there. We have meals. We have everything. And now we are moving the first step to establish also a lab there in my new hospital. And we have an airport there. The airport is Alghero Airport that is attached just 15 to 20 minutes to my hospital there. And this is my new hospital here. This is a huge hospital with 900 beds there and 26 beds of neurosurgery. And this is the catchment area that we have in Sardinia, there in Sassari. And this is just 30 seconds to show to all of you how beautiful this place is. When you know, I was in doubt if to go or not to go, I immediately decide to go because of this, so you are more than welcome. And one of these places, Professor Costa has a beautiful apartment there. I put Stintino. Stintino is a beautiful place there. And lots of culture and tradition, and it's beautiful. And my dream I just arrived, you know, 1.5 months ago, but my dream is to arrange maybe one of the future events of World Federation there, and you are more than welcome. Thank you so much for this few minutes to describe my new affiliation, but the topic of my presentation now is a strategic approach to trigeminal schwannoma. I will just focus on this kind of schwannoma, trigeminal schwannoma, and how to choose the best approach and also to avoid complication. Everybody knows very well, this is not a novelty, that the interdural approach is the best one for trigeminal schwannoma. Why? Because we take advantage to, you know, separate the meningeal dura and periosteal dura. So for pure Meckel's cave trigeminal schwannoma, this kind of surgery totally extracerebral and interdural even surgery. So if you do a good job, you don't touch anything. But these are some of the pictures that I have to say thank you to the Michelangelo of dissection, Max Nunez, that provided us, and we published together with my Argentinian friends there this you know, beautiful paper about anatomy of the Meckel's cave and approaches to the Meckel's cave. When you focus on the Meckel's cave trigeminal schwannoma, we immediately realize that we have 3 possible corridors to go there. I'm talking just about transcranial approach. I will not focus on endoscopic endonasal approach because I don't have experience in that kind of approaches. But if we talk about interdural transcranial approach, we have 3 different corridors. The first one, potential, is the infratrochlear corridor, anteromedial and anterolateral corridor. For infratrochlear corridor, it's the classic and historical corridor that White Parkinson used for the first time for a clip ligation of, you know, fistula there, carotid cavernous fistula. So it means that it's a huge corridor, just lateral to the ICA, that leaves you to reach immediately from the lateral side the Meckel's cave that is just lateral to the cavernous sinus. And we have also to make, you know, a distinction from this kind of trigeminal schwannoma that invade the cavernous sinus that are very, very few, because it is possible an invasion from lateral to medial, but it's very, very rare. In most of the cases, despite the big and huge extension, this kind of tumor remain in the context of the volume of the Meckel's cave. That's the reason why we have to perfectly understand the anatomy of this approach and this corridor to make a good job. So, based on this kind of assumption, we can tell that volumetric analysis of these working corridors of the interdural approach to the Meckel's cave lead to a selection of the most suitable routes to this kind of tumor. And we perform with this group, with Argentinian friends and guys, we perform, you know, a study to quantitatively compare from the volumetrical point of view, from the surgical standpoint, these 3 different points of corridor, just to make, you know, clear how to choose which corridor to choose. And we calculate, I don't want to take too much time, we did lots of calculation here about, you know, volumetric analysis base, and just to show you very briefly our, you know, study here, we calculate the anteromedial corridor, the anterolateral corridor. Anteromedial is between, obviously, V1 and V2, and the lateral between V2 and V3. And we did lots of these measurements. But what we found here, we found that the volume of these 3 corridors is totally different. And the infratrochlear one is the hugest one of these corridors. So it means that we can use this kind of corridor for huge tumors, for those tumors that invade the cavernous sinus that are, you know, not so frequently, but they do exist. And we can use this kind of corridor because it's perfectly tangential to the lateral part of the lateral wall of the cavernous sinus For that kind of tumor, the Jefferson type C that invade the posterior fossa, that the dumbbell pattern of growth. But why? Because these tumors tend to enlarge the porus trigeminus. So because this is the widest corridor, we can use this corridor to treat the supratentorial and the infratentorial part of the tumor just in a single approach. And now I will show you a video here. And we calculate also another important concept about the feasibility of this corridor, that is the opening angles. The opening angles of the infratrochlear is the lesser one, is the smallest one. Why? Because for sure we have no opening angles apart from opening the infratrochlear corridor, but we have an opening angle between anteromedial V1 and V2 and anterolateral V2 and V3, and for sure the anterolateral is the hugest one, but is unpracticable. Why? Because it is not tangential to the lateral part of the cavernous sinus. So it means that for smallest tumor, with very, very tiny extension in the posterior fossa, or better, totally confined to the Meckel's cave and just lateral to the cavernous sinus, the best corridor to use is the anteromedial corridor in terms of interdural approach to the Meckel's cave. We published the results of this anatomical study on operative neurosurgery a few years ago. I suppose probably it was the last year, and I will just show you a case. This is just a couple of cases. This is a case, this is a pure classical, trigeminal schwannoma here. As you see here, this is a dumbbell shape, porus trigeminal is enlarged, and the extent of involvement of the posterior fossa through the porus trigeminal is very small. So it means that we can have the opportunity here, if you know very well this basic anatomical assumption, to treat that lesion just in a kind of approach, transcranial approach for sure. And this is a video that completing the article. This is video of my Argentinian friends that here from Baldoncini, Alvaro Campero, and also Max Nunez. And this is just to show to young people that are in the room the basic principle of the interdural approach. Meningorbital band is critical step to opening this kind of corridor. And then now, as you see here, the meningeal dura is totally separated from the temporal dura here, and you protect and you directly expose the Meckel's cave here. As you see, we can coagulate later the medial meningeal artery at the level of foramen spinosus here. And here, this is the peeling of the Meckel's cave, not of the lateral wall of the cavernous sinus. It's just a lift. Now we are coagulating the medial meningeal artery at the level of the foramen spinosum here. This is pure extracerebral surgery, extradural surgery, and this is the tumor. In most of the cases that I show you here, you can use neuromonitoring also, and you can, find V1 and V2, but with eye magnification, it's very easily to find V1 and V2, and in their pattern of growth, in most of the cases, this kind of tumor tend to, distract V1 from the 2, and you can exploit that corridor here. Oh, sorry. Okay, sorry about. You can displace the tumor here, performing debulking inside-out technique, classical, conventional, microneurosurgical technique. You can remove the tumor in block or piece by piece, depending on, but the line of sight is perfectly tangential, as I told you, to the lateral wall of the cavernous sinus, so you can reach even the posterior fossa because the porus trigeminus is already enlarged by this kind of tumor. You don't need to cut the tentorium, you don't need to do anything. You just have to know the anatomy there, and you can remove the tumor, and this is the post-op. Sorry, the post-op picture is at the end of the video, but I skipped the video. Okay. Sorry, I missed the post-op. Okay, anyway, this is the second case. This is a huge tumor. This is totally different story. Why? Because this is type C Jefferson tumor, but most of the tumor is in the posterior fossa, so no way to treat this tumor just in a single approach. That's the reason why with the retrosigmoid approach, the first part of tumor was removed, and after that, in the second part of surgery, we did the same approach to remove the supratentorial pure make escape trans-anteromedial corridor to treat this remnant of this tumor in between V1 and V2, and this is the post-op, and this is the post-op once again. So about the conclusion, the infratrochlear corridor, infratrochlear, the hugest one, can be advantageous for those kinds of Meckel's cave trigeminal schwannoma with huge involvement of the cavernous sinus and the small involvement also the posterior fossa. For the remaining part of the tumor, the anteromedial corridor between V1 and V2 is very, very suitable for most of the cases. Thank you so much.
Thank you very much. Are there any questions? No question?
Okay.
Thank you.
No question. There is one. Sorry, I don't hear you. Sorry about that.
Thank you. I think this is the same approach we used to operate on trigeminal neuralgia. When Gazerian ganglion was approached and the nerve, the median and the V2 and V3 was cut, and V1 was the same. It was in old age, it was a treatment of trigeminal neuralgia. We are familiar with this approach. This was very good technique, and our professor used to operate this in sitting position.
Okay, thank you. Yeah, it's just a comment from me. In the early morning, we see the beautiful presentation of Professor Mahmoud about the skull-base anatomy, and it's, you know, when I mentalize and I wrote also a paper about this kind of, you know, when I figure out the skull base, I always keep in mind which are the structures that are in the median and the paramedian corridors, okay? Because in my mind, you know, crista galli, planum sphenoidale, posterior limbus, and sellar area, and dorsum sellae, but the central part are on the same line, you know, that is median corridor. And now we are talking about paramedian corridor. In the paramedian corridor, you have the anterior clinoid process, the cavernous sinus, the carotid sulcus, the posterior clinoid process, and also the foramen lacerum. So now the talk is about where to go there. You can go there from, there is no way to go there, you know, from, for median, a poor midline lesion, for sure the best way is from the midline. So it's from the nose, okay, transnasal and transsphenoidal. And for those lesions that are lateral at the level of the medial skull base, just lateral to the paramedian corridor, there is no way to go there, you know. Okay, today we are talking about transorbital approach, but personally I don't agree with that kind of approach to go very, very far. The main problem and the argument that is questionable sometimes, and you know, it is very controversial, is how to approach those lesions that are at the level of the paramedian corridor, because you know you can approach that lesion from the medial to lateral or from lateral to medial. In the transcranial approaches, you go from lateral to medial. In sphenoidal approach, you go from medial to lateral, okay? But it's also a matter of, you know, the discussion about indication, you know, it's also about your expertise, okay? The only take-home message that I want to leave when we treat this kind of tumors, you know, trigeminal schwannoma especially, Meckel's cave, V1, V2, they are, most of the cases, benign tumor. So it's unacceptable for me, you know, some approaches, okay, remove part of the tumor and then do the gamma knife. The assumption is totally wrong, okay, because we have lots of approaches. It's not about, you know, to go transcranial or transsphenoidal. It's about to perform what Professor Ashargi called the pure lesionectomy, You cannot start, you know, your surgery with this plan. This plan to go there to remove just part of tumor and then to send the patient to gamma knife. it's a wrong assumption for us. We are neurosurgeons, okay? We have to take into account and we have to develop different corridors. We have to understand how to go there, and maybe it's better to go there twice instead of leave a piece of tumor in most of the cases, you know, and then send the patient to gamma knife, okay? Okay, sometimes you can leave just a piece of tumor there, but it could be accidental, and we can talk about that. But the assumption to remove just partially the tumor and send the patient to gamma knife, in my humble point of view, it's questionable. I don't know what you think about, but now I'm entering in the, you know, dangerous field. You know? I don't want to go ahead. Thank you. Thank you so much once again.
Thank you, Dr. Luzzi. Our next speaker is Dr. John Muto from Japan, who will be speaking on anatomy for nose and sinuses for neurosurgeons. Yes, sir.
Okay. Hello, everybody. My name is Muto from Japan. Okay. So, thank you for invitation, Dr. Sharman. Also, let me talk about today. I was asked to talk about the basic anatomy for nose and sinus for neurosurgeon, not ENT. Let me introduce myself. I'm from Japan. So I'm from this small city, Nagoya. This is the fourth largest city. And my hospital, Fujita Health University, is the largest number of the beds hospital. The ex-professor Kano was a WFNS 2005 president. Also, Dr. Sano is he has a Guinness record of the number of the clipping, and the current professor is Hirose. Also, I was trained by the Professor Kawase. I'm a scalpel surgeon. Now I'm working with Yoko Kato. I'm at Fujita Health University. So let me talk about another sinus anatomy divided into the two. So first, sagittal plane. Sagittal plane divided into four. The anterior skull base here, and the sella, also clivus part, and the foramen magnum part. We can see this. And the coronal plane, Dr. Kassam divided it into the 7. So petrosal portion and petroclival portion, and the quadrilant portion. Quadrilant portion is here, gastric ganglion and carotid here. Also infratemporal fossa here, and cavernous sinus, and medial condyle, also jugular foramen here. So we can access from the nose to the sagittal plane, also coronal plane, all. So nasal corridor divided into 3. The supraturbinate, middle turbinate, and the inferior turbinate. The bone is a cellar, and cellar, clivus, and the choana. The vascular, the SCA, PCA, and the vaginal artery, and the vertebral artery. Cistern, just interpendicular cistern, premedullary cistern, prepontine cistern, also premedullary cistern. Cranial nerves, 3rd nerves, 6 nerves, and 12 nerves. This is the frontal view. The 3rd nerve, and the 6th nerve, and the 12th nerve we can see. So these are the table about the landmark. You can take a picture to understand for the endoscope anatomy. This is a limitation of the endoscopic and laser. Okay, let me back. Okay, you can take a picture. And sorry. So these are the anatomy to understand, especially for the 3rd nerve, 6th nerve, and 12 nerves. Important to divide into the 3 corridor. Also, it can be access to the midbrain, also pons, and the medulla to the brainstem area from the nose. And this is a limitation of the endoscopic approach in the anterior skull base. Anterior limitation is frontal sinus, and the posterior limitation is brainstem. And the lateral limitation, the mid-orbiter, also optic nerve and carotid. But in this area, now we can go the supraorbital approach. Also, this area, the middle fossa, we can go through the transorbital approach. So this is a bone protrusion. You can imagine So this lecture will help you to understand the anatomical structure like this. Can you see the anatomy like this? Okay. So the most important structure is the medial OCR, also lateral OCR. Medial OCR is the intersection of the sella, tuberculum sella, and pranam, optic nerve, also carotid. The medial OCR is the medial edge of the carotid. And the lateral OCR. Lateral OCR is the intersection of the optic nerve and the carotid and the supraorbital fissure here. This is a super. In a frontal view, this is a optic canal and a supraorbital fissure. Between the supraorbital fissure and optic canal, this is a bone. This is the name is optic canal. Optic canal is this part. That means the lateral OCR is behind it. There is a optic struct. So when the big pneumatization of the lateral OCR, it's connected to the optic struct here. This is an intracranial view, the same anatomy. This is optic canal. This is a supraorbital fissure. This is an optic struct and anterior crinoid. So when the pneumatization of the optic canal, lateral OCR is big, so when you do the anterior craniodectomy and crack this part, so sometimes it's broke in the floor of the sphenoid sinus, disconnect into the sphenoid sinus, then the risk to the leak area. Okay, next to the epidural part. So this is the epidural anatomy. See, the medial OCR, also lateral OCR like this. So and the distal dural ring. Distal dural ring is the distal segment of the lateral OCR connecting with the sella part here. This divided into the intracranial part, intradural part, and the cavernous part. Also, the proximal ring here. Proximal ring is the proximal segment of the lateral OCR here. Lateral OCR to the middle crinoid here. So this is the interdural view. See, this is an anatomy of the interdural anatomy. So medial OCR, also lateral OCR. The nerve structure is important. Third nerve is here, and the fourth nerve is beneath the third nerve from the endoscopic view. And the sixth nerve is coming from the pont medullary junction here and through the Gruber's ligament and Drell's canal to the interdural space like this. And from the endoscopic view, sixth nerve is on the V1, ophthalmic nerve here. Also, this is a gastrial ganglion and the quadrilant system here. See, and these parts are the supraorbital fissure and the carotid here. So distal ring and the proximal rings, as I said. So there is a variation of the ICA. There is 3 types of variation previously published. When we go to the sella or clivus part, please check the width of the carotid before surgery. Also, mucosal flap. There are several types of the mucosal flap incision. I use a standard septal flap, but they have a septal flap, also Killian incision, or incision at the middle turbinate or like that. So I think you can establish your own style to make a flap or to access the sphenoid sinus. So this is my procedure. This is one of the examples that's to help you. So first, identify the sphenoid ostium and so anesthesia under the mucosa. And first, I make a frontal incision of the flap like this. And enter the mucosa, submucosa, and dissect to the vomer bone like this. Once we dissect this part, we can make easily to make a flap. From the sphenoid ostium to this is the middle turbinate, the tip of the middle turbinate, we can cut the incision. After that, we make a big flap like this, like this flap. Also, this is from sphenoid ostium to going down to the floor of the nasal cavity and make a flap like this. So dissect here like this, and after that we make we remove the cartridge part of the nasal septum. And this is the left side. We make a Killian incision in front of the inferior turbinate and make a hook. The left incision is just to make an entrance to the for the instrument, like a drill, like this. So another important structure is a BDN nerve. BDN nerve is a very important structure to show the carotid artery, the paracrine part and the petroclize part. BDN nerve is going up to the carotid. That's why the 3 o'clock to 9 o'clock, this is a safe area to drill to the carotid. Also, BDN nerve is formed from the junction of the great petrosal nerve, also deep petrosal nerve. And palatovaginal canal. This is also important anatomy to access the cavernous sinus. When you access from the front, so you open the anterior wall of the cavernous sinus, but how do you wide open the anterior wall of the sphenoid sinus? So when you see the palatovaginal canal, it's enough to access to the sphenoid sinus. You can get the enough corridor to the lateral corridor to the skull base. So also there have anatomical variation, lateral recess, you can check before surgery. Also, last important thing is Onodi cell. Onodi cells is a posterior ethmoid sinus and the overhang in the sphenoid sinus. Sometimes involved in optic canal. So when you go in the Onodi cell, sometimes injure the optic canal. So before surgery, you can check the Onodi cell. So these are the points to check before surgery by CT scan. And this is a conclusion. So the step 1 to 3 like this. Thank you so much.
Thank you. Are there any questions?
I have a, okay. I talked so quick. But this is a basic anatomy for neurosurgeon.
Any questions for Dr. Juan Moto? No, I think that's it.
Thank you.
Thank you, Dr. Moto. Our next speaker is Dr. Yasir Khaibar from Pakistan, who will be speaking on the topic of anatomy of endonasal pituitary adenomas. Dr. Yasir.
Okay, so till they upload the presentation, I'm thankful to Dr. Salman for giving me this opportunity today to talk about the anatomy of the endonasal path to the pituitary adenomas. We have already heard from Dr. Mahmood about the basic anatomy, and then Dr. John just described about it. Can we upload the presentation, please?
यहीं से चेंज कर लीजिए
तो आ नहीं रही
यहाँ से चेंज वो दे रहे हैं अभी वहाँ से करेंगे
सही तो माउस आ जाएगा इसमें
जी
कहाँ है माउस pointer I need a pointer
सर ये चार्ज नहीं है
okay so we do not have a pointer right now but all of you can see this picture. This is a picture of the nasal pathway to the pituitary. So you can see this mid-sagittal section, and moving on to the anatomy of the endonasal area, we should know about the sphenoid first of all. Sphenoid is a simple bone. It's shape of a bed. You can appreciate the two lesser wings anteriorly. You can appreciate this greater wing of the sphenoid, and we have got a body in the center. If we take a 3D view, we can see the so this is better. So we can see that lesser wings over here. These are the lesser wings of the sphenoid, and we have got a greater wing. In between the two, we have got this superior orbital fissure, and in the center, we have got this body. This body actually houses the sphenoid sinus, about which we will be studying today. And then if we see from the cranial base, we look into the vault of the skull. At the cranial base, we have got this jugum sphenoidale. We have got the chiasmatic sulcus. Then we have got the house of the pituitary, that is the sella turcica. Anterior to the sella turcica, we have got this bony ridge that is the tuberculum sali, and the lateral margins of the tuberculum sali are sometimes pointed, known as the middle clinoid process. The most medial margin of the lesser wing is also pointed, it's the anterior clinoid process, and then the two lateral margins of the dorsum sali are the posterior clinoid process. So again, this is the basic picture that how things are arranged is taken from the natus. You can see that pituitary lies within the sella turcica. On both sides, it's bounded by this bluish structure, that is cavernous sinus. We've got various nerves traveling within the cavernous sinus. Along with the ICA, we've got the abducens. And then just below, we have got this sphenoid sinus. So starting with the nose, I have placed a colored picture over here. You can see that various bones are colored. This purplish bone is the ethmoid. And this is the picture of the central mid-sagittal section. So this is the nasal septum that you are viewing. And then we have got this greenish structure that is the, this greenish structure that you are viewing is the vomer bone. And this is the perpendicular plate of the ethmoid bone. And this orange structure is your sphenoid bone and the sphenoid sinus. We have always heard in the endoscopic pituitary surgeries, we talk about the keel. So this keel or the rostrum of the sphenoid is actually composed of these two bones. That is the perpendicular plate of the ethmoid at the anterior sphenoidal face, and at the anterior-inferior surface, we have got this vomer. So again, this picture is taken from Rutan, the same thing. The perpendicular plate of ethmoid can be seen, the vomer can be seen, and you can see the sphenoid sinus, but you cannot see across the sphenoid sinus because it's covered by a septum over here. This is the septum that is usually present within the sphenoid sinus itself, known as the sphenoid septa. Moving on to the lateral wall, we can see that various projections are there within the lateral wall. We've got three projections. The superior and middle projection are part of the ethmoid bone. The inferior projection is a separate bone. So we have got superior, middle, inferior turbinate. Obviously, we have got three meatus, inferior, middle, and superior meatus below each turbinate. And then just superior to the superior turbinate, we have got this sphenoethmoidal recess. It's called sphenoethmoidal recess because it's between the sphenoid and the ethmoid above the superior turbinate. Why is sphenoethmoidal recess important? Because it's the site of the sphenopalatine foramen. It's usually located over here. Oh, sorry, sphenoid ostium is usually located over here. So you can see in this picture from the Rutan, this is the inferior turbinate or inferior concha, and this is the inferior meatus. Then we've got the middle meatus and the superior meatus. Just within the region of the sphenoethmoidal recess, we have got this sphenoid ostia present. So sphenoid ostia is easy to locate. It's just above the corner, around 8 mm above the corner during the surgery. So this is again the picture of the lateral wall. I'm not going into its detail, just skipping this portion. You can see the sphenoid sinus in this picture. And then above the sphenoid sinus, we have got the sella turcica. So when we are doing the surgery, we have to reach to this area. You can see that just at the level of the sphenoid sinus, laterally we have got this danger artery traveling over here. It's the internal carotid artery. And its prominences can be seen within the walls of the sphenoid sinus. We can also see the relationship of the optic canal over here. You can see the cranial nerve 2 and the ophthalmic artery. And then you can see the ICA. So this area between the optic and the carotid is known as the optico-carotid recess that Dr. John was just talking about. In this region, we have got a bony prominence known as the optic strut. And it actually separates the optic canal from the superior orbital fissure, which would be lying over here. So this is the coronal view. The previous one was a sagittal view. In this coronal view, you all can appreciate that we have got this midline structure. This is the septum. We have got these concha projecting on both sides. We have got the superior concha, middle concha, and the inferior concha. So whenever we are doing this endoscopic approach, you see that when we want to reach over here, the exposure is limited by this middle concha or the middle meatus, middle turbinate, sorry. So we have to lateralize it. Sometimes people tend to resect it to gain the proper access. Also, you can see that posteriorly here, the ethmoidal sinus can be seen. So we are going to remove these in the next picture. In this dissection picture, the ethmoidal sinuses have been removed. Concha have been dissected. So you can see the ethmoidal perpendicular plate directly attached to this wall. This is the anterior wall of the sphenoid sinus. And we can see the sphenoid ostia on the both sides. And if we get an enlarged view, we can see that the ethmoidal sinus just overlaps one part of the lateral portion of this sphenoid ostia. Also, we can see that laterally we have got the optic canal. So again, another picture further enhanced. In this one, you can see that inferiorly we have got the clavus, and superiorly we have got the sella turcica. So this is the anterior sellar face. Once we remove this bone, we can see the dura that is lying within the sella. So in this picture, the dura has been removed, so you can appreciate the pituitary gland and the claval region. Okay, Ji. So how does it look within an endoscope? So when you are passing within an endoscope, this picture shows various distances from the tip of the nares down. So the distance up till the anterior margin of the sphenoid sinus is around, the posterior margin of the sphenoid sinus is around 9 centimeter, and you have to go 2 centimeter within the sella as well. So the endoscopic instruments should be at least 12 centimeter in length for us to get adequate access. And this is how it looks within the endoscope. So once you put in your scope, you can inspect, and here we can see the nasal septum on the medial side and the inferior turbinate and the middle turbinate. If you direct your scope posteriorly and you can inspect the posterior end, you can see the corona, nasal septum. Again, the inferior turbinate and middle turbinate can be seen. If you look in this picture, again, we have got this nasal septum, the inferior turbinate, the middle turbinate. The middle turbinate would be lateralized to gain access within this region. This is the superior turbinate that can be appreciated. So if we go further deep down, we have to identify the sphenoid ostia on the both sides. That will be a useful landmark for beginning of a surgery. So in this picture, again, you can appreciate the superior turbinate, the middle turbinate, and the nasal septum. This is within the region of the sphenoid ostium. So now you can see the sphenoethmoidal recess can be seen over here superiorly, just superior to the superior turbinate. So within the sphenoethmoidal recess, we can identify our sphenoid ostium. And once this ostium is identified, then you know you're in the right place. And then you can do that incision within the mucosa and then deviate and then start the surgery. Again, this endoscopic picture shows the sphenoid ostia of the both sides. Once the septum has been retracted to the one side, this is the rostrum of the sphenoid bone before starting your surgery. So again, coming back to the roton, the anatomy, we have studied about these conch already, so I'm going to skip this portion. So this picture is about the various type of the sphenoid sinuses that we encounter. It can be a conchal type of sphenoid sinus in which it is entirely solid. It can be a pre-sellar when it's extending just anterior to the sella, or it can be a sellar type or a post-sellar type in which it goes all the way up till clavus. The implications of this is that in various surgeries, obviously the amount of drilling that you are going to need is going to differ. If you have got this post-sellar kind of sphenoid sinus, the bone is going to be very thin rim, and you have to be careful about the various vascular structures. This is about the septa within the sphenoid sinus. So the septa within the sphenoid sinus is not an ideal landmark to guide the midline. The midline is ideally guided by the rostrum or the point where the septum, nasal septum is attaching, not the sphenoid septa itself. They can be misleading. Some of the septa can take you towards the carotids. This is about the septa as well, the type of attachment to the wall of the sphenoid sinus. The septa can lead to the left ICA, right ICA, posterior wall. So not an ideal guide for the midline orientation. So again, in this picture, once the bony work has been removed, you can see that the dura is covering over here. We are looking within the sphenoid sinus now, and this is the region of the sella. You can see just lateral to the sella, there's a prominence, and this prominence is actually formed by the carotid arteries. So you've got this carotid prominence, you've got sellar prominence, and if you go laterally, you have got this prominence of the optic canal. In between the carotid prominence and the optic canal, you have got this recess, that is the opticocarotid recess, as Dr. John described. It extends within the optic strut, and sometimes this leads to the anterior clinoid process. So if you are doing an anterior clinoidectomy, it can lead to the inadvertent CSF leak via this path. So also you can see this is the cavernous portion of the carotid, and this one is the petrosal segment of the cavernous, or we can say the parasellar types. So once the dura has been removed, you can see that this is the carotid and this is the pituitary gland. The closest the two ICA come is in the region of the tuberculum sellae. So you have to be careful that what is the distance between the two carotids when you are doing this surgery. Move from midline towards the lateral as indicated in the safe surgical points. Also, you can appreciate that within this lateral wall, you've got various other cranial nerves as well. You've got 3, you've got 6th cranial nerve. So you have to be careful about these as well if you're doing a lateral dissection. Usually, once you're doing it with the endoscope or a microscope, you're not going to look that laterally. You would be in the midline. But previously in the older times, there was the speculum used. Sometimes surgeon used to open the speculum within the sphenoid sinus. That is always contraindicated. You have to keep the speculum out of the sinus. So if the speculum is opened within this region, it can lead to damage to these structures and the nerves as well. Sometimes the bone over there is very thin, around 0.5 mm, so it can easily lead to the injury. So this picture just shows that opticocarotid recess I previously described. Now, this is the picture that is actually the sellar face. You can see the midline sphenoidal septa, you can see the plenum and the sphenoid sinus. Once we remove the bone, you can see the pituitary gland. This bluish hue is due to the cavernous sinus that is actually surrounding the ICA part of the cavernous segment of the ICA. So the book also writes that within the experience of the Roton, the bony ridge that is separating the ICA from the sphenoid sinus is also being separated by a small segment of the cavernous sinus that comes in between. So you can see in this picture, the basilar sinus, once we remove the claval segment, we can appreciate the basilar sinuses and the pontine area. Over here we have got the pituitary gland, and this is the cavernous segment of the ICA, and then we have got the optic canal. In this picture, you can see the arterial supply of the pituitary going down from the cavernous segment of the ICA, the inferior hypophyseal arteries supplying the posterior lobe of the pituitary. I think time is up, so let's just wind it quickly. So if we look superiorly in the suprasellar region, we have got the relation of the chiasm and the pituitary stalk. So this was the picture I was talking about, the sellar face. You have got the center, sella in the center, you have got the optic protuberance, and then you have got carotid protuberance and plenum superiorly. The medial opticocarotid, lateral opticocarotid recess have already been described by Dr. John, so I'm not going to repeat it. So this is all the repetition we have already discussed about it. Just going to skip. So this is the actual picture that how it looks within the endoscope, the rostrum, the two sphenoids, and once you remove the keel, you go inside, and then you can see the region of the sella, the right sphenoid, the tuberculum, and then finally it would be explained by those who are going to discuss about the surgery itself. So that was about anatomy today. Thank you very much.
Thank you, Dr. Yasir.
Any questions? No.
Thank you, Dr. Yasir. There's a slight change in the plan. The next talk will be given by Dr. Khalid Mahmood, who will be speaking on the topic of endonasal surgery for microadenomas. Dr. Khalid.
Bismillah ar-Rahman ar-Rahim. From endonasal anatomy, we move on to the application of endonasal anatomy for endoscopic endonasal surgery for pituitary microadenomas. And I'm very grateful to Professor Salman Sharif for extending a kind invitation to me to present this talk in WFNS meeting and course. Yeah. Now, the learning object of this talk is that at the end of this talk, the participants should know the indications and contraindications, the surgical techniques, steps, the post-operative management, and the functional outcome. Now, microadenomas are the tumors when they are less than 1 centimeter. They can be contained or they can be invasive, and they can be all sort of hormone secreting, the commonest being the prolactin, then is the acromegalic, 65% are secreting and 35% are non-secreting. For the diagnostic workup, it is very important that in 20% of the cases, a good quality MRI brain plane and contrast can actually miss these microadenomas. Petrosal vein sampling is done to lateralize the site for the ACTH-secreting tumors. PET scan can be used, or in some cases, the blind exploration can be done in 2 vertical or 1 vertical and 1 horizontal plane. Now, it's very important to know that the normal pituitary gland enhances more than microadenoma. So whenever you find microadenoma, it's going to give enhanced less, so it will give you a hypo signal. And the normal pituitary will actually enhance more. This is the very important point you should remember. Now, so far as the indications for microadenoma surgery are concerned, it's the first line therapy for Cushing disease because there is no medical treatment available. It's also the first line therapy for microadenomas and contained macroadenomas. Although sandostatin is available and it's widely being advertised, but surgery is still the gold standard for small tumors. In specific situations, yes, we can use surgery for prolactinomas, and generally for non-functioning microadenomas, surgery is not indicated and it's not done. Now, when you want to do the surgery for pituitary microadenomas, you should actually understand the concept of capsules of the tumors and the capsules of the normal pituitary gland. The normal pituitary gland capsule is firm because it is full of reticulin fibers, and the pituitary tumor's capsule does not have reticulin fibers. It is a pseudocapsule which is actually soft. This is again shows the reticulin fibers microscopic view that actually surround the normal pituitary gland. Now, what you do in the surgical technique is you actually, with a sharp knife at the site of microadenoma, you actually go through the capsule, the pseudocapsule, and you cut it. Unless you make a sharp cut, you're not going to actually visualize or see the microadenoma coming. You have to define the plane by making a sharp cut in the pseudocapsule. Now, it's very important to understand the pneumatization of the sphenoid sinus. Usually, we are lucky to have a post-cellular type or a big pre-cellular type of sphenoid sinus. But you just imagine if you have a microadenoma and you have a very less pneumatized sphenoid sinus, it makes surgery very, very difficult and impossible. And if you have a well-pneumatized sphenoid sinus, and even if the tumor is very small, the surgery, I think it's not very difficult. This is the normal anatomy. You know, it has already been elaborated very nicely. This is the endoscopic anatomy. And as I have mentioned that microadenomas, they are hyposignal on T1 beta image. They enhance less. And usually they are eccentrically, all the microadenomas in which we do surgery, like in acromegalic or in Cushing or in drug-resistant prolactinomas, there is a usual peripheral component, very in the near vicinity of the carotid. So your lateral exposure is very, very important, because if you don't do the lateral exposure, you're going to miss out the biochemical cure in these patients. Same concept, the normal pituitary enhances while the microadenoma enhances less. You should have an anatomy, and this is again the same concept of the pituitary capsules and pseudocapsule of the normal tumor, and you should actually, with a sharp knife, cut the capsule before you approach the microadenoma. Now, this is the patient with the Cushing disease, microadenoma that was eccentrically placed on the right side. So you're doing endoscopically, and for microadenomas, there is no need to actually raise a flap because the chances of the CSF leak are too little. We used to do, this was a child actually, that's why we did turbinectomy, but nowadays we're not doing turbinectomies, you know, we just lateralize the middle turbinate. You cut through the mucosa and do the posterior septectomy. There's no need to raise a nasoseptal flap. So if you reach the sphenoid sinus, and as I have already said, that if the sphenoid sinus is well pneumatized, it makes the microadenoma surgery a fun actually. But the real difficulty is when the sphenoid sinus is not well pneumatized and it's either a pre-cellar type, then you have to use the neuronavigation because the cellar floor is very small. The bone of the cella is thick. This is the vomer which we are going through. And as you go through the vomer, we have entered the sphenoid. We are doing the sphenoidotomy. And you should be very radical with the bony work, to be honest. Although you're doing endoscopically, but the type of exposure you do, you are actually maximizing the exposure. And you are maximizing the bone work cranially, caudally, medially, laterally on the both sides. And there is no need actually to use the neuronavigation for any bony marks because you have done exposure and everything is in front of you. Yes, in redo surgeries or in difficult cases, there remains a place for neuronavigation. The drill which you use, you should make it paper thin, and when you lift it with a hook or with the foot plate of pituitary rongeurs without actually using any force. That you should mind it for microadenoma. The cellar floor is very thick. It's not like a big macroadenoma which makes the cellar floor thin. So it's take a while actually to drill it. And you can use the size of the drilling bit, either 3 mm or 4 mm or 2 mm, depending upon the size of the cellar. You make a cut, and there is all sort of different ways of actually incising the dura. Sometimes I incise it circularly, sometimes I make a cruciate, sometimes I make a flap. Once you have actually incised it, depending upon the preoperative anatomy, you should go as lateral in exposure and as lateral in cutting the dura as possible, but obviously not going to the cavernous sinus. And now you are actually incising the capsule at the possible site. Sometimes you see a bulge of the microadenoma. If you don't see the bulge, then you know which side is it. And at that point, actually, with the number 11 knife, you make a cut. You can easily differentiate between a microadenoma, which is actually grayish type of a tumor, while the normal pituitary is pinkish, it is firm, you can't suck it. It has got a capillaries on it, it's orangish color, and the microadenoma start coming out. And once you have the 2 mm semi-curved pituitary rongeur is my favorite. Once you get in, you can use a very small ring curette and try to do everything under vision. And you would realize that even if you want to enter the normal pituitary, you cannot because it has got a resilient reticulin capsule. So you stay within the microadenomas and try to remove it as much as possible because this is your first and last chance. And you're working at the site of this tumor, and I'm maximizing my efforts of removing the tumor on that site. For ACTH secreting tumors, most of the ACTH are actually less than 1 centimeter. They are less than 5 mm. The outcome is 80%. For growth hormone secreting tumors, which are either micro or contained macro, the outcome is very, very good. It's 57. And for others, what is the aim of surgery is to decompress the visual pathways and actually to optimize the standostatin therapy, because the smaller the size, the more the standostatin, the chances are that you would work with a lesser dose and there are more chances of the biochemical cure. For a prolactinoma secreting tumors, for microadenoma, it's a 74% cures. And my experience is that all those prolactinomas which I have operated who have been on cabergoline for many, many years, when you operate on these, I have a feeling that as if I'm operating on a meningioma, it's not a pituitary tumor, they're very hard. And you have to go through the extracapsular approach and try to excise it as much as possible. And many of these patients, they came off the cabergoline, but you cannot guarantee that in every patient they would come off the cabergoline. There are more chances of the transient diabetes insipidus because you are fiddling with the normal pituitary, But since it's a smaller in size, there are less chances of the dural leak. So there is no need to raise the nasoseptal flap. The sinonasal complications are less because you don't raise the flap. Now, there are increased overall morbidity and mortality due to microadenoma surgery because all these patients, they can have a cardiomyopathy, they can have a hypertension, they can have a diabetes, they can be overweight, they can have all sort of metabolic problems. So that actually increases the mortality in functioning adenomas if you compare with the non-functioning adenomas. So these are the references for microadenoma surgery done endoscopically. And thank you very much for your attention. I hope I am on time. If there are any questions, I would be delighted to answer. Thank you.
Thank you, Dr. Khalid. Our next speaker is Dr. Asif Bashir, who will be speaking on the topic of MIS tubular surgery.
Connector. Thank you. So switching gears, I think everybody's ready for lunch. And my talk was supposed to be early this morning when I was still on the plane. So just bear me out, please. It's been wonderful listening. You know, every time I come to Liaquat National, or especially what Salman has arranged, we started with the Karachi Spine. That was right after I moved to Pakistan. It has been wonderful making new friends. But my disclosure today is that I really enjoyed two beautiful people and two beautiful talks. One was Abu Zar with the jet skis, and Sardinia with our friend from Italy, Dr. Luzzi. So I think we should definitely have our next meeting, or at least an educational course there. So as we are going to have the spine session after lunch, but I'm going to just quickly give you a layout of minimally invasive MIS spine, especially to our youngsters who are here. So what is minimally invasive surgery? You just saw minimally invasive endoscopic surgery for the pituitary. It is the same in spine also. It's just a catch term. It is surgery which is done through less invasively, smaller incisions. It's the same as, the goals are same as getting an open surgery done. And approaches are less morbid, less bleeding, reduces the preoperative pain of the open procedures, reduces recovery time, as well as hospital cost. So improves patient outcome. So if you do MIS surgery, at least where I practice in the other part of the world in US, and you send them home in 2-3 hours, it is the other way. The insurance company is bundling up. So if you're doing it, fusions, anything you're doing less invasive is going to go home. So you look like a star in the hospital because you're sending all those patients home. And of course, that is not the only goal. The real goal is the patient's outcomes. I think that's what matters most. So revision surgery is one of our most common indications. Instead of large dorsal incisions, we have traditional open approaches. They have overnight stays or longer. They have pain for distraction pain for weeks. And how you transition to MIS is just looking through smaller and smaller incisions. By the way, if you look at the first slide, I mentioned MED, which is 99% of what is done still done in US, and Mehmet is sitting here, and he's been leading the front in Turkey. But I have been very, very intrigued with the ED, which is the endoscopic decompressions, and we've been trying, being in this part of the world, we get to try Chinese, Korean, whatever. So we're trying UBE. I'll talk briefly about the UBE also. We've done a few cases with that. Instead of one small incision, we end up doing 2 incisions, which come out to be a little bigger than the if you combine the two incisions with the microendoscopic incision. So instead of 12, 14 millimeter, you may sometimes have to go for the 16 millimeter. But the real advantage is I feel I'm working, as I do cranial also, I'm working just like Professor Khalid was showing you, working with two hands, binasal. So that's an advantage. But I think it's an evolution, the UBE also. So targets, location, radiology, anatomy, anatomy, anatomy. How do you localize? You have one X-ray. We start with always with an AP. You mark the lamina. You identify the landmarks and expose. And always start with a larger tube. I started with 18, and slowly we went to the smallest one. The smallest we can now use. Metrics has 14, which is the smallest. We do all spinal tumors, which are 1 or 2 levels, which are extramedullary through the tubes now. We have close to 70 plus cases now, which we've done. I think it was this forum when I mentioned that we've had a 0 CSF leak. We don't even close the dura. But we've had CSF leak lately, in fact, 2 patients, which were spontaneous, not even the tumor surgery, so where we didn't have that big of an opening. So every patient is different. Spondylolisthesis, I think that's a great indication to operate endoscopically or microendoscopically. How you dock your tube or your endoscope is the key. Looking at this. So all the planning is done. You market everything on the skin, on the AP. And I'm very proud that we have a lot of people who have learned how to do percutaneous kyphoplasties. That's where you start with, and then you move on to the next paradigm. And if you're doing a TLIF, you go about, the book says 4 centimeter, but I usually do about 2 finger breadths, which is about 3 centimeter, depending on the size of your. So different dilators. Even with endoscopic, you have to still dilate. You can use, like the Wolf setup or something, Revo, it's a 7 millimeter versus if you're doing the one which we use, UB, which is slightly bigger than that. So guide wire insertion, I have, initially I had a couple of CSF leaks, so I don't use a K-wire. I never recommend using a K-wire. You use the smallest tube, which is a bigger, you always look for the, feel for the bone. Once you've placed on the bone, especially in revision cases, go laterally and then come medially. Don't go medial. Medial is where you will get a leak. So fluoromarking, docking, 14 is what we use now. Dilate, smaller, maybe better, and always between the facet lamina junction. So different types of tubes. This was the initial metrics, which we still use, a lot of these. I don't like the beveled ones. I've had leaking with this also. We've damaged the dura once with this also, so I don't like to use this. I like the rounded tubes, if you're using a tube. So, of course, no question, this is a less morbid incision, less, and this is a typical patient for an MIS, ED, or, by the way, I'm getting more and more convinced that even with endoscopic decompression, you can attain, multi-level is challenging, but you can attain a very good decompression with pure endoscopic decompressions also. And synovial cyst, neoplasms, like we mentioned, intradural, extramedullary tumors. These are the typical, this is size of a dime, this is a revision surgery again, this is post-op, this is pre-op on the right-hand side. Again, some of the steps, how to dilate, how to expose. We have, in fact, we've prepared special bovies also. If somebody is too deep, like if it's more than 9 inches, we had the local vendors make long bovie needles also for us, so we don't have to damage the dura. So central, this is another preoperative case. This is a lumbar stenosis. On the left, you will see preoperatively. On the right side, you see postoperative decompression. In fact, here I get to, so I always recommend doing both sides. For lumbar stenosis, you dock it from one side, which is the more symptomatic side, and you can always go to the opposite side under the spinous process. You can do, so we do an L2 to sacrum with one incision now, which is 4 levels. They do get a little bit of spasm, which takes about 4 to 6 weeks to settle. And some of the planning with the metrics. Case example. So 58-year lady with neurogenic claudication, perfect patient for just has typical neurogenic complaints, no back pain. She has EHL weakness, L4-5 spondylolisthesis, about grade 1 to 2. You can safely do grade 2 up to grade 3 also and not have to fuse. And we followed our patients over long term now, over 10 years now, and we've had 0 patient we've had to fuse. If you've done unilateral, minimally invasive decompression, even on a grade 2 spondy, they don't need fusion surgery later on if you are very careful. So contralateral decompression is very doable. You can see postoperative. It's about 50 minutes of operative time as compared to, it takes you about an hour just to expose if you're doing it open. And the resolution of weakness with time, no back pain. So we follow, typically I've been following these patients for at least for 5 years. And in fact, I've learned this from our orthopedic colleagues. You know, we do the surgery and we let them go. Even in US, we don't normally follow them up for more than 3 to 6 months. But the orthopods, they always follow their patients for up to 1 year. I think this is a learning thing which we do. So I think the longer you follow them up, you can critique your own results and change your practice also and how you teach. So again, synovial cyst, which is also one of the wonderful indications for this. You can see the synovial cyst right here. You can remove it. You can remove the medial facet. The patient just does fine. Again, open versus MIS. This is a MIS T-lift done from the left side after a revision. C-spine. So C-spine, we were very commonly using C-spine also. This was the same patient, left MIS T-lift. Revision MED versus T-lift. You can see this is how we do that. And we always do the decompression first, and then we do the percutaneous screws. Coming to the cervical spine, switching gears, you can do mostly framinotomies, discectomies with the 12, 14, 7 millimeter endoscope, metrics, whatever you feel comfortable with. But the OC junction, occipitocervical junction, this is a 89-year-old female. So she was in a wheelchair. I just saw her at a wedding 2 years post-op. She's already 2 years post-op. So instead of doing an open LAMI, all she needed was a C2, C1 decompression. We put a small tube here and look at the postoperative decompression. And even if you have a leak, it doesn't really matter because it's not going to be overt. So another example, intradural tumor. You can see it on the SAG also. And then postoperatively, neurofibroma. Almost done. Lumbar, a couple of other cases. So I think this is another L2 intradural neurofibroma. You can see the post-op on the right side. So gross total resection in most cases, no neurological deficits, no CSF leak in our series for intradural tumors. So advantages, limitations, of course, learning curve is always when I just used the UBE a couple of weeks back, it was a learning curve, but then we realized, it is just like operating with 2 hands doing a cellar surgery. So lessons learned, AP, always start with AP. We can use a drill through this, which is a micro drill. Always preserve the flaval ligament before you have seen the dura. And don't really need to close the dura even if you have one. Conclusions, it's same-day surgery. You can use minimal EBL, learning curve, far lateral paramedian incisions. Any open for questions? Thank you.
Thank you, Dr. Asif. That concludes our morning session. I would request everyone to join us for lunch. The faculty is hosted downstairs and the guests are in the exhibition area. Thank you, everyone.
Dear friends, we must start the session. I think from the morning session there is one talk lacking. This is John Muto's talk. You'll make your talk and on the yeah. Okay. Endoscopic approach to tumors extending into the third ventricle.
Yes.
You will make that talk now.
Yeah. Now?
Okay. Now.
Oh, okay. It's working.
Yeah, please. Can you please help Dr. Muto for connection? The technical personnel, please help Dr. Muto. No, I cannot wait. No, I cannot wait. I said we will start at 2 o'clock. Yes. Please call them. I cannot wait. No, because we are too late from the program. Okay. Okay. No. Okay. I would ask Dr. Halit for moderation. Please, Dr. Halit.
So they still have a lunch.
Yeah, a lot of people are still not back. Okay, sir, please.
Yes, Dr. Muto.
Okay. Hello again. So now I'm talking about the endoscopic approach to the tumor extending into the third ventricle. So I finished my introduction. So my topic is three this time. So PITNET, craniopharyngioma, and the robotic surgery to the third ventricle. I think third one is interesting for you. Huh? Okay. So the tumor extending the third ventricle, the pathology is a PITNET, craniopharyngioma, also tumor in the third ventricle. There are several approaches to the disease region, interhemisphere, endoscope, orbitozymatic, transpetrosal, and supraorbital approach. So merits of the combined approach is these 4 points. Prevention of the post-operative bleedings due to the residual tumor, and reliable hemostasis by compensating the blind spot, and enable removal of the tumor in the one block as much as possible, and prevention of the CSF leakage. So indication of the combined approach in PITNET, 40 millimeter. This is a good indication for combined approach. Less than 40 meter, we can approach only in the endoscopic endonasal. And beyond the carotid, and also multilobular like this. Also including the MCA, also ICA, the PITNET. I would like to introduce this case. This is not so big, but interesting. 66 years old male was presented with a visual disturbance. The MRI shows a regular PITNET non-function. The normal pituitary gland is thin on the upside, also backside. Then the patient shows a left upper quadrant nausea. So this is a regular pituitary case. Open the sphenoid sinus and go into the sphenoid sinus. This is a tumor inside the sphenoid sinus. We resect as usual. Open the bone and open the skull and resect the tumor like this. Also remove the bone and the septum. during the bone and septum like this. So we expose the normal dura like this. So this is a bone structure, as I shown in a previous presentation. So this is a tumor, and now I cut the dura and expose the tumor like this. This is a regular pituitary surgery like this. And I use the ICG to identify the normal pituitary gland, as I show you later. So the expose the tumor, also dura, normal pituitary gland. See, the green one is a normal pituitary gland. After ICG injection, so the normal ICG stays inside the normal pituitary gland, and we can identify the normal pituitary gland and pituitary tumors. This is the normal pituitary gland, very thin. So we can remove the unstained part of the ICG. So this is a regular tumor removal, and also resect by the curette, like this. First, empty the cell floor because of, this is a thinner normal pituitary gland is coming up from the top. Also, second point is this wet field. I like wet field technique to wash the blood, also to make a hemostasis. So to identify the residual tumor like this, so to use I use the ICG, also a wet field technique, and carefully protects the normal pituitary gland. This is the end of surgery. So wet field identifies the normal pituitary gland and arachnoid. So I use the Duragen here and finish. This is a finish. So the point is just remove the bone of the tubercular cell part to access the supracellular region. We don't need to open the extended supracellular part of the dura. Just to remove the bone, we retract the dura and access to the supracellular part of the tumor. So I told about the ICG technique. I named the delayed window ICG technique about this. The half dosage of ICG is injected after 15 minutes. So the rate of the normal pituitary gland to tumor is higher, so that we can identify the normal pituitary gland in this time. That's why we call the delayed window ICG. I published this technique in the World Neurosurgery. Okay, next, craniopharyngioma. They have 4 classification about the craniopharyngioma: intracellular type, prechiasmatic type, postchiasmatic type, and interventricular type. Usually, we can access by endoscope and nasal to the intracellular type, prechiasmatic type, also retrochiasmatic type. But if the prechiasmatic with lateral extension, we use orbitozygomatic, and retrochiasmatic is larger one. Also calcification with the transpetrosal type. And interventricular type, we cannot access from the nose. So we need to use the interhemispheric approach. So this is a case about the prechiasmatic type. 50 years old female, just a patient shows the upper quadrilateral tonospcia. MRI shows that this kind of tumor in prechiasmatic supracellular region. We do the endoscope approach. So this is a regular approach. We make a septal flap, also remove the bone, and this is a cella. Also remove the bone of floor like this, expose the dura widely like this, and cut the dura medially. So I like this medial incision because usually this kind of tumor, after tumor resection, the ventricle is open and higher leakage from the ventricle. That's why for the closure, so we use a linear incision like this. So go straight in the midline and access to the tumor directly. So this is a optic nerve, also pituitary stalk is here, left side. So we access directly to the tumor and remove carefully and in this small window. Another point is drill out the bone, everything, because we need to push down the pituitary gland, and we make a space about this part. So slowly we go into the deep side, and sometimes I use the QSA. So this already opens the third ventricle, and we can dissect the only tumor. Because inside the third ventricle, there is no critical perforator. Critical perforator is just a super SHA, super hypophyseal artery near the stalk. That's why inside the tumor is safe and dissect from the attachment. So this is the inside the ventricle. We check. I like water wet field technique like this. So I check the tumor almost resection, and finally I close like this. So for the ventricle open exposite grade 4, I use suturing like this in a deep sheet, but it's very troublesome for suturing. But also this hard reconstruction to prevent the water hammer effect, I put this hard plate to the cellar part and close the mucosa. So this is a small residual, but the patient has a pituitary function, preserve the pituitary function. The next case is a retrochiasma type tumor is like here in a retrochiasmatic place, but located only in the midline. That's why so I use endoscopic endonasal approach. The approach is the same. So we drill the bone as much as possible, and so as I told you, there's a drill of the cribus part of the this part. So we can push down the normal pituitary gland and make a corridor this space. Make a incision in a midline. Also, it's going to the. Okay, let's. Last 3 minutes. I just quick finish because I want to talk about the robotic. So just going to straight and go midline and so go lateral. So just dissect carefully. This is a stalk I preserved, and to dissect from the surroundings, and or just use a cursor on the dissect like this. Sorry for skipping. And the total finally, so I confirm the total tumor resection like this. Okay, I used the Duragen previously. Duragen also flap. So patient is like this. But this is adenomatous type of the craniopharyngioma. The treatment strategy for papillary craniopharyngioma is changing because the papillary craniopharyngioma, most of tumor has a BRAF V16E mutation. For this mutation, so BRAF/MEK inhibitor can work. The 93% of response, also volume shrinking, they said. That's why, so the strategy is changing. The currently of the treatment strategy of the craniopharyngioma, just by biopsy and identify the adamantinomatous or papillary. For adamantinomatous, just surgery and resection. This is a regular style. But for papillary case, they have a BRAF V16E mutation. So we can use molecular targeting drug several times and shrinkage. If not, so we can use surgery. So this is how do you say here? It's different. This is a current strategy for the craniopharyngioma. Okay, next topic will be robotic. So there have some publication of the Da Vinci to the skull base region, but currently it's not useful for the neurosurgery field. How far from can the robotic work transorally? So I did the transoral approach. This is a Da Vinci XI to the transoral. So open the mouth, and usually the transoral approach to the for ENT is downward, but I put it upward, and this is soft operate, and make an incision soft operate laterally, and make a space of the nasopharynx to expose the nasopharynx. Just to skip, just cut the laterally, so make expose the nasopharynx and the eustachian tubes easier. So usually to access this part, we make a mucosal flap like this. So we did the same by monopolar. So this is a cribus, also sphenoid or sinus here. Usually we from endonasal endoscopic approach from the front, but this from this angle, this is from the lower. So we expose. This is a cellar, and this is a pituitary gland here. So now, usually use scissors, but for the cadaver, it's very hard for scissors. That's why. So this time I use the monopolar like this, and open the dura mater and expose the pituitary gland like this. So this is the pituitary gland and the sella from transoral view. So just touch the pituitary gland to expose diaphragm. So diaphragm is here. Okay, almost time. So just open the diaphragm, and open the diaphragm, we can enter the third ventricle from the transoral approach like this. Just the posterior circulation we can expose and identify. This is the flow of the third ventricle. So just to access from the transoral, let's go top. So finally, we can access to the third ventricle from the transoral approach by robot. In the future, we can use the robotic technique from this approach. See, this is the end of the view. Okay. My conclusion is transoral robotic approach from to the third ventricle to the C2 also oropharyngeal. Okay, this is the conclusion. Thank you for attention.
Thanks a lot. Really very educational talk. Are there any questions from the audience? Yeah, please.
After the transnasal endoscopic approach, I think the transoral is totally obsolete because you can easily go from the nostril, and as you do the cellular surgery, you can go a little bit down and work on the clivus. So what is your concept of transoral for the surgery, and what are the indications for that? What kind of the transoral pathologies you are doing right now?
Thank you for question. So currently the big chordoma, chondrosarcoma bone structure, also schwannoma or malignant pathology, I think. But this is just a suggestion in the future.
So still you can go easily from the transnasal endoscopic approach. I think for us also it was very big task before we learned how to go from the transnasal endoscopically. I think that is very easy. You can go anteriorly, and you can work on the sella, and you also go downward in the clivus.
Yeah, I agree with you.
Thanks a lot. Thanks a lot for a nice talk.
We move on to spine section now.
Yes, our next speaker will be speaking on the topic of spine, who will be Dr. Nicolas Pive. I request Dr. Pive to join us on the stage and discuss intra-LIF approaches, first steps, and how to start. Dr. Pive? Okay. We can move on to our next presenter.
Do you have any other talk today?
Basically, what happened is they moved my talk from tomorrow because I am flying tomorrow.
Okay. Is there any other talk you're giving today?
YMIS, I think I was asked to.
Okay. Well, let's go to the second speaker.
No, but since he has been announced, he would like to give us another talk.
I don't mind.
No. We don't have much time. Thank you. Thank you. Thank you.
Okay. We will move on to our next speaker then.
Yeah.
Dr. Mahmood Qureshi. Can you please come up on the stage and talk to us about sacral fractures, osteoporotic spine fractures, and management?
Sacral fractures,
Thank you very much once again. Always a pleasure. Two things. When I was given the request to speak, two topics that I usually give separately were asked to be given in one, so I'll kind of need to rush. No, it's the second talk. It's the spine one, it's the sacral fractures. The second is a confession. There are more people in this audience who are who are proficient at sacral fracture management than my humble self. So if I do say something that is not agreeable to those who are more experts in sacral fractures than my humble self, then please feel free to criticize me, critique me, because that's not my area of strength. So with that, I will... What's happening? Are we good? Are we good? Right. So that's myself. Briefly, we'll go through the osteology of the sacrum. It's formed by the fusion of 5 sacral vertebrae articulating with the 5 lumbar vertebrae, coccyx, the ilium, and the 4 foramina through which the sacral nerves exit. There are neural structures that are important to consider. The L5 nerve root running on top of the sacral area, S1 to S4, S1 and 2, which carry the highest rate of injury, the lower sacral nerve root, and of course, which are involved with the function of the anal sphincter and the bulbocavernosus reflex, the perianal sensation, and the unilateral preservation of nerves is, it is recognized that even if you do have the fractures, if you have unilateral preservation of nerves, this seems to be adequate for bowel and bladder control. Epidemiology of sacral fractures, the incidence is suspected to be around 30 to 40% in injuries of the pelvic ring. There's a bimodal distribution, a high energy trauma in young adults, and low energy fall in the osteoporotic elderly. Associated injuries with this type of trauma is neurological injury in about 25% are frequently missed. 75% in patients who are neurologically intact may actually have a sacral fracture, and 50% of patients who have a neurological deficit will have a sacral fracture. So a high index of suspicion is required. When it comes to classifications, there's a plethora of classifications which have been proposed for sacral fractures, but none are comprehensive and none are universally accepted. The existing sacral injury classifications are based on either fracture morphology or an inferred mechanism of injury. So of the existing systems are either very broad and simplistic, such as the Dennis classification, and currently the most commonly used sacral classification is indeed the Dennis classification. Others are exceedingly specific, such as the Isler classification, the Roy-Camille, the Strange, Wongson, and the Beck are other classifications. But one very, very extensive and I think appropriate for research, and I'd like the comments of those experts I mentioned earlier, is the AO classification which has been developed. For purposes of this talk, we shall be discussing the Dennis classification in this presentation. So what is the Dennis classification? This is a 3-dimensional volume rendered CT image of a sacrum with demarcated zone described, as you see. Zone 1 are fractures that are lateral to the foramen, the sacral foramina. Zone 2 are fractures through the foramen, and Zone 3 are fractures that are medial to the foramen. As one would expect, this is the more common occurring fracture, and nerve injuries are usually to the L5 nerve root, and these occur less frequently. Zone 2 are fractures through the foramen, and these are oftentimes unstable, but they may sometimes be stable. Zone 2 fractures with shear component are the ones that are highly unstable. Such fractures have a high risk of non-union and poor functional outcome. Zone 3 are fractures that are medial to the foramen into the spinal canal, highest rate of neurological fallout, and associated with bowel, bladder, and sexual dysfunction. Zone 3 fractures involving the central canal is then further divided, and we won't go into details, but suffice it to say that they have 4 types of different classification within that zone 3. Then there are the transverse sacral fractures, as seen here. These have the highest nerve dysfunction fallout rate. Then there is what is described as the U-type sacral fractures resulting from axial loading, falls from a height, representing spinal pelvic dissociation, very high incidence of neurological complications. The clinical presentation is important, but because of your combining two talks, we'll run through them quickly. The history is most commonly a motor vehicle accident or a fall from a height, repetitive stress in the elderly, insufficiency fractures in the osteoporotic patient, and they often complain of peripelvic pain. There are different ways of examining them. The Faber test and the Morel-Leville test are the common ones. We'll just go briefly. The vaginal examination in females is advised to rule out an open injury into. This is the flexion, abduction, external rotation test, the so-called Faber test, which is done with one leg in flexion, as you see at the knee, externally rotated, a downward pressure on the flexed knee and contralateral anterior superior iliac spine. The test provokes pain at the site of the fracture. So this is the Faber test. The Gainsland test is also a stress test at the fracture site, and the description is shown. One leg flexed maximally at both the knee and the hip, and downward pressure on both knees towards the floor. The test provokes, again, pain at the site of the fracture. Clinical examination, it's important to carry out a rectal examination. Light touch pinprick is often the impaired dermatome. A perianal wink, a bulbocavernosus and cremasteric reflex are examined. But it's important to equally examine the vasculature, because distal pulses can get impaired, so those need to be examined. And one can examine the so-called ankle brachial index, and is described as dividing the blood pressure at the ankle by blood pressure at the arm. The normal pressure is 0.9. If it's less than 0.9, this suggests that there is vascular compromise. The radiological assessment of sacral fractures, X-ray reveal about 30% of the fractures. An AP view, an outlet view provides the best view. Lateral views are necessary, but an inlet view usually is more helpful. The recommended inlet view provides the best assessment of sacral spinal canal and the superior view of the S1. The outlet provides true AP of the sacrum. CT scanning is the diagnostic study of choice. Recommended views include the coronal and the sagittal reconstruction views, as is shown. The role of MRI is to be considered. MRI is highly sensitive and specific for diagnosis of sacral stress fractures. Often it is the edema which is most conspicuous, as is shown on the image, exhibiting low signal intensity on T1, weighted images, or high signal on stir sequences, as is shown on this particular image. Should be requested particularly when there is a neurological fallout. Treatment options: there is the non-operative option of progressive weight bearing with an orthosis usually. Indications are if there's a less than 1 centimeter displacement and no neurological deficit, or it's a osteoporotic insufficiency fracture. There are operative indications, none that I have performed myself. These are displaced fractures of greater than 1 centimeter. If there is suspected soft tissue compromise, persistent pain despite non-operative management, and displacement of fracture after non-operative management. Any evidence of neurological injury warrants surgical decompression and fixation. So the management techniques we shall go through, don't know how much time I have, but are outlined in that slide. I won't go into each one of them, but the percutaneous screw placements may be placed at the sacroiliac, transsacral or transiliac. Transsacral, useful for sagittal plane fractures. The technique is to use screws placed percutaneously under image intensifier. We must be aware that the L5 nerve root could get damaged. Avoid overcompression of the fracture. This may cause iatrogenic nerve dysfunction. Screw placement posterior to the ICD line ensures safe screw placement used in non-dysmorphic sacrums. The cons of this procedure are that it may result in loss of fixation or malreduction. Does not allow for removal of any loose fragments, obviously, and is not to be used in the osteoporotic spine. There is now a growing tendency to use percutaneous sacroplasty. It's a minimally invasive percutaneous image-guided technique done by neuroradiologists as well. Injection of methyl methacrylate bone cement through one or more trocar needles. First documented use of sacroplasty was in 2001 for painful sacral metastasis. The image guidance is operator dependent. The two main needles approach the posterior and the long axis, as is shown here. The anterior oblique view is shown here. The needle with the left S1 wing is advanced as the target of the S1 needle tip. The intersection of the lines is drawn. Basically, Binari et al. In 2006 suggested the long axis technique is an optimal approach. Using a single needle, they thought there was better cement distribution and decreased risk of anterior cortex violation. The single needle lateral sacroplasty technique, as I mentioned, was described again in 2019, and it is emerging as a useful tool for the treatment of sacral fractures. We will not go into the details of that technique, but it's the paper is provided for you to look at for more detail. This is again the single needle lateral sacroplasty technique, which one can look into. This is what you expect to see on your lateral image. Then there is something called posterior tension band plating. It's an approach from the posterior to incision sites, allowing for direct visualization of the fracture, can result in wound healing complications, as you see what I shown on the images there. The iliosacral and lumbopelvic fixation is another approach, as shown in the images. Decompression of neural elements, the techniques involve indirect and the direct approach. As I mentioned, I was asked to give 2 talks in one, so I'll just run through very quickly. These are the conclusions. There are many classifications have been proposed for sacral fractures. In effect, in an effort to develop classification that will obtain global acceptance, the AO classification has been developed. There are common pelvic injuries that are underdiagnosed, and diagnosis can be made with pelvic radiographs, but frequently require CT with 3D reconstruction. Treatments may be operative or non-operative. Presence of a neurological deficit is the most common factor in predicting outcome. Displacement risks a greater chance of neurological fallout, and mistreatment fractures may result in lower extremity deficits, urinary dysfunction, rectal dysfunction, sexual dysfunction. So while I was asked to combine 2 talks, I think for the interests of time, I can continue, or I can leave it to the judgment of our do tell me whether I can continue, because I was a bit taken aback when I was given 2 talks to be combined into one, and I didn't really want to do injustice to either, so I just combined the two.
What's the topic of the next talk?
It was to combine sacral fractures with osteoporotic vertebral compression fractures.
Yeah, you can continue, yes.
Thank you. With your permission, I shall. The definition of an osteoporotic fracture is defined as fractures resulting from mechanical forces which would not ordinarily result in a fracture. It is also referred to as fragility fractures or low-level or low-energy fractures. And the WHO has quantified these forces as being equivalent to a fall from a standing height, or less commonly, a fall onto a buttock or pressure from normal activity. So the bottom line is that it's not going to be excessive force, may occur without any identifiable trauma, particularly in the very osteoporotic. The incidence of these OVCF, osteoporotic vertebral compression fractures, is most common type of osteoporotic fracture worldwide, and its prevalence is gradually increasing as the aging population increases, and some studies have suggested that it could be occurring in about 30 to 50% of the global population over 50, a worrisome statistics for those who are sitting in this room, largely unreported and probably more common if x-rays were done on all of those patients. The risk of an osteoporotic fracture is both a symptom and a sign of osteoporosis. Factors that increase the risk are use of oral or systemic steroids, advanced age, the female sex, family history of osteoporosis, and previous fractures. Patient who has sustained one fracture is at a higher risk of a secondary fracture due to the increased bone loss. After menopause, ladies have more bone loss. Age-related age loss is obviously in both sexes. The prevalence is higher in females, from 2% at 50 years to more than 25% at 80 years in women. Fragility fractures are associated with decreased life expectancy. Diagnosing these traditionally is with an X-ray, but CT scanning is the best test to visualize these fractures. MRI has a role in detecting osteoporosis by defining the appearances of the bone marrow through its relative amount of protein, fat, water, and cells on an MRI. The dual X-ray absorptiometry, DXA, uses very low levels of X-rays, and currently is the technique to measure bone density as well as diagnose osteoporosis according to the WHO guidelines. The diagnosis of the use of DEXA is shown to diagnose vertebral fractures with the advantage of determining bone mineral density at the same time. So DEXA is what you want to go for. The principle is that these dual X-ray absorptiometry scan is a means of measuring bone mineral density along with using a spectral imaging. It also helps with the bone density measurements. 2 X-ray beams are used, and then the bone density measurements are compared with the bone density of a younger, healthy adult. Advantages of using DXA over conventional X-rays is its minimal radiation and the faster acquisition. That's what a DEXA image will look like in normal bone and osteoporotic bone. And should we use CT or MRI? CT is much faster modality, obviously. The preparation usually takes longer than the CT scan itself. In a patient with a lot of pain, it's obviously better and quicker to do a CT scan. However, CT scan expose patients to a dose of radiation. MRIs are ideal for diagnosing any soft tissue or spinal ligament pathology and can reveal abnormal marrow appearances or other causes such as pathological fractures. The medical management of these, the fractures cause moderate to severe back pain for a shorter or longer duration. There are several aims of medical treatment. If the vertebral fractures are painful, pain relief is primarily what is focused on. The the medical treatment of painful vertebral fractures includes analgesics, obviously, physiotherapy, and exercise. The principles involve have the aim to prevent future vertebral fractures. The treatment can be divided into anabolic and anti-resorptive therapies, with anabolic therapies of course primarily stimulating the osteoblasts, and the anti-resorptive therapies primarily inhibiting osteoclasts and bone resorption. There is a role for calcium and vitamin D in this. There is a whole plethora of medication used for anti-resorptive therapies, which we shall not go into a detailed discussion on. There are the biphosphonates, there are the hormone therapy, then there is the selective estrogen receptor modulators, the so-called SORMs, which are drugs that bind to estrogen receptors in a different way than estrogen, and thereby confer some effects similar to estrogen, for example, but without the bone loss occurring. There are, again, as you see on the screen, a whole range of medications, and they may have changed in more recent times, but there are several other anti-resorptive therapies, which includes strontium, dianoximate, calcitonin, etc. A note on medical treatment: both anabolic and anti-resorptive treatment with a proven anti-fracture efficacy and acceptable safety are available for the prevention of the next fracture, which is the aim, really. However, vertebral fractures are still often overlooked, and therefore the patients are far too often not offered these treatments. There is the treatment of vertebroplasty, which involves the application of methyl methacrylate to the fracture, is considered very successful in the stabilization of the fracture, as well as quick pain relief. A possible alternative is to inject calcium phosphate cement into the vertebral fracture. Then there is the procedure of kyphoplasty. Balloon kyphoplasty is inserted to create space in the fracture vertebra to reduce its height before the balloon is removed and cement is placed. So those are the two that, then there is the whole range or role of spinal fusion surgery. Major surgery needs to be considered for patients who are severely impaired, patients with who have lost walking ability and with a neurological compromise. There are controversies on the surgical procedures, which include anterior spinal fixation, combined anterior and posterior procedures, and posterior procedures involving wedge osteotomies. And again, a whole range of surgeries are offered. Patient points to consider before performing such surgery are the patient factors, obviously, localization of compression, severity of osteoporosis, and the general medical condition of the patient. The role of the surgeon is equally important. The surgeon's experience in performing these various surgical procedures may be needed, which are needed for osteoporotic vertebral fractures. As I mentioned, they include a whole plethora of anterior, posterior approaches. So the conclusion is that osteoporotic vertebral fractures present a challenging entity. There are several approaches to management that have been developed, including pain management, medical therapies for prevention of further fracture, percutaneous procedures, and open surgical interventions. Careful evaluation of each individual particular patient is obviously necessary before recommending a particular approach. The patient factors, nature of osteoporotic compression, neurological status, surgeon's experience must all come into play when considering the best approach for an optimum outcome. So I think that's the run-through of the sacral and osteoporotic. As I mentioned, I'm happy to answer some of those questions, but not all, because I'm not a particular expert in the surgical side of sacral fractures. Thank you very much.
Well, thank you, Mahmood, for such an elaborate talk on a difficult topic, and moving on from skull base anatomy to the sacral fractures and osteoporosis and everything.
I'm glad it
it was a head to sacrum, not a head to toe. So
Can
I'm
I
glad
make
for
a
that.
comment? Just a comment about these osteoporotic fractures. It's really very common because of the aging of the populations. And we recommend not to use the word kyphoplasty. We must instead use balloon vertebroplasty, first of all this. Second, we must try not to make open surgeries in osteoporotic fractures patients. The only indication is the neurologic compromise, which is quite rare in osteoporotic fractures. Second is significant instability. If there are two of those, and there is a classification, you may have heard this, in the upper stages, we can make some open surgeries, but since the whole spine is very soft, then it's not easy and it's open to many complications. So we must try to be as conservative as possible. Thanks a lot. Great talk.
Thank you, Dr. Mahmood Qureshi, for that talk. Our next talk will be on complication avoidance in adult deformity surgery, which will be given by Dr. Mehmet Zaleli.
No, we will make his talk. Yeah.
MIS okay.
Yeah.
Yes, we can ask it. Our next talk will be given by Dr. Nico Lipiv on YMIS surgery.
So the short answer to why MIS surgery is because it's good for your patients and it's good for you as well. I'm going to try to convince you on that. Can we start that? Yes. Okay. Okay, so this is just a quick flash on how the surgical techniques have been developed. And you can see that the minimal invasive techniques we are developing only since 2000. And you can see on that graph that previously on every single open surgery now we have a couple of MIS options. So minimal invasive surgery is becoming more and more popular, and it makes sense. And I will try to convince you why. This is surgery that will achieve the same goals of the open surgery, but with less damage to the collateral tissues. And this is the goal of any surgery, but the open surgery is achieving that to a lesser extent comparing to the minimal invasive surgery. So if I ask any of you if that is the end point of the surgery, which way you want your surgery to go, through this one or this one, I'm sure what's the answer. So minimal invasive surgery is a surgery that is achieving the goals of the surgery with less collateral tissue damage, measurable decrease of the morbidity, and faster functional recovery. And to greater extent, this is because you are preserving the muscles. And this is one of the keys for the success and the faster recovery of your patients. So if we go and research the literature, now there is extensive body of information that will tell you that the minimal invasive surgery is reducing the complications that you would have, like infection rates, like blood loss, like the pain postoperatively, reduces the need of instrumentation in many cases. It is cost effective. After you do enough surgeries and you become fast and efficient, it appears to be more effective. And also the long run is more effective, comparing costs and readmissions and hospital stays. Patients like it. A lot of patients now ask for that, and they specifically ask for this surgery. And if you cannot offer that surgery, they might go somewhere else. And also that surgery will allow you to operate groups of patients that you would not think of operating before. So overall, it is a good thing to have in your armamentarium, and it's good for you, for your patients' recovery, and for your satisfaction as well. So, of course, there will be, but yes, Minimal invasive surgery is good, but has long learning curve, but has a lot of radiation exposure, especially if you are starting to do it and you rely a lot on the x-rays. The technique acquisition in your hands could be challenging. Screw placement precision, some people report on inadequate decompression, inferior fusions, nerve roots damaging. Yes, to an extent this could be true, but there is ways to overcome that. So, steep learning curve, yes, we know from publications and from our experience that indeed the minimal invasive techniques, they have steep learning curves. And what is steep learning curve? There is a publication from Pereira and group, Paulo Pereira, some of you might know him. He's been here a few times, I think. He published a paper that suggests that if you do 50 cases, minimal invasive TLIF surgery, then you're achieving about 90% of your milestone. So this is somewhere here where you are. So if you, in order to achieve from 90% to 100%, however, you have to double that. So you have to do another 50. So at 100 cases, roughly, you already start understanding something of that surgery. And then the point is that every time you want to go on another level, you have to double your cases. And that is why we talk about steep learning curve. So another pitfall of the minimal invasive surgery is radiation exposure. Yes, there will be more radiation exposure comparing to the old techniques. However, if you educate yourself properly and if you do the X-ray machine appropriately, you can significantly reduce your risk of radiation. And that is visible from many publications. That is a very important publication, for example, that suggests that if you step away from the patient body only 20-30 centimeters, that will decrease your radiation exposure significantly. That means that instead of using your hand to hold the instrument, you have to hold in the instrument with an instrument, or ideally, let's say if we're talking about Jamshidi needles, you try to dock it and step 20-30 centimeters back. That significantly reduces your exposure. Also, the other thing that you can see from that picture is that the site that you stay comparing to the source of radiation, the source of radiation is this one. If you stay towards the source of radiation, that will significantly increase the load of radiation that you will get. So when you're operating, try to stay on the site contralateral to the source of radiation. Two things with radiation protection. Try to be 30 centimeters away from the body when you ask for X-ray, and try to be on the contralateral side. So, expensive equipment. Yes, special equipment is important and it's necessary for some of the techniques that we do, but we can, if we have a bit of a thinking out of the box, you can overcome that. So, for example, I can show you that this was my first operating table that I was using for minimal invasive TLIF surgery, and I managed to adapt it so I can do minimal invasive TLIFs. This is the first retractor that I was using before I have these fancy retractors that are available now. However, I will show you that I have returned back to this retractor. This is McCulloch retractor, widely available in most of the units in UK at least. It's cheap and efficient, and I'll show you why I'm using that retractor again. So this is the settings. When I use the retractor, I use on one side the blade, And I have different sizes of blades. The longest is 10 centimeters, and that allows me to operate big people. And then on the outside, I use the hook, and this is what I see. This is what I can see with that retractor. Insufficient decompression. You can see that with this retractor, I can just tilt the retractor a bit, and I can decompress the central structures, and even I can go contralaterally. You can see here, this is the cage, this is the exiting nerve root, this is the traversing nerve root, and this is the central dura. So I managed to decompress all that with this approach only. So you can do, you can put bigger cages with the same approach. So you can do many things. So the technique of the minimal invasive surgery is important, and by practicing that type of surgery, your technique will improve, and it will be possible to do things that you would not be possible to do in the beginning. This is a good example. What happened with me, I used this technique with 4 positions for the Jamshidi needle, and the accuracy is pretty good. The last screw that I have revised is, I think, back in 2017. I haven't revised any screws recently, thankfully. That technique is giving me pretty good accuracy. Also, you can see that with the number of the cases that I have done, my time to put screws has dropped, and the X-ray exposure also has dropped. So, insufficient fusions. On that side, you can see the standard that we are used to see when we do ACDF or corpectomy, for example. You can see how good the end plate is cleaned. Now, I spent in that disc about 10-15 minutes trying to clean it nicely, and then I decided to put an endoscope to see how clean is the disc, and you can see how clean is it. Not very clean. So it is really not about the technique, but probably is about how you apply the technique. So if you clean the end plates appropriately, you will have good fusion, and the other way around. If you don't clean the end plates appropriately, you will not have good fusion. And there is different things that you can apply to improve your fusion. So this is something simple that I have started doing lately. This is sputum trap. This is available in every ICU, and it costs very, very small amount of money. So you can attach it like that. So you can attach your suction to the sputum trap, and then you can attach another short tube to your suctioning end on the other side. And when you suction, when you're drilling, that container is collecting the drill dust, and then you can send this back in your cage. So that's what you're getting. You put it on a swab, you squeeze the swab, and then you will have this pure bone that is very good. Sorry, you will have this pure bone dust that is very good, and that will increase your fusion rates. You can put it in a cage, you can put it inside the disc. So part of it, I collect pretty good amount of that, and part of it will go in my cage, and part of it will go in the disc, whatever is left. And I usually drill with that matchstick. If you're drilling with diamond, the particles are too fine and they are burned, so that's not gonna give you this. It's gonna give you nothing. So another problem with the technique, for example, is nerve root at risk. In the beginning, when I started my technique, I started using pedicle to pedicle decompression, and then later on that evolved to only partial removal of the facets. So the cranial facet I would remove only partially, and like that I will create an overhang that will protect the nerve when you later on start drawing different instruments inside. I tried with some key wires here, that was unsuccessful, but this is good enough technique. And this is what I do. Instead of doing the full decompression, I do 1, 2, 3, 4 cuts, and like that I do only partial decompression. And you can see here the overhang is protecting the nerve root when you draw instruments. This is how it looks like on the X-ray. When you start drawing the instruments, you can see that with the hook I'm checking if I have the overhang, and you can see how the nerve is located cranial to your instrument, so there is enough space for your nerve to be protected. Another thing that I started using is when you do the partial decompression, the cage actually is opening for you, so even if the disc is very collapsed, you can do a little bit of a osteotomy here to increase the chance of the cage to slide in and to open the disc for you, and the nerve is just displaced and is not damaged. This is how it looks like in my practice. And the last thing that I will show you is why I returned to that retractor, because unlike the tubular retractors, that is providing more freedom, left and right, back and forth to draw your instruments. And you can see that's what I see when I apply that retractor. That's inferior articulating process, that's superior articulating process, that's the facet, that's the TP here and TP here. So this is the key wire. And a simple calculation can show you that if you calculate, this is 2 centimeter blades, and then I can open even 20, not 25. So if I open 25 millimeters, the calculation shows that the footprint is as big as 18 millimeter tube. And if I open 20 millimeters only, which most of the cases what I do, it's 16 millimeter tube. So at the minute I am calculating and I'm checking the creatinine kinase release after the tubular retractor and this retractor, and the results are similar. Basically, this one is providing you similar results as with the tubes. And I think that was it. Thank you. I hope you're convinced that MIS is good, and that's my answer.
Any questions? You said in your presentation that you don't use neuronavigation for MIS instrumentation. Is that right?
So okay. So if I have a straightforward case, I probably will not use it. I'll tell you, if you were here in the morning when I was talking to Corina when she presented the robotic, so I have access to Excelsius robots, and let's say if I am doing uncomplicated case, with the Excelsius will take me over 2 hours for a single level non-complicated TLIF. If I am doing that what I just presented to you, I'll be way below an hour and a half, so it is way faster. My time is precious, and also patients' time under anesthesia is precious. At the minute, there is research that suggests that every half an hour that your patient is under anesthesia, you are doubling the risk for complications. So operating fast and fast turnover of your patient in and out of anesthesia is important for your results and for the complication rates. So if I can do something faster, I tend to do it faster. But I don't deny the value of the navigation systems and the robotic systems. There is cases that they are so degenerated. The last case, for example, that I did was so twisted and degenerated and osteoporotic, so I probably wouldn't have done it the way I did it without navigation. So navigation has a value, but I'm not obliged to use it. I don't feel obliged to use it for every case. And furthermore, I was talking to a person from Minnesota, from States, who does a lot of endoscopic TLIFs, and he's done already thousands of this for many years, and he said to me that he went back to only X-ray because he sees the same thing. He's faster with the X-ray because these robotic and navigation systems, they take time to set up and sometimes could be slower. I think it's a case by case and it's decision based on your own experience. I don't say no, please don't use the navigation. The navigation is important, definitely is helpful. And there is cases that you will not be possible to do the navigation. But for the straightforward cases, if you feel you're faster without, you probably can skip it. Thank you.
Thank you, Dr. Peev. Our next speaker is Dr. Mehmet Zileli, who will be speaking on complication avoidance in adult deformity surgery.
Dear friends, it's my pleasure to talk here on the complication avoidance in adult deformity surgery. Actually, the deformity surgery are full with different type of complications. And adult deformity may have more complications than adolescent idiopathic scoliosis surgery. In adolescent idiopathic scoliosis surgery, neurologic complications you can expect, instrument failure, pseudoarthrosis you can expect, and crankshaft phenomenon. But the total amount of complications is approximately 5 to 15%. However, in adult spinal deformity, it is about 45%. Because those patients have osteoporotic spines, they have more systemic problems, comorbidities, and their spines are somewhat rigid than adolescents. Pseudoarthrosis rate is quite higher in those patients, and the reoperation rate is about 36%. 1 out of 3 patients of your group will have some revision in the future. Especially, there are 2 types of adjacent segment disease. One is the distal junctional problems, which is more common at L5-S1 level. Because of that, we must try to avoid the L5-S1 level. If we add L5-S1 level, we must then make interbody fusion at there. Sometimes we must add iliac screws. And complications by long fixations, including S1, are also high. Pseudoarthrosis rate may be diminished by adding iliac fixations. But in spite of that, there may be some other adjacent level problems, like sacral insufficiency fractures, which Dr. Mahmoud Qureshi has nicely described us, or some hip problems. The proximal junctional kyphosis is another problem which happens quite often in long fixations. Those surgeries are very bloody surgeries, and we can avoid such bleeding by MIS surgeries. Yes, we must try to apply more MIS surgeries in adult deformities. To avoid non-union or pseudoarthrosis, there are mainly 2 types of techniques we can use at those ages. One is the interbody cage and graft, the other one is the osteotomy. But to get good results, we must have 3 concerns. One is the sagittal balance, degree of osteoporosis, and premorbid diseases. This study has compared 2 types of surgeries in sagittal deformities and sacrum to upper thoracic, sacrum to lower thoracic fixations did not get much differences. What about osteotomies? Osteotomy is a good addition to our deformity surgeries. It is not very new. Currently, we are applying it more often, but it is a very complicated surgery. As you know, there are Schwab's osteotomy classification, and there are 6 different types. First of all, if you look at 1, 2, and 3 grades, you don't need to place any cages in between the bodies. However, in 4, 5, and 6, you must place also interbody cage and grafts. And you must finish the surgery under some compressive loads. These type 1 and type 2 are not very bloody. You need to make some facet resections, some posterior osteotomies only. You don't enter inside the body or the disc space. However, type 3, 4, and 5 are very bleeding, especially epidural veins bleed a lot. This so-called pedicle subtraction osteotomy, type 3, must end with some closing at the backward. And if you don't make a good carpentering, so then you will not provide a good compression of the bodies. You may have non-unions. As I mentioned before, you need to place cages ventrally in those cases. As you know, Smith-Peterson or Ponte osteotomy provide 10 to 15 degree reduction in each level, so multiple levels are necessary to correct a kyphosis at 45, 50, 60 degrees. However, pedicle subtraction osteotomy provide 10 to 30 to 35 degree reduction in each level. If in an osteotomy case with multi-level fixations, approximate amount of bleeding is about 1,000 milliliter to 1,500 milliliter. A patient who cannot tolerate that in the older ages, it is possible, you will get hemodynamic problems, even cardiac arrest during surgery if you don't be very cautious. These are the complications of osteotomy: blood loss, neurologic deficits, dural buckling, over-distraction, wound problems, CSF leakage, non-union, coronal and decompensation, and the general complications like delirium and some other systemic problems. This study is involving 140 patients with PSO, pedicle subtraction osteotomy, and saying that mean blood loss was 1,500 milliliters. Reversible complications in 15 cases, irreversible complications in 3 cases. This study involved 423 cases, and total measured complications are 42%. In the older ages, in case of 2 osteotomies and thoracic osteotomy, the complication rate has increased. As you know, a pedicle subtraction osteotomy at the thoracic level must be involving the spinal cord, so then the neurologic complications may be higher. Because of that, many surgeons try to make the osteotomies at lower than L1 level. This is the Lancaster department and 4 other centers. Complication rate was found 49%, and blood loss was 2,120 milliliters in 3CO level. Neurodeficits were about 10%. In that series, Schwab type 1 and 2 osteotomies, complication rate was somewhat lower 28% because it is posterior osteotomies only. In spite of that, it's quite higher, the complication rate. And this study is very important if you are correcting sagittal deformity for the monitoring. You may have more incidences, monitoring incidences during surgery if you are correcting a kyphosis than if you are correcting a scoliosis, coronal deformity. So the incidence of intraoperative monitoring changes have been found 26% if you are correcting a sagittal deformity. Mechanical failures are also important, and if you make lower osteotomies, the mechanical failures are lower than upper osteotomies. Surgeon's experience is also important. In case of inexperienced surgeon, the complication rates is about 44%. However, in experienced end, it decreased down to 28%. Neurologic deficits are also higher in non-experienced hands, 22%, than in experienced hands, in 4%. What about orthopedic surgeons and neurosurgeons? There is not much difference in neurologic complications. However, the neurologic surgeons, the costs of surgery are somewhat higher than orthopedic surgeons. They have done, they have used additional instruments like navigation, robotic assistance, and they have done surgeries in older ages than orthopedic surgeons. Buckling of the dura is another issue. In type 1 and 2 osteotomies, there is no buckling. However, at type 3, 4, 5, there may be bucklings. Tension on cord may be reduced more quickly with VCR than PSO, pedicle subtraction osteotomy. If you see that there is a significant buckling, then you must make additional laminectomy at that level. This is a case report that those authors have done by opening the dura, how much the buckling is. And then they have, after durotomy, the spinal cord was visualized without kinking or buckling, and they have described how to prevent the buckling. Postoperative dysesthesia may happen not very often, but it is because of spinal ganglia squeezing, compression of the spinal ganglia, or spinal cord itself. So there is no neurologic deficits. However, those patients may have severe dysesthesic pain in the lower extremities. This is one of the cases that the postoperative dysesthesia have been described. Results of osteotomies. Fusion rate high if osteotomy closed posteriorly, stable fixation and sagittal restoration. Patient satisfaction is high if there is no complication afterwards. Patient satisfaction low if wound infection, coronal imbalance, and poor family and social support of the patient. Patient motivation is important. If not motivated much, if the patient is somewhat frail, it's better not to make osteotomies or big deformity surgeries. Surgeon should be prepared the patient and patient family for the worst options, and you must inform the patient before surgery. And I will try to tell that we can probably revert that the geriatric, by aging, the people becomes more kyphotic, we can revert it. But with a good planning and with a good knowledge of how to avoid complications of deformity surgeries. Thank you for listening to me.
Thank you. If there are any questions from the audience.
How about these new various fluids or glues that we use to stop bleeding, hemostatic agents? Do they not work when we are having 1.5 liter blood loss? Yeah, you can use them, although they are somewhat expensive, costly. They have value, I guess, but I cannot use them much because they are quite expensive. Yeah. This was I was using autotransfusion, but those patients do have again significant decrease of hemoglobin levels 1 day or 2 days later, because those re-given blood is hemolyzing very quickly. I have done it very often when I was in the uni hospital, but I didn't find it very useful.
Instead of greens, we can use the transaminase acid.
I use it routinely. Another thing, if you think that if you are operating, especially in the younger patients, you can get blood before surgery and then give during surgery.
Thank you.
So may I just short comment? So there was, tranexamic acid is very helpful, and it's known to reduce the risk of bleeding and not increase the clotting. So you can give a couple of grams, 3-4 grams, you can give without punishment. There was one of our surgeons, orthopedic surgeons, who used, I think, 15 vials of Surgiflow, which then he was criticized. He was doing major deformities correction surgery. 15 vials of Surgiflow, 150 pounds per vial. And so you can calculate how much is that. But he justified that. He was criticized, and he said that the blood loss that he would have had is way more expensive comparing to extra 2,000 pounds for that procedure.
One comment about the monitoring. There was a question to Nikolai about monitoring. Actually, I think that there is indications of monitoring. You cannot monitor all spine cases. It's useless because you don't get any result of that. The main indications is if you expect neurologic compromise during surgery, those patients can be monitored. Like deformity patients, like I have shown here, especially osteotomy cases and intramedullary tumor cases. Others, it's useless.
So, Mehmet, wonderful talk. I just have a comment and a question from you. Monitoring. How often do you have false positive monitoring?
Yeah, good question.
So we had we did a thoracic MIS case, and monitoring improved.
Yeah.
Intraoperatively, motors were improved.
Yeah.
But the patient had definitely worsening paraparesis. So. This rarely happens, but I've seen this now a couple of times.
False positivity is not a bad thing. False negativity is bad. Very, very worse occasion. If there is a false negativity, then you are thinking you are safe during surgery, but postoperatively the patient has paraplegic. This is a catastrophe. But false positivity can prevent your operation. For instance, with false positive responses, you can stop removing intramedullary tumor. Or you can make less correction during an osteotomy. But to diminish false positivity, the neurosurgeons must be aware about the neurophysiologic potentials and the conditions of the neurophysiology. And we must have in our basic education a good electrophysiologic education, training. We can prevent it by this.
I think two main benefits of monitoring is that you can do things quickly. You are reassured, and you know you're doing the right thing, and that's you're just reassuring. Second thing is, it's at least it's the warning, and because that you stop, you're not going to lose anything instead of causing serious problems.
Yeah, but you know, when you have the baselines to start with, the motors are low. They are like 40%, right, on the threshold. And when you get improvement on that, they go up to 60, 70, and still you have paraparesis. That's the first time I've seen.
I've seen the patients like that lately, but I think obviously issues that.
And that makes me wonder why are we monitoring then? This is like happened to me twice now.
But I think neuromonitoring is helpful only in the hands of the trained neurophysiologists. You have to be really trained. Yeah.
Thank you, Dr. Zalali, for that talk. Our next speaker is Dr. Yaya from Turkey, who will be speaking about odontoid fractures, current concepts.
Good afternoon, and thank you for kind invitation again. Yes. I want to talk about the current concept of the odontoid fractures. And odontoid fractures, between 20% of the cervical fractures, and most of them is type 2 fractures. And sometimes these fractures potential spinal cord injuries. Because of that, it is important and can lead craniocervical deformity. And we know odontoid process blood supply is low, and because of that, necrosis at fractures, and we can see necrosis, and most of them is elderly patients. Because of that, necrosis is important, and sometimes it can be fusions, and fracture shape is important for odontoid fractures. We use this classification. All of us know this classifications. Type 1 is superior of the odontoid, and type 2 is base of the odontoid here, and type 2 to corpus. And we know fracture pattern related with prognosis, fracture type and extensions of osteoporosis again affect the prognosis, and height of the fractures distance is very important. Because of that, there is some classification again, Grauer classifications. In Grauer classifications, type T divided 3 parts. Type 2 are base of the here, and type 2B is the again fracture line. It starts superior to inferior. Type 2C, it starts fracture line inferior to superior. Each one is different treatment method, and we use now in clinically frequently we use these classifications. And we know some of the odontoid fractures need non-surgical treatments. We use cervical collar Minerva like that. And when we use Grauer classification type 1, 2A, and 3, we use hollow Philadelphia. Type 2B, we made anterior secret fixations, and type 2C, we use posterior fixations. And this is our patients. There is a fracture line type 2A, and we use only hollow, and after that we get fusions. And type 2B, there's a fracture line. It starts from superior to the inferior. We use only odontoid secret for these fractures, and we make anterior approach. And for example, this patient is suitable. This is Grauer classification 2B, and this is our starter point. And we can get fusion for only one script, but this is important things. There is a pressure transverse ligament. We check always to do MRI with transverse ligaments is safe. We can use anterior approach. And type 2C, posterior fixations, this is some of the fusion rate is low in anterior fixations. Because of that, some of the patients need the posterior fixation, for example, osteoporosis patients. And sometimes there is a listhesis, and we can use again this posterior approach. And Grauer type 2C, this means this fracture line start inferior and go to the superior. And again, this fracture type need posterior approach. This is posterior approach. This is our cadaver studies, and this is all of the spine surgery use posterior approach, C1, C2. This is lateral mass. This is vertebral artery. We use C1 secret to do lateral mass, and this area is pedicule of C2, and we use C2 pedicle secretes. And this is an example. This is type 2C fractures, Grauer type 2C. This is suitable for posterior approach. And there is another thing, there is a listhesis, some of the case, but this is not listhesis, but this only shape of the fractures need the posterior approach for these patients. And this patient has atlantoaxial dislocations. This patient is type 2B, but there is a transverse ligament injury in this patient's shape is suitable for anterior approach, but this patient, if we made anterior approach, we can't touch to the part of the odontoid. These secretes go to the empty area. Because of that, in this patient, if there is a transverse ligament injury, we need to do make posterior surgery again. Again, this is different patients. This patient's type 2, but this patient's, we give the cervical color. He didn't want to do any surgery, but then is changed fractures. These fractures again, type 2B, but again there is an anterior C1, C2 dislocations. Because of that, and we know this patient has transverse ligament injury, so we made again posterior approach these patients. And we know osteoporosis patients, most of them elderly patients, non-fusion rate is very high. So in this patient, if there is a osteoporosis type 2B or 2C or 2A, we make some posterior approach. And there is a different things again for odontoid fractures. Some of the authors support these techniques. Some of them in odontoid fractures, young age, they make only posterior approach and they don't use any fusions. And 1 year later, they removed the secretes, and there is no any neurological deficit, and all of the patients safe. They write in the paper, but we don't use fusionless surgery. And there is again a problem for odontoid fractures. Some of the elderly patients, if there is a osteoarthritis here, if we use anterior secrete, this secrete can break in the futures. Because this osteoarthrosis, make compression to the screws and get instrument failure. Because of that, we checked the CT because before operations, if there is a osteoarthrosis, odontoid to the C1 or inferior of the clivus, like in here area, we use again posterior approach. And when we look at the anterior and posterior approach, anterior increases osteosynthesis as it connects to the direct fracture lines and reduce C1, C2 loss of motions. Because of that, we select this anterior approach, and it takes maybe 1 hour or 1.5 hours. It's easy. And posterior approach is different. If we need the reductions, we select again posterior approach. If there is a revision of the odontoid fractures, anterior revisions, sometimes we select again posterior. And C1, C2 limited motion of the cervical area, but this approach has high fusion rate, and we should know posterior techniques. Again, anterior short surgery time, and we should know biomechanics, because biomechanics is very important. In posterior approach, biomechanic result is very strong support this approach. There are a lot of finite element analysis study for support to the posterior approach. When look at the complications, we can see dysphagia in anterior approach and pneumonia. We can't see our cases, but we can see dysphagia because of the accartations. And in posterior approach, wound infection and pneumonia we can see. As a conclusion, in anterior fixation indications, Grauer type 2B, and if patient transverse ligament preserved, we can select anterior approach. Young and mid-age patients, we can select anterior approach. If fracture lines are in the same plane, we can anterior approach. In posterior, if patient has osteoporosis, anterior is non-reducible. If fracture lines are not in the same plane, if there is a C1, C2 listhesis or Grauer type 2 shape of the fractures, and elderly patients, we can select the posterior approach. Thank you.
Yeah. Are there any questions? What about not operating a patient with odontoid fracture? There are some instances, especially in the elderly.
Yes, non-operated. Yes, sometimes we get non-fusion. We talked Professor Serdar before the talkings. Sometimes if patient is very, very elderly, we have some patients over the 90 years old, they don't want to do anything. We send to them for cervical color. They don't want to do hollow, and we observe them. Some of them is non-get fusions, but some of them get fusions to do with anterior of the C1s. There is no problem in these patients. Is transverse ligament preserved? We can't see sometimes any problem. But if there is no, if there is an injury in transverse ligament injury in these patients too, it will be dangerous for them because it makes spinal cord injury. And we say to them, if transverse ligament injury, we should make operations. We offer to them.
Yeah. And there are some series, in case you apply halo, you have more complications than making a surgery you may have. Are there any questions? Yeah, please.
The biggest classification system for the odontoid fracture is the Anderson D and so is it obsolete now, or we are following the Grower system altogether?
Yes, we use Grower system we know Anderson Alonso system is a very useful system. If there is a complicated fractures, we look at the Grower systems because Grower systems have to ask for surgical styles. Sometimes we use anterior and posterior, but in Anderson Alonso systems, patients need surgery or conservative therapy. Only have to do us like that. Because of that, in our practice, we use Grower systems.
Yeah, one more, yeah, please. Please talk to microphone.
Okay, how do you assess the transverse dental ligament? Just on MRI or just some ADI distance on flexion extension X-rays?
If there is a C1, C2 listhesis, I show some cases, there is a C1, C2 listhesis. This means there is at the same time transverse ligament injury. So we say this is instable and we should make posterior reductions. And we can only make posterior reductions. We put C1 screws and we take to the C1 to the posterior. We put rods and we take to the C1 to posterior. And if there is no any listhesis, again we check to the MRI. If transverse ligament injury, there is any transverse ligament injury, we always look at the MRI by helping the thin MRI sequence, 1 millimeter sequence. We checked the all of the area. If we skip
and axial images,
and axial, yes, in axials.
Yeah. You can see in axial MR images. And you can suspect a transverse ligament rupture if there is neurologic deficits, which is quite uncommon in this region. Second, if there is significant translation, you can suspect. But then you can be sure with the good T1, yes, T1 axial thin images of MR.
Thank you.
Thank you.
Thanks a lot. Great talk. Thank you.
Thank you, Dr. Yahya. Our next speaker is Dr. Zuhair Shakir, joining from Iraq, who will be speaking about the intradural spine tumor management and surgical results. Dr. Shakir.
Assalamu alaikum. Good afternoon, everyone. I would like to thank Professor Salman for his by name and by the name of Iraqi participant for his kind invitation and hospitality. Thank you very much for you and your organizing committee. I will start with the topic of intraspinal tumor. I think this is strange about it, to talk about it. This is the odd, maybe. The classification of intraspinal tumor, you know it, I guess, the intraspinal extradural tumor, which is mostly secondary or primary in the bone, and intraspinal intradural tumor, both intramedullary and extramedullary, which we talk about them. Actually, the vast majority of these intradural tumor is not more than these, maybe. There is a very rare condition, astrocytoma and ependymoma as intramedullary tumors, and the schwannoma and meningioma as extramedullary tumor, maybe hemangioblastoma. We should differentiate these tumors actually from some lesions, especially MS and inflammatory and infarction, and actually nowadays, I guess there is a lot of advances in MRI and other investigation that can distinguish these tumors from these lesions. And sometimes, in rare occasions, we may need a frequent MRI in follow-up to say this is an infarction, sometimes to differentiate from, for example, astrocytoma. The epidemiology represents about 4 to 20%. Astrocytoma and ependymoma is, as I said, it is about 80 to 90% of intramedullary tumor, while meningioma and schwannoma represent also 90 to 80%. 80 to 90% from extramedullary tumor, and you know that this is the distribution of the tumor. Intramedullary is more in maybe 40% in pediatric, and extramedullary is more in adult, and the extradural one actually 50% or 50%. This is the distribution of clinical symptoms of the patient: pain, motor weakness, and sensory deficit usually more predominant in intramedullary lesion, while pain more in extramedullary lesion. And actually, usually it is long history, and mild clinical symptoms might be without neurological deficit, and actually the dysesthesia is go more with the intramedullary lesion. The preoperative imaging, of course, the most important one is MRI, and because it is narrow, it will narrow the differential diagnosis, guide to surgical operation. Sometimes we need CT and CT myelography in some occasions when there is a metallic, for example, something metallic in the side of the body. And X-ray, actually, it is very important to evaluate the sagittal balance of the patient. Even still, we have importance of sagittal balance even in some times of a tumor, because you know some tumors need to excise a lot of segments, and then to preserve the sagittal balance, one of the important concepts in modern treatment of tumors. The angiography is also important in vascular tumors, especially in angioblastoma. And you know, this is the features, I guess most of us know it, that astrocytoma is more in pediatric. It represents about 40% of intramedullary tumor, the peak in adult incidence in the third decade, and an increased incidence with neurofibromatosis type 1. Actually, most of it is low-grade type, and the anaplastic represent 25. And if we guess that this is a high-grade astrocytoma, then better not to touch the patient, because it is a very, very high morbidity in high-grade glioma if it is present. The astrocytoma appears as iso-intense to hypo-intense in T1, hyper-intense in T2, and actually it may take some enhancement, while ependymoma, which is more intramedullary tumor, you can see there is a well-circumscribed tumor, and there is a cyst and syringomyelia, many of them, and there's satellite distribution usually of cyst above and below, with rare calcification, and the average length is more than maybe 4 vertebrae or more. The angioblastoma is more rare, they take more contrast enhancement, and there is maybe relatively a big cyst in relation to the size of the tumor, and may associate of tortuous vessels, and actually arachnoid cysts appear clearly in MRI. When you pass to meningioma, which is extramedullary tumor, usually you know it, iso-intense with homogeneous calcification, commonly in thoracic region, and get female predominance as in brain tumor, while schwannoma, it is also solitary usually, there is no significant sex predilection, and you can see it as also in a common age of 40 to 60, and male predominance, hyper-intense in T1 with contrast enhancement. Oh, this is one, you can see this myxopapillary ependymoma. This is actually very, very extensive tumor. We did operation to her, and this one of the cases with partial excision, because you see a horrible tumor. It's almost extended from L1 to all sacrum. So the differential diagnosis of film traumatic tumor, myxopapillary ependymoma, schwannoma, neurofibroma, and others. And when we talk about surgery, we should consider the following. Local tumor control is very important, and anyway you can control the tumor excision during the operation is important, whether to use CUSA or excision of the tumor. Then the spinal stability is very important. If we if you want to excise more of the facet, for example, then you should consider fusion surgery, or then actually, nowadays we do have either the traditional laminectomy, for example, or we have a minimally invasive spine surgery, MIS, to excise the tumor. So both of them, you should consider the stability and the balance of the patient during the operation. Neurological function should be considered, especially in the intramedullary tumor. And actually, we use the intraoperative monitoring device in all intramedullary tumor, and sometimes in some extramedullary tumor in revision surgery, for example, or when the tumor, they extend more anteriorly, maybe. So the decision type is the operation type, which operation you should do, anterior or posterior, the time of the surgery, when to stop is very important, because sometimes astrocytoma, we cannot excise all of it. We can do partial excision for it. If we go more steps on the operation, the patient may get high morbidity rate. And the technical, also we should have the attention to arachnoid adhesion, anterior location of the tumor in order not to injure the anterior spinal artery or to retract cord more, and the number of lesions, and then the other lesion. The preoperative principle is laminectomy or laminotomy, full extent of the tumor. Facet, if we need, we should excise it, and then the dural removal of the meningioma. And okay, we should consider laminoplasties in some cases to reconstruct the lamina and preserve root. I will go to our study in Mosul. Actually, it is from 2019 to 2023. It is a single surgeon study. It's about all records. It's taken from the same center, and we include all intradural, and the result was 28 patients, male and female, may be equal. 20 to 30 years is the maximum of our patients. And there is more extramedullary tumor, actually 20 patients and 1 intramedullary tumor. And you can see thoracic region is predominantly, and then lumbar, and after that the cervical region. Most of them, they get a limbs pain and motor weakness, actually. Some of them get backache. And the schwannoma is the vast majority of our patients was schwannoma. And gross total excision was in 25. Actually, we subtotal in 2 cases, and biopsy in 1, which was astrocytoma. And there is a deterioration of 3 patients, while 24, they either improve or still in the same motor function after the operation, and 1 not change their deficit. In our study, extramedullary tumor was the vast majority. Microscopic total excision had achieved in all extramedullary tumors with improvement of neurological status. The total excision of the ependymoma achieved in 5 patients with subtotal in another 2. Preservation and improvement of motor function in all patients except 3. 2 of them was ependymoma had partial recovery, and the other one had lipoma and had improvement motor function but sustained urological dysfunctioning. 1 sustained deficit in astrocytoma, he did not change, and urological dysfunction observed in 3 patients. 2 of them transient and 1 permanent. The backache and leg pain, this appeared in all patients. There was no CSF leak, no wound infection, and no significant bleeding. This is some cases of our surveys, and you can see this is a cystic schwannoma. This is a preoperative with 50 years old male with leg pain, and this is the MRI. You can cystic lesion in the L4, L5, and it was treated traditionally by laminectomy and excision of the tumor, and the patient improved. This is another case with mature teratoma, actually, at the level of L2L3S, and total excision also, and this is the picture, and this is ependymoma, exopapillary ependymoma, and also the total excision has been done by traditional laminectomy, and this is upper thoracic ependymoma grade 1, and T1 to T3 laminectomy with total excision, and this is the post-operative. And this is another one, ependymoma in the cervical region with 2-level or 3-level laminectomy and total excision of the tumor with post-operative images. Now this is I think this is with video. This is L4, 40 years female with leg pain predominantly and some paresthesia, normal neurological function. And this is the post-operative, and this is the video of, this is traditional laminectomy. Why? Not working. Okay. So this is traditional laminectomy with total excision of the tumor. Maybe yes. No. Yes, unfortunately not acting. And this is the other case with for 27 years old male with severe leg pain, actually right leg pain with paresthesia. And we do unilateral laminectomy, actually unilateral laminectomy with the total excision of the tumor. I hope this will, no. Also, yes. Open the videos. Yeah. So it is unilateral laminectomy and total excision of the tumor. And this is actually this come as emergency paraplegia, a young female, 27 years old, I guess, and We operate on her. Unfortunately, she get AVM. You can see, and we do ligation. She's get paraplegia actually, the sensory level at. I remember her about L1, and we ligate only the feeding artery, and we don't remove the nidus, intramedullary nidus. And actually, she did well. After 2 years follow-up, she returned to normal gait with mild spasticity. In conclusion, intradural tumors include a wide range of histopathological subtypes arising from spinal cord, spine nerves, meninges. MRI is a golden diagnostic tool. The mainstay in the treatment involves surgical resection when possible. Chemo and radiotherapy may reserve for residual or recurrent tumor. Surgical removal of the intradural tumor allows rapid decompression and stand as an effective means for symptom relief. Adequate exposure is very important to achieve a gross total excision. And I will show this slide. And for the spine diploma made by Middle East Spine Society, and I think it is a good chance to get this diploma with the good prices, I guess, for our countries. And you can find it in the website of Middle East. And thank you.
Assalamu alaikum. Sir, how do you approach for spinal stabilization in resection of larger spinal tumors? Spinal stabilization in resection of larger spinal tumors.
Yes, actually, if we excise the facet, if you disturb the facet, you need fixation. If there is multi-level, especially in cervicothoracic region, yes, you jump in the junctional zone. Yes, you may need to fix it. Otherwise, if you do a cervical laminectomy for more than 3 level, maybe, and the patient already have straight spine or kyphotic spine, yes, you need instrumentation for this patient.
It's better to do a laminoplasty and fix them with a...
Yes, if you cross the junctional area, then there is no laminoplasty, because you know most of these tumors is in cervicothoracic region, usually. So if you cross the junctional area, then you need to do fixation, cervicothoracic fixation. If you, in the cervical, yes, you can do laminoplasty.
Thank you.
Thanks a lot.
Thank you, Professor.
Good talk.
Sir, thank you. One another question. I just recently had one patient. He was incidentally found spine tumors. He didn't have any symptoms, but he had an intradural tumor. So my question is about the timing of surgery in spinal tumors if the patient don't have any symptoms, especially in cervical spine.
He is accidentally diagnosed as spinal tumor.
Yeah, incidental.
Which type of tumor?
It was intradural, looking like a schwannoma.
Yeah, if I can comment on this. If there is no neurology, no symptoms, you can observe a patient for a while. If it is, however, growing, you are sure that it is growing, you can suggest a surgery.
Yeah.
Well, the consideration was that patient was old age and he was also having a degenerative spine disease. So spinal cord was...
Right. If you don't think the pain the patient describing is not related to the tumor, you can observe. You can make consecutive films every year, probably.
And also, we do observe neurofibromas in neurofibromatosis.
Yes.
We do get many tumors. You don't operate on everything.
Actually, I get a patient, he presents with severe leg pain, young age, severe leg pain, but I see this is a mechanical pain. So the MRI showed disc prolapse, severe disc prolapse, and small schwannoma with his root. I only remove the disc and then let the patient on the observation every 1 year, maybe, or 2 years. So usually these small schwannoma, they grow very, very slowly. Usually, if it is caused neurological deficit, yes, you need. But if it is small and there is no deficit, I agree, we should observe it.
Thank you.
Thank you.
Thank you.
Thank you, Dr. Shakir. Our next talk is by Dr. Sardar Kahraman on unilateral approach to intradural pathologies.
Thank you very much. Before starting in my talk, so it's regarding the last question, it's not quite acceptable for the intramedullary tumors. So we are talking about the extramedullary tumors only. So if you see any intramedullary tumors, then you should go for surgery, okay? So I want to talk about the unilateral approach to intradural tumors. So unilateral approach for intradural tumors is coming from the experience of decompression based on lumbar spinal stenosis, actually. It's a minimally invasive technique, and you can consider as an alternative surgical approach, and you can preserve the biomechanical structure at least at the cross site. So you can do it in an extended laminectomy. So I want to start with the case. This is the 14 years old female. She had a congenital anal atresia, a back and right leg pain within 8 months. And also she had a neuropathic pain. On the other hand, she had a neurogenic bladder with the not preserved motor function. So MRI showed the conus tumor. Electrophysiology is almost normal range, but we didn't have a sphincter EMG preoperatively. Neurology revealed only the neurogenic bladder. MRI showed that peripheral contrast enhancements, hyperintense on T1 and T2 images. And also you see the absence of the signal on CT images. This is the fatty tumor. And our case solution, right L2-3 unilateral laminectomy, microsurgical resection nearly total under the fluorescent microscope. So also this is neuromonitoring guided surgery, including the sphincter EMG. This is the two-level unilateral approach. And you can see we can easily reach the midline, and we can open the dura with the arachnoid knife, and then we are using the stitching for the dura. And then we open the arachnoid. And this is the conus area. So that's why we should be very careful about the neurological deficit. It's very sensitive, eloquent area. So that's why very small myelotomy, midline myelotomy, and then we reach the tumor. You see we are removing the epidermoid tumor. You see the skin, adnexial follicles, hairy tumor parts. And this is not according to tumor size, myelotomy, because of the conus area. So otherwise we can have a kind of severe neurological deficits. And we do the irrigation during the surgery. And you see after the irrigation, still we have some tumor remnants in there. You see. And the final microsurgical manipulation is using the kind of hypophysis curettes, because the wall of the medulla is very thin and also very delicate, and you see how the medulla come into the operation site. So this is the final step of the tumor surgery. This is the closure of the dura. So follow-up, now we have a more than 5 years follow-up, and also she showed the neurologically improved in terms of the neurogenic bladder, neuropathic pain completely resolved, and only right moderate paresthesia at L4-5 level, and pathological results dermoid cyst. So this is the postoperative MRI. And when we are talking about intradural tumors, dural opening is also important. We can have a slide the Trendelenburg position to prevent the over-drainage of the CSF. We can use the arachnoid knife or simple surgical blades, hang up suture of the dura and arachnoids, and then cotonate pedis and strips is very important in terms of the protection of the medulla. There is you shouldn't do the direct suction, and you can use the spatial suction cannula. And myelotomy is the other problem. you always should use the dorsal median sulcus, which is actually not a sulcus, no arachnoid and no crossing axons in there, so it's very safe. So thin blade of collagen diameter consisted of the dorsal median sulcus, and you can easily recognize the myelotomy site as you see the dorsal sulcal vein. And also you should avoid bipolar coagulation if possible. If necessary, discontinuous myelotomy could be done, and PL stitching for medullary retraction could be done. So, and also some authors state that the PL closure is very important in terms of the prevention dorsal tethering and also arachnoiditis and also painful dysesthesia. But in my clinical practice, I never see any kind of complications. And also you see the fluorescent microscope to check the remnant of the tumors. This is the two-level myelotomy and also two-level unilateral laminectomy. After removing the tumor, intramedullary tumor, sometimes we are using this kind of hemostatic agents, intramedullary. It's fibrillar Surgicel, maybe you know it. And also we can do the PL closure like this. We are using the 8-0 or 9-0 suture with the PIA. And then you can easily close your myelotomy sites. This is the final view of the myelotomy closure. And then we close the dura. And this is I'm going to show you a couple of cases. This is the 42 years old female. 4 years ago, she had a biopsy, and then she had a radiosurgery, cyberknife. Since last 6 months, she had a progressive paraparesis, and we did the microsurgery again. You see the preoperative MRI, and this is the surgical video. We did 3-level laminectomy, unilateral laminectomy in cervical area. Even in cervical area, you can do it 3-level unilateral laminectomy without any implantation, without any biomechanical consideration. And we are doing the myelotomy again. You see how nicely polar cyst of the ependymoma is evacuated. And then we are extending the myelotomy sites. We are avoiding the too much bipolar coagulation. This is the 3-level myelotomy according to tumor size. And then we start to micro dissection of the tumor. This is the fluorescent microscope view of the tumor. You see how nicely tumor can be differentiated from the medulla. Here is the medulla. This is the tumor. And also you can easily recognize under the normal microscopic view because of the ependymal tissue is very clear. And we are removing the tumor piece by piece. And we can continue the microsurgical dissection with using the bipolar dissection. And again, as I mentioned before, the cotonate pedi, using the cotonate pedi is very important to protect the medulla from the suction damage. And a little bit go further. This is the fluorescent microscope check again. This is the previous biopsy sites. You cannot see properly the biopsy sites because of the granulation tissue in there. So that's why we need to use the fluorescent microscope to assess this tissue, whether it could be the tumor or granulation. And under the fluorescent microscope, we decided that this is the tumor, so that's why we are using the CUSA, because it's very hard tissue, granulation and tumor tissue together, and we check again under the fluorescent microscope. This is the final view of the intramedullary resection. And then we use the fibrillar Surgicel again, and also we close the dura later on. This is the postoperative 3rd month. You see the very good cyst resolution and also total microsurgical resection of the tumor. And even you see the very tiny spinal cord in there. Believe me, the patient is very good neurological condition. There is no neurological deficit. She can walk independently. She can have only the small paresthesis in their hands. That's all. And you see the control MRI, only unilateral approach at left side. So also we are doing the neuromonitorization routinely. This is the 42 years old woman. She had a progressive left paraparesis since last year, and MRI showed the T9 extradural tumor and surgery in prone position. We are using the total IV anesthesia because of the electrophysiological neuromonitoring. Right unilateral T9 and hemilaminectomy and T8-10 partial laminectomy. This is the microscopic view of the tumor. This is extramedullary tumor. We are dissecting the tumor and we are using the microsurgical techniques again. This is the microcissor, and we are dissecting the tumor from the medulla. And my assistant is a little bit help me. And then piece by piece, we are removing the tumor. But you see, at the beginning of the procedure, the left motor evoked potential amplitude responses very low. And during the surgery, and we see the right MEP amplitude responses, but continuing the surgery, and then we see the rising in left MEP amplitudes through the microsurgical debulking of the tumor. But on the other hand, we are doing the SSEP, somatosensory evoked potentials. It was almost normal. So we are using the nothing or all criteria when we are dealing with the intradural tumors. So that means we continue the surgery. At the end of the surgery, all MEP amplitudes improves. So this is another case, 86 years old male, paraparesis, and this is the preoperative and postoperative MRI of the patients. This is the hemangioblastoma. She had only the biopsy. Hemangioma surgery is a little bit complicated because of the tiny vascular structures. You have to consider as a kind of vascular lesion. So we are using again, fluorescent microscope. And this is the final view of the tumor. I'm passing. This is another case, pediatric case. Particularly in pediatric case, unilateral approach is very important in terms of the postoperative biomechanical deformity. So this is the postoperative MRI. So as a summary, unilateral approach, safe and effective minimally invasive method for the intradural pathologies. And also, you should have an experience for unilateral laminectomy. You can do it up to 3 levels. Avoiding the implantation provides us the very good postoperative imaging quality and also cost effective. You can discharge your patients 2 days later. Thank you very much for your attention.
Just a quick comment, at least in my practice, in my hands, sometimes with these intramedullaries, when they distort the shape of the cord, I find unsure where exactly the midline is, and I use spinal cord mapping, so this is very helpful for me to find the midline.
Yeah, it's true.
You use that as well?
Yes, sure.
Thank you.
And another thing that can help to define the midline is the fluoroangiography in order to see where the vessel in the midline go inside. So sometimes can be helpful to use also this tool.
Okay, thank you very much for your comment.
Yeah. Sardar, actually, appearance of a potential which was not presenting before surgery is quite uncommon.
Yes.
And in such instances, I always suspect that there is a mistake in the beginning instead of it is recovering.
But
There are some studies telling that potentials have somewhat increased, but if you have no potential before and now there is some potential, this is very uncommon, and I don't think if you can rely on it.
Based on my clinical experience, you are right. If the patient has no any amplitude before the surgery, and then during the surgery, even of course we are continue the neuromonitoring, but we cannot see anything after the surgery.
The opposite is true, however.
Yes.
If it disappears or gets smaller, this is true. But
Yes,
it
that's
gets
why-
better. You cannot rely on it.
That's why I used to nothing or all criteria in neuromonitorization. So if I see the very small amplitude during the surgery, even in very severe dropping, I continue the surgery.
Thank you.
Okay.
I think we have finished here, and we will come to the next panel. Thank you.
Thank you, Dr. Sardar, for that talk. Thank you, Dr. Mehmet Zileli and Dr. Khalid Mahmood for moderating. We continue on to our next session, which will be on PEDS and peripheral nerves. To moderate this session, I would like to invite Dr. Hassan Syed and Dr. Riaz Ahmed Raja. Yeah. Our first talk will be given by Dr. Samir Al-Baba, who will be joining us via Zoom. His talk is based on fetal surgery.
So first talk on the fetal surgery, a keynote lecture by Samir Al-Baba from USA.
Good afternoon, colleagues and friends. Can you hear me well? Can you hear me?
Yes, we can hear you.
Yeah. I'm greatly honored to join you and esteemed colleagues and faculty at the World Federation education course in Karachi. Sorry I could not be with you in person. I'm looking forward to seeing you all again in the future. My friend Salman Sharif and the esteemed faculty, thank you again for the kind invitation. I'm honored to share with you some data about the field of fetal surgery for spina bifida. And as we all know, spina bifida is a global problem. Neural tube defects, we can consider it as a global disease. Here in the US, out of 1,000 pregnancies, 1 or 2 will get affected by spina bifida or open spina bifida. We know the etiology is multifactorial, can be genetic, environmental, but we know that metabolic etiology is very essential in prevention. We know folic acid prevention remains the main factor in helping reducing the incidence and prevalence worldwide. The problem is when we look at the world map, we see that a huge part of the world, it's still affected by spina bifida with low rates of folic acid fortification. In some countries, like in neighboring India and other countries in Africa and South America, the numbers are actually alarming. 4 to 8 cases out of 1,000 birth pregnancies are actually affected by spina bifida, and those numbers are actually alarming. If you look at the excellent work done by the Global Alliance for Prevention of Spina Bifida and with the World Health Organization, unfortunately, only 23% of the world countries are doing fortification of folic acid right now. So the question is, as we know, prevention should be our first goal, but what should we do for cases we cannot prevent? As of today, the standard of care worldwide remains to perform the postnatal repair. Typically, we do it in the first 24 to 48 hours. In many countries worldwide, this repair is delayed beyond 1 to 2 days after birth because of many social and transportation problems, and depending on which part of the world you live in. Those are 3 babies from my own practice. We still do postnatal repair for the cases that are counseled and not considered candidates for the fetal surgery. What is fetal surgery? Fetal surgery is, you can consider it an operation on 2 patients at the same time. While the fetus is connected to the mother through the umbilical cord, a comprehensive multi-specialty team, including pediatric neurosurgeons, are involved in doing the repair before 26 weeks of pregnancy. And the goal is to close the defect, continue the pregnancy after closing the uterus, and keeping both the mother and the fetus safe. How does spina bifida repair in utero works? We all know the pathophysiology of hydrocephalus or the Chiari type 2 malformation has to do with the leak of CSF from the spina bifida defect very early in pregnancy. As early as 15 to 18 weeks of pregnancy, we start seeing a hindbrain herniation and Chiari type 2 malformation, which leads to fourth ventricular outlet obstruction, which leads to the obstructive hydrocephalus. And the MOMS trial was a prospective randomized trial funded by the NIH, costed $7 million, randomized prenatal and postnatal repair. And the primary outcome of the MOMS trial was looking at mortality, rates of shunting for the hydrocephalus at the age of 1, as well as look at secondary outcomes, looking at motor and cognitive developments at 30 months of age. The trial had to be stopped early because of positive outcomes. Here we can see when we compare the standard of care, postnatal repair to the right side to the prenatal repair under 26 weeks of gestation, you see the rates of shunting dropped in half from 80 down to 40%. And also the hindbrain herniation or the Chiari improved in most cases. Most exciting part of the trial was here when they found that the babies who had fetus surgery at the age of 3 years, they function 2 levels below the anatomical level, which is very impactful. So a fetus or a baby, a newborn at L1 myelomeningocele, as we know, high percentage of them can be in wheelchairs. The ones who had fetus surgery functioned at L3 or lower, which means that now they're walking with crutches or a walker. And if we look at the percentage of kids who walked independently by the age of 3, it was over 40%. Obviously, the mother had to pay the price by increased rates of maternal complications. The average gestation age at birth from the trial was 34 weeks and 1 day. And the most alarming part of the trial was here, that 13% of the babies who had fetus surgery were delivered prematurely under 30 weeks of gestation. And the mortality was at 3%. So the take-home message from the MOMS trial was the rates of shunting for hydrocephalus after fetus surgery dropped in half, with improved the Chiari malformation in almost all cases, improved motor function and cognitive function, and the cost of increased prematurity rates. Follow-up studies looked at other factors like urological, orthopedic anomalies, and found retrospectively, not prospectively, that those kids who had fetus surgery, their neurogenic bladder was partially improved. Then the ACOG, American College of Obstetrics and Gynecology, came out in 2017 with this recommendation. that all pregnancies complicated by fetal myelomeningocele who meet established criteria based on the MOMS trial for in utero repair should be counseled in a non-directive fashion regarding all management options, including fetus surgery. And since this came out in 2017, the rates of in utero repair in North America increased dramatically. I've been fortunate to be working with an amazing team, first in St. Louis. As soon as the trial was closed in St. Louis, I was part of the team. We did 60 cases. Since then, I moved to Florida, and in Orlando so far, we have done 54 cases, and I have been involved with over 12 cases internationally, and hopefully we can get one in Pakistan in the future. Criteria are very, very strict for inclusion, exclusion criteria. We continue to follow very religiously. We follow the criteria based on the MOMS trial. So the level of the myelomeningocele has to be between T1 and S1. There has to be evidence of high-end brain herniation. Gestational age has to be under 26 weeks, and there has to be documented normal karyotyping or microarray based on amniocentesis. And the exclusion criteria, primarily maternal, are long, and we follow them very strictly. When the referral is received, we do the ultrasound, then we do the MRI. Here you can see the MRI, large ventricles, Chiari malformation, and the myelomeningocele. This fetus actually is 22 weeks. The maternal-fetal medicine team, who are the essential partners with neurosurgeons in performing those cases, along with the anesthesiologists, neonatologists, and many other team members who are all important in delivering this treatment successfully. The amniocentesis is done by the MFM team. And at our program, we also do 3D printing. We found it to be very useful in understanding the defect. One of the challenges in fetal surgery that you operate on a patient you never met. You've never seen how complex the lesion is. So 3D printing actually was useful in trying to get very good anatomical assessment of the defect, especially for the large defects that are flat, more challenging to close in utero, like myeloschisis. Again, I have to emphasize the importance of teamwork. You cannot do this alone. You have to work closely with colleagues from MFM, anesthesia, and neonatology, and many other services. We do ultrasonography, Q3 minutes. We replace amniotic fluid in the operating room. And I can tell you, I have been involved in performing this surgery in over 10 countries right now worldwide. And I can tell you, fetus surgery is cheap when it comes to equipment or the setup. Basically, there is almost all of you in the room can perform this surgery if you have the team trained to do it, but you do not need special equipment. After the mother goes under general anesthesia and lithotomy position, after an epidural catheter is placed, phenosteel incision is made. Then the uterus is explanted. We work together from skin to skin, MFM team and neurosurgery. After the uterus is explanted, then we start using the ultrasound to localize where the defect is, as well as where the placenta. It's important to make the opening in a way that's close to the defect, but at the same time, far from the placenta, since we need the placenta for the rest of pregnancy. Then the uterus is open. There are different techniques, some with staples, some with the suturing. The company that makes the staples are not making it anymore, so we're going to old school hysterotomies now. Then in our practice, we bring the microscope. Here you can see the amniotic membrane is stapled and sutured into the uterine muscle. You see the back of the fetus. You see the tube, which is replaced in the amniotic fluid, artificial environment to keep the baby warm. And we make sure that the umbilical cord is not kinked. We do continuous monitoring every 3 minutes for the heart rate. If the heart rate drops, means either there's some bradycardia from hypothermia or because the umbilical cord is kinked and we have to adjust the fetus. Those are some more challenging cases, which are the myeloschisis. You can see wide defects, wide lumbar fascia is exposed, long placoid, and those are the cases that are challenging to close in utero, but we've been fortunate to close all of them so far. The technique continues to evolve. We adopted over 10 years ago a pure microneurosurgical technique to perform those closures. Exactly the same technique we use postnatally. First step is retubularize or reneurulate the placode, followed by elevating the dura circumferentially off the underlying lumbar fascia and epidural fat, bring it to achieve as much as possible a watertight closure, followed by closing the skin with or without a graft. I give all the credit to my mentor, Professor Ghazi Yassergul. I've been privileged to be mentored by him in my early career as faculty, and he was the first one to actually push the field of fetus surgery to go into microsurgery. And he always used to tell me that treat the myelomeningocele in a 24-week fetus similar to an AVM or a brainstem tumor or an aneurysm, and this should be done microsurgically. We adopted this technique 100% now in all the cases. You can see here, the mother is in lithotomy position. I'm standing between her legs, my MFM colleague from one side and my assistant from the other side. Here are some pictures from the early cases we did almost 14 years ago when we used to do 2-layer closure. Here you can see I'm closing the dura on top of the placode without neuralalia of the placode. I only did this technique for 2 years. And in 2013, I started 100% 3-layer closure. We start by injecting the back of the fetus and the right buttock with a cocktail of anesthetic, fentanyl, vicuronium, and atropine epinephrine, followed by doing, here you can see sharp microdissection to excise the arachnoids surrounding the placode circumferentially. This is done while protecting all the nerve roots without sacrificing any of them. This saline is injected like a tissue expander to elevate the paper-thin dura off the underlying lumbar fascia. Now we're elevating the dura circumferentially. Underneath, there is the lumbar fascia and paraspinal muscles. The next step now is to do the tubularization of the placode. This is done by 8-0 or 10-0 proline suture approximating pia to pia. To go and show the young colleagues in the room step by step, if you look at the diagrams on the top, here you can see the amniotic fluid is replaced. One of the challenges of fetus surgery, you're operating on a moving target. So the fetus is doing micro movements from the continuous irrigation, and you're doing microsurgery with sharp dissection on a moving target. So with time, it can be challenging, but we have been blessed to be able to achieve all the cases now microsurgically. Next step, again, is tubularization. You can see in the top left, flat placode, to the right, tubularized placode. Now has been tubularized. The next step is to achieve the watertight closure. Occasionally, for low lesions that reach the sacrum, we may need grafts like dural substitutes, and I truly believe in doing watertight closures in all cases. The last step is doing undermining of the skin circumferentially. This is one of the easy cases. Only 40% of the cases can be closed primarily, like in this case, small myelomeningocele case. This is an easy one. The medium-sized defects, 2 to 3 centimeters, I call them mild to moderate myeloschisis, complex lesions. They need an inlay skin graft, or what we call alloderm graft, used by plastic surgeons. We do mattress closure on top. And how about the wide lesions, like in this one? This is a very complex wide myeloschisis defect, and those are the cases we do only alloderm. After that, the amniotic fluid is replaced, the uterus is closed, and we put the uterus back into the retroperitoneal cavity, and we maintain the pregnancy as far as possible. Typically, we aim for an elective cesarean section at 37 weeks pregnancy. By day 1, usually the spinal cord is going through like a spinal shock, not much of movement in the legs. By day 2, we start seeing fetal hip and knee movements. By day 3, we start seeing knee extension and ankle and toe movements. Again, we push the pregnancy as far as possible for elective cesarean section at 37 weeks. And 70% of the cases, the back is fully healed and without even needing any dressings. We do early functional assessments as soon as the babies are born, but even the defects when we use, complex defects when we use large alloderm inlay or unlay grafts, we have been very blessed by doing wound debridement at birth and then doing wound care at home. We're able to achieve excellent healing. It's beautiful how the skin epithelializes beautifully on top of the graft. Here you can see a baby was born with an exposed graft. They go home in 1 or 2 days, and the mother will come in a week or two to the office, and this has been closed completely. The more experienced we become, the smaller the incisions have been. Now we have been doing most of the hysterotomies around 4 to 5 centimeters. In the old days, we used to do 10 or 12 centimeters. All those are recent cases, and you can see the openings are becoming smaller and smaller. So what happens now? Like this fetus, on the left side is the MRI at 25 weeks pregnancy. And now after the repair at 32 weeks, we do another MRI. Look what happens here. The CSF on the sagittal T2 MRI for this fetus, you can see beautiful reversal of the hindbrain herniation with CSF surrounding the cerebellar tonsils. Actually, CSF also surrounding the spinal cord and beautiful skin on top of the closure. We do also MRIs after birth at 6 months of pregnancy, and we're very happy to report very low rates of tethering because of the tubularization technique that we believe is essential in reducing tethering rates. When we compared our first 50 cases to the MOMS trial, we compared maternal, fetal, and neonatal complications. We found the results are very comparable. Actually, this applies for all busy fetal surgery centers. The busier you are, the better outcomes you'll have, and even better than the MOMS trial. The MOMS trial, gestational age at birth, 34 weeks and 1 day. Our data in Orlando, a little bit better than 34 weeks of 4 days, now 34 weeks and 6 days, almost 35 weeks of pregnancy. We have been blessed that all lesions have been closed successfully, 0 maternal and fetal mortality. We have perinatal mortality 3%, similar to the MOMS trial, and 60% of our kids walk independently at 3 years. And the average neurosurgical repair time is 43 minutes. And we typically do the cases around 24 weeks and a half. And there are different techniques to be used. Some other centers, like this group at CHOP, they use modified myofascial closures. This group at Vanderbilt, they like release incisions. I don't use release incisions, but some colleagues use them and they have good outcomes as well. When we looked at our data, look at what causes preterm labor, we found that doing fetal surgery under 23 weeks of pregnancy led to high rates of preterm labor. So now we're pushing most of our surgeries around 25 weeks. And now there's more and more interest worldwide in the experimental fetoscopic surgery, doing it endoscopically with or without laparotomy. I do believe fetoscopy is the future. The problem is the rates of complications and tether rate outcomes are really concerning right now, but the technology continues to improve. And the people who are doing fetoscopy, I do believe, are doing great work, but there's a still long learning curve and still considered experimental. Around 2017, we published our data, look at our first 60 cases, looking at ETV outcomes rather than shunting. ETV was never studied in the MOMS trial. And this data we published for the first time, look at large series, look at ETV outcomes. And we found that the cutoff that we feel is good for ETV after fetal surgery after birth is around 4 months of age. When we look at our shunting rates right now, we're in the range 25%. It's because we are doing a lot of ETV or ETV CPC. And now our center is part of the prospective randomized trial, the ST trial. So some of our babies are getting randomized to shunting. So our numbers are a little bit higher than we would like them to see. And does the technique impact the future tethering? And the answer is yes. We're in the process of publishing our data. I cannot share it with you now, but we're very blessed that right now we're showing that the impact of the microsurgical closure on lowering the rates of tethering. Again, as I mentioned earlier, experimental fetoscopic repairs are showing great momentum, but unfortunately, we're still dealing with high rates of tethering, like this data from Istanbul, Turkey, showing very severe tethering in the first year of life after fetoscopy. But again, the colleagues who are doing fetoscopy are continuing to make great progress. Like this great team from Texas Children's in Houston, and doing great work, really improving the fetoscopic techniques. And it's important to track down the outcomes through the North American Fetal Therapy Network, the NAFNet. The more experienced we're becoming, the more minimally invasive we're heading in that direction. Again, nowadays, most of our hysterotomies are small, are in the range of 5 centimeters or less. What is the future outside of spina bifida? I think slowly we're heading into expanding the armamentarium of what we can do. This group in Brazil, in Sao Paulo, have published data a few months ago looking at doing, for selected indications for encephalocele, doing fetoscopic repairs and showing positive outcomes of impacting the hydrocephalus. The learning curve is very long. We worked with colleagues in Brazil and anatomical simulators for myelomeningocele, training for colleagues, and we found this to be essential in training before going to the operating room. And most importantly, we have to track the outcomes of those kids very well, especially the kids who are with high lesions like thoracic or high lumbar, who walk with assisted devices. We need to monitor them to make sure they do not decline. But the most concerning for me are the kids who had fetus surgery and they're walking independently. Those are the kids we need to monitor to make sure they don't get into complications in the future. International collaborations are important, and looking forward to partner with you and colleagues around the world. We have been blessed with a team in Dubai. Around 4 years ago, we did the first surgery in the region, and have been blessed to visit the colleagues at Aga Khan University in Karachi a few years ago. And a group from Karachi came to Orlando, visited us as well. Many colleagues in India also working on setting up their programs. And this is truly teamwork. None of us can do it alone, and partnership is essential. In conclusion, fetal myelomeningocele repair is gaining excitement and momentum worldwide after the MOMS trial. In our center, we believe that the technique matters. We believe that spinal plaque tubularization can lower tether cord outcomes while maintaining safety outcomes for the mothers and babies. And it's important to track the outcomes prospectively. Fetoscopy is showing great momentum. And at the end of the day, pediatric neurosurgeons should be the ones to take the lead in deciding which techniques are best for long-term ambulatory outcomes and tether cord outcomes. Thank you. And again, it has been a pleasure and honor to join you at the WFNS course. Thanks to my friend Salman and the organizing committee. Thank you very much.
If anyone has any questions for Dr. Samir Al-Baba.
I have one question. Is the Dr. Al-Baba is there?
Yes, I can hear you.
Meantime, when you are closing the meningocele defect, and at the same time after the patient develop the hydrocephalus, so how you can deal the case if you are going in utero repair, after the 1 or 2 months, the child develop the hydrocephalus then?
So, great question. So in most cases, after the in utero repair is done, within 2 to 3 weeks, we start seeing hindbrain herniation reversing. And once you start seeing the hindbrain herniation reversing, the severity of hydrocephalus in most babies will stop progressing. It will stabilize. As you know, the brain is growing, so proportionally the ventricles will grow a little bit, but the threshold we always look at is 15 millimeter mark. Once the diameter of the width of the ventricles reach 15 millimeters in the fetuses, in the obstetric data, we call this severe hydrocephalus. And when this happens, nothing is different. There's nothing you and I can do about it. You have to just continue the pregnancy, keep the mother and baby safe, and deal with the hydrocephalus after birth. But I can tell you, those babies are very different. Even when they're born with large ventricles, because they had fetus surgery and the myelomeningocele reverse, their hydrocephalus starts brewing and starts progressing very slowly. And in over 100 cases I've done so far, almost 120, 130 cases, I can think I've only shunted less than 5 babies before leaving the hospital after birth. All the rest, if they ever develop the need for CSF diversion via shunt or ETV or ETV CPC, typically it happens a few weeks or months after birth.
Okay, thank you.
Thank you.
My question is how you will follow the CSF leak in case of if you do not do a watertight repair and there is CSF leak. Is there any impact of CSF leak in the entire uterine cavity, or is there any impact of communication between the amniotic sac and the intraspinal cavity? Is there any impact?
The answer is no. And in utero, there's no way for you to track CSF leak. There's no way. It's impossible. After birth, we have not seen a single CSF leak in over 6 years because we achieved watertight closures in all our cases. For colleagues and centers who do not do watertight closures, and they still have low rates of CSF leaks, and those are easy to manage by taking the babies to the operating room to do a very quick patching or closure repair of the dura. And typically, you do not need like rotational flaps. Usually by doing skin and fascial approximation, you'll be able to repair it soon after birth if you encounter it.
Thank you.
Any other questions?
Just one question. Are these fetal surgeries having any subsequent impacts on the next or the subsequent pregnancies of mothers?
Excellent question. Thank you. So obviously the mothers go through extensive counseling before the operation. One of the essential requirements for a safe outcome is to avoid any pregnancy for a total of 2 years after the delivery of this baby who had fetus surgery. All our mothers, over 100 of them, all the ones who elected to become pregnant again, after 2 years, they had 0 complications. The very tiny percentage of them who happened to become pregnant in less than 2 years, some of them had uterine dehiscence, and in one case, uterine rupture that was reported. Because you're putting this uterus through 2 cesarean sections, the wall of the uterus is weak, so it's important to wait 2 years before the next pregnancy.
Sir, I have a question. So how many cases of T3 card you have seen yet?
So, thank you. So right in the first 60 cases that we did in St. Louis, we had 9 tether cord cases. Now in over 50 cases in Florida, we only had 4 cases. We claim, and again, we're in the process of publishing this data, we found statistical significance that the technique actually matters. The better the closure is, and the better microsurgery we do to do the repair, the lower rates of tethering
I
we
have a
deal with.
supplementary question. So do you think this T3 card is actually due to adhesions at the surgical site, or it may be due to the hypertrophied phylum terminal, which is usually with these lesions?
Yeah. So this has been studied actually. When the group in Philadelphia at CHOP looked at their tether cord outcomes, they found that 60% of them were due to inclusion cysts, like dermoids or epidermoids. In our data, it's around 20%. What happens is when you do a quick repair, and some skin cells will be buried inside the under the dura, and those cells will multiply, and this will lead to inclusion cysts like dermoid or epidermoid. The other percentage are the ones who are from scar tissue.
Thank you.
Thank you very much. That was an excellent talk, and I just want to emphasize the point that Dr. Samer mentioned, that the operative technique is very critical, as opposed to some centers who are doing a quick closure. But I'm looking forward to your long-term results as well. So thank you very much.
Thank you, Sayed. Pleasure to see you again. Thank you.
That concludes our session on PEDS. We will now head for a small tea break for 15 minutes.
Very good evening to all of you. So we are starting our last session. I will invite Dr. Deborah about her presentation on management of the injection injuries, and also at the same time she has to be given the presentation on the non-discogenic brachyalgia and sciatica.
And the amazing hospitality. It's really an honor, and especially it's a big pleasure to be here. So, as you know, I'm Italian, and ancient Romans used to say dulcis in fundo, which means the sweet part comes at the end. So this is why the last session is for peripheral nerves. So I'm going to talk about management of injection injuries, which seems to be a quite statistically significant problem because the medical literature reports up to 50% of nerve injection injuries in series related to iatrogenic injuries. So this means that they are actually the most frequent type of iatrogenic injury. And unfortunately, the majority of them are caused by intramuscular injections, which are given by non-professional staff. Actually, I have to say, I think this is probably not the only cause, because typically these injuries seems to be present in very skinny people. So also we have to consider that there is a cofactor which is also related to the body mass index of the patient that received the injection. Unfortunately, the majority of these injuries occur in children. And based on the site of the injury, we may have two main clinical presentations. If the injection was administered in the deltoid, then the patient may present a wrist drop due to a radial nerve injury. If the injection was an intramuscular injection in the gluteus, then the patient will present a foot drop consequent to an injury on the sciatic nerve. So why do we get a nerve injury after an injection? Well, the causative mechanism is a little bit complex, and we may simplify it in related to the direct needle trauma, the chemical injury, and the perineural fibrosis and scarring consequent to the injection of the chemical agent. Now, the direct needle injury is very often overestimated. It exists, and it's also dependent on the angulation of the injection. If the angle of the needle penetration into the skin surface is equal to 90 degrees, then the depth of the penetration is great, and the needle can actually reach the central part of the nerve and cause an intraneural injury, resulting in the immediate effect of the functional deficit. And usually in these cases, we have even up to severe neurological deficits. When the angulation of the needle with the skin is less than 90 degrees, then the needle does not exactly penetrate inside the nerve, but it mostly remains in the perineural area. And therefore, these are the cases which are milder with less severe neurological deficits. But the direct injury related to the needle is not the main thing. We have to consider that this is basically a chemical injury. So we have identified some chemical agents that seems to be more neurotoxic than others, and this is a list, and you can see that we have penicillin, diazepam, and also a number of other drugs, including steroids. Now, once you have injected the chemical agent, which is neurotoxic, and it has penetrated into the nerve, symptoms usually become manifest approximately 30 minutes after the injection. So the patient will develop either the wrist or the foot drop. So the patient starts to complain about pain, then there are sensory disturbances which are anyway not as significant like the motor deficits, which are definitely the most worrisome and the most important concern from our point of view. There is something that we have to say. The clinical presentation of sciatic nerve injuries due to intramuscular injection is quite peculiar. You know that the sciatic nerve is quite a thick nerve, it's as thick as my thumb. So it's usually what happens is that the chemical injury does not affect the whole trunk of the nerve, but we see that the medial component, which is the one that eventually will continue distally as the tibial nerve, is preserved, and the damage is mainly related to the lateral component. So the patient has a foot drop, but then when you examine neurologically the patient, you see that the tibial distribution is still working well, or at least better than the peroneal distribution. Now, concerning the management of these patients, we do not really have clear guidelines, although I have to say that some authors in the literature have mentioned that the patient that present a full wrist drop or a full foot drop should be probably given an indication for surgery as soon as possible, and some authors even advocate that you should go for surgery within the first 24 hours after the onset of the symptoms. Others, and I would belong to this group, advocate a more conservative management, and they consider that the patient should be monitored clinically and also with electrodiagnostic studies. And then if we see that there is no improvement within 6 months, then maybe 8 months also for the sciatic nerve, then we could consider that there is an indication for surgery. It's not mentioned in the literature, but from my point of view, it would be also important to give an indication for an ultrasound, especially to rule out the possibility of the superimposition of an abscess. So it's always something that, you know, the imaging always gives you additional information. Now, what is the natural history, which is actually the reason that supports why we are in favor of a conservative management? Approximately 50% of the injection injuries seems to present a spontaneous recovery, although in some cases there might be some sequelae with residual deficits. These are actually quite frequently observed. In those cases where we do not have a spontaneous recovery, what can we do? We do have surgical options, and these are represented by internal and external neurolysis. Some authors have advocated that you might actually resect the segment of the nerve which has been damaged and then go for a graft repair, and we also have the option on tendon transfers. So, when we compare the outcome, we are going to see that neurolysis seems to provide the best results. So basically, a surgical exploration with external neurolysis and then an internal neurolysis seems to be extremely beneficial. I've done a few cases, and I have to say that really there was a very favorable outcome. I have never personally attempted any resection of the damaged segment with graft repair, but the literature seems to consider them less favorable in comparison with the option of neurolysis. And then finally, tendon transfer definitely seem to be a very reliable option, and certainly this should be the first choice when you have a late referral case. So this is a 5-year-old little girl that came to my observation after she had developed the foot drop when she was not even 1 year old. And in this case, I certainly gave an indication for a tendon transfer. As you know, the tendon transfers have to be considered as an indication when the donor muscle scores more than M4. So in these cases, there was a good tibialis posterior, and the transfer could be done successfully. The other option, if you have a wrist drop to a radial nerve injury, this is a fantastic painting that is in the hospital of Guadalajara in Mexico, is the triple transfer according to Merle Daubigny. Now, because this is an educational course, I thought that it would be a good idea to introduce you to this amazing project, which has been developed by a Bulgarian neurosurgeon, Dr. Tomas Piriev, It's a three-dimensional atlas for neurosurgery, which actually won the award of the EANS 2 years ago. And I really urge you to Google it and study that, especially for young people. It's providing you an amazing atlas and excellent anatomy. And if you want to know more about our activities, start following us on the social media. Thanks for your attention. I will obviously be available for questions, but I think we can now proceed to the second presentation, because as Dr. Riyad said, we thought that it would be easier to go for presentations back to back, as it's only Carlos and I, and so that we save time. So my second talk is about a topic that I believe it's extremely important for all neurosurgeons, because we are going to talk about non-discogenic brachialgia and sciatica. Now, obviously, complaints of pain and paresthesias along one of the limbs are one of the most frequent complaints for neurosurgeons. And in over 90% of cases, we know that degenerative spinal pathology is the cause of brachialgia or sciatica. However, it has been estimated by the literature that approximately in 10% of cases, MRI does not show findings consistent with degenerative pathology of the spine, or it might be that there is actually no correlation between the clinical presentation and the imaging, which is, by the way, something which is always crucial. And we also have to consider that in the population over 50 years old, that unfortunately is represented in this room as well, even if you are asymptomatic, there might be findings consistent with degenerative spinal pathology. So it's quite tricky. And for those of you that do spine, maybe you should consider that some of your cases of failed back surgery syndrome might be related to misdiagnosis. So what are we going to say about non-discogenic symptoms? How can we explain them? Well, we are starting to talk about that, and I'm trying to provide you an overview and show how peripheral nerve surgery is essential for also those that do spine. So let's start talking about non-discogenic brachialgia. Now, to your disappointment, I have to say that herniated cervical disc does not seem to be the only cause of brachialgia. Actually, you have a plethora of medical conditions. There is a very wide spectrum, and if you have a look, you can see that few of them are actually related to peripheral nerves. And by the way, nowadays we have a lot of neologism in the social media that actually refers to entrapment syndromes. So the first one I would like to talk about is thoracic outlet syndrome, which is very frequently a cause of non-discogenic brachialgia. Its incidence is certainly underestimated. There is a prevalence in the female patients, and this is also related to the fact that these patients typically may present a specific phenotype. I call it the Modigliani phenotype because these ladies usually have a long and slender neck with narrow shoulders. So this is basically an entrapment syndrome affecting the neurovascular bundle for the upper limb, which is related to the fact that it crosses a region of the body where there is a narrow passageway. And if you have anatomical anomalies that make it even further narrower, or factors that alter the relationship between the container and the content, then you may have the development of the symptoms. Now, we are all familiar with the fact that there are three main groups of thoracic outlet syndrome. Of course, we are not going to focus on the vascular forms, but we will focus on the neurogenic TOS, which basically divides into two subgroups, with and without neurological deficit. The form with deficit, neurogenic TOS with deficit, is actually quite easy to diagnose because you have the typical development of muscle waste both in the thenar and hypothenar areas, and it's the so-called Gilead-Sumner hand, and it's very easy to be detected. But the problem comes when you have the form without neurological deficit, where you have no anatomical anatomy, anatomical anomaly detected on the investigation, so there's no deficit, and these are cases where even the electrodiagnostic tests are unremarkable. So how do you diagnose them? Well, basically, we have to consider that it's important to focus on the multi-radicular distribution of pain that starts from the neck and radiates to the shoulder blade, and then mostly follows the ulnar distribution, with paresthesias also associated in the ulnar distribution, or occasionally on the whole end. But these patients may also complain about pain that radiates at the axilla and the lateral thoracic wall. In men, I have observed that very often there is a radiation in the pectoral area, which unfortunately was misdiagnosed as cardiac pathology at the beginning. In some patients, approximately 1/3, there is a proximal radiation on the ipsilateral hemiphase and the nape, and also migraine. And a few patients occasionally may present also a very subtle ulnar sign. Typically, pain and paresthesias worsen at night, and the patient also complains about having a swollen hand at awakening. Sometimes there might be also discoloration at awakening. And these symptoms worsen when carrying weights or whenever they have to do actions that imply a repetitive or prolonged shoulder abduction. Now, you're all familiar with the fact that textbooks report a number of provocative tests. The ones I personally use are the last three, the Roos test, the traction test, and the Tinel sign. And then the focus of my diagnostic workup is on imaging. All patients have to be screened with cervical spine MRI, and then a brachial plexus, and then the electrodiagnostic studies as well. The MRI of the cervical spine usually shows findings which are not significant or not consistent with the clinical presentation, but all these patients present a straightening of the cervical column, which is consistent with the muscle spasm that is typical of TOS. Electrodiagnostic studies are useful, although unremarkable, because sometimes they detect the superimposition of other entrapments. But the core of the assessment, from my point of view, is the dynamic MRI study of the brachial plexus. So basically, we compare the three sides of the compression, and then we see what happens between the neutral and the shoulder abduction. And if we see that there is a reduction of the space that is equal or higher than 50%, this is very likely to be symptomatic, as you can see here. You can clearly see how the costoclavicular space is narrowed in shoulder abduction. Surgical approach, neurosurgeons prefer the anterior approach, but I'm not going into the details of the surgery. Another cause of brachialgia, although quite neglected, is related to brachial plexus tumors. And then there is something that I would mention, because I have seen quite a few cases of this syndrome, which has been given indication for surgery by spine surgeons. The so-called Parsonage-Turner syndrome, or amyotrophic neuralgia, which is an immune-based neuropathy that might be triggered even by mild trauma or infections, that specifically involves the upper roots of the brachial plexus or the spinal accessory nerve. And these patients typically present an acute onset of pain that then subsides spontaneously after weeks. The pain is always multiradicular, and afterwards there is a fast development of muscle waste in the shoulder girdle. And something which is really typical is that you see that there is a significant discrepancy between the motor impairment and the complete lack or very mild sensory loss. This is very important because, as I said, a lot of patients have been given an indication for surgery. Now, in these cases, if the diagnosis is early, we can do administration of steroids with good results. The mainstay of the treatment remains physiotherapy, and for the surgical treatment, there are now suggestions of going for neurolysis, but it's quite controversial. MRI sometimes shows you very clearly the inflammation affecting the plexus, and the EMG is usually very typical. Final words about brachialgia. Consider that very often the misdiagnosis also comes from the fact that the patient actually has a multiple crush, which means that you might actually have degenerative spine pathology that can be associated with entrapment, or you may have a thoracic outlet syndrome associated, for instance, with a cubital tunnel or a carpal tunnel syndrome. Now, some words about non-discogenic sciatica. And I think some of you are probably starting to think, oh, she's going to talk about piriformis syndrome. Well, first of all, yes, this can also called non-discogenic sciatica can also be called like deep gluteal syndrome. And I have to say something. If they gave me just 1 rupee for every patient that has been referred to me saying that they had the piriformis syndrome, I would probably be a millionaire, which I am not. And this means that this syndrome is actually a real pain, because when you have a non-discogenic sciatica, you have to understand what causes the sciatic pain. And look here, we have quite a long list. So what can we find here? Well, first of all, I would urge every time you see a patient that does not have significant or consistent findings with the neurological presentation on the MRI of the lumbar spine to give an indication for an MRI of the pelvis. This is essential. And then we have several things. We may have cysts and tumors in the first place. So for instance, this was a case of a young lady. She had complained about lumbago and paresthesias and some pain radiating down to the knee on the posterior thigh for up to 5 years. And then when finally she was given an indication, so she had done a lot of MRI of the lumbar spine, and only when finally there was an indication for an MRI pelvis, we found out she had the schwannoma that affected the cluneal nerves mostly. Neurofibromas are usually found in NF patients. They might be intrapelvic, subgluteal, or in this case, to present a growth which is both intrapelvic and subgluteal. Some cases may be also malignant, unfortunately. And then there might be cases like, for instance, this ganglion cyst from the hip that gave a considerable compression on the sciatic nerve. All these cases were referred to me as piriformis syndrome, by the way. So, but we do have other situations. So piriformis syndrome, let's talk about it, because I know that you say, so what? Shall we consider it or not? Well, so the idea is that you have a compression at the level of this extrarotator muscle, and the literature would distinguish them between primary and secondary forms. Now, when we talk about the secondary forms, which are usually related to the fact that the patient may have sustained a trauma at the level of the buttock with an hematoma in the piriformis muscle, that therefore becomes quite thick, and maybe also with our consistency. I'll finish in a minute. Then we all agree. But for the primary forms, there is a lot of controversy. Somebody considers anatomical variations of the relationship between the piriformis muscle and the sciatic nerve as related to the onset of the syndrome, but others, and I would be in this group, consider that it's quite unlikely. And you can see a lot of anatomical variation without the patient presenting symptoms. So maybe we have to consider other etiology. Sacroiliitis, that's probably the most frequent cause of non-discogenic sciatica. And I would urge you to include this provocative test when you examine the patient. Professor Qureshi already mentioned them this morning, and I think they should be really included in the neurological examination as well. You may have gluteal tendinopathy that also seems to present like lumbago and sciatica, and ischiofemoral impingement. And in women, do not forget gynecological etiology, and in particular, the possibility of an extra pelvic endometriosis, like the catamenial sciatica, which is a sciatic pain related initially to the period of women, but then that might become continuous and even related to presence of sensory motor deficits. Other causes, we may have vascular etiology. Cases of a persistent sciatic artery with the development of aneurysm are quite rare. I never saw one. Same thing for the aneurysm of the iliac artery, but do not forget that gluteal veins varicosities may exist. I've seen about 4 cases of non-discogenic sciatica related to that. Traumas, we already heard Professor Qureshi mention it in the morning about fractures of the sacrum and the sacroiliac joint, infectious disorders. So in conclusion, we may have non-discogenic brachialgia and sciatica that should be examined with a further diagnostic workup, and keep that in mind, the whole spectrum of neurological differential diagnosis, because that might be responsible of misdiagnosis and failed back surgery. Thanks for your attention. Questions, if any?
Thank you, Dr. Ebra, for such a wonderful talk. I want to ask how clinically we can differentiate sacroiliitis from the piriformis syndrome, and in which patient we should go for the MRI of the pelvis.
Okay, let's put it from one point of view. First of all, statistically, sacroiliitis that can be like a sporadic form and also related to seronegative spondylitis is definitely quite significantly represented. Then clinically, the patient presents some symptoms which are the sciatic pain. They have tenderness, typically along the sacrum. When you examine the patient and you do the provocative test that I did before, you're going to see that, for instance, compression, distraction, Faber, Gasland, trigger pain, and also the way the symptoms manifest. So one of the things which is quite typical is that, for instance, the patient will report that if they sit for long hours, then they have worsening of pain, and then you understand that it's also an inflammatory pain and not a mechanical pain, because usually they report that this pain typically is present also at nighttime, and they might wake up already having pain, okay? And then, of course, as I said, you have to go for investigations. They might have electrodiagnostic tests which are not significant, but if you go for the MRI, you may see that there are alterations typical of the inflammation at the level of the sacroiliac joints. Was I clear?
Thank you.
Thank you. Yes?
The time of EMG follow-up every how many months, and then when you decide to go to neurolysis, in which time you decide to go to neurolysis?
So as I said, this is a little bit controversial, because some authors say that if you have a full wrist drop or a sciatic nerve injury with a foot drop, you could even go within 24 hours after the onset of the symptoms. I think that's a little bit extreme. I'm always quite conservative when it comes to surgery, if I can get the chance. So mostly I follow up the patients up to 6 months for the wrist drop and up to 8 months for the sciatic nerve. And so the first assessment, then usually, so I follow them clinically like every single month, okay? And then I give an indication to repeat the EMG and nerve conduction study every 2 or 3 months. So let's say if the patient comes to me immediately afterwards, then I would do the baseline diagnostic workup. Then I would follow the patient clinically. After 3 months, I repeat the EMG and nerve conduction study, and then again. So it's basically, let's say, 2 EMG and nerve conduction studies. And I always include ultrasound.
As most naive neurosurgeons, I too sometimes think it's a piriformis syndrome. Now we've brought up a whole host of diagnoses, but in the gluteal etiology and in the piriformis, there's been a tendency by the pain specialists to give ultrasound-guided Botox injections to release this so-called spasm. and the radiologists seem to think that the piriformis is edematous or swollen. What is your view on that?
So, I think we should never be black and white. Let's say that, as I said, I'm absolutely in favor of the secondary forms. When it comes to the primary form, it might be that you have some specific anatomical anomaly that might relate to that in patients that maybe have a particularly bulky piriformis syndrome. But at the end of the day, what I have seen is that probably 98% of the cases that were referred to me as piriformis syndrome, when they were better investigated, at the sacroiliitis, and especially, to be honest with you, the differential diagnosis between the tendinopathy, the gluteal tendinopathy, the ischiofemoral impingement, and the possibility that there is tension on the piriformis syndrome is something which is not so easy to discriminate, because at the end of the day, it's related also to the pelvic stability and to the way that we use our pelvis. So, was the patient getting better because of the injection of the Botox? But usually then you also go for physiotherapy, you also give painkillers, anti-inflammatory painkillers. So this, of course, would impact on the inflammatory tendinopathy if there is anything. So, you know, for me, as I say, piriformis syndrome, at the end of the day, I would consider it like an umbrella term that actually has a plethora of other medical conditions. Absolutely, extremely useful. As soon as I have a patient with sciatica that does not show findings consistent with the distribution of the pain, I go for the MRI of the pelvis, often also with contrast, if I suspect that there is an inflammatory case, and I can tell you that usually it is resolutive. And women over 35 years old should always be referred for a gynae consultation.
Dr. Debra?
Yes.
You are really right. The non-discogenic pain, and particularly at the cervical region, and especially the gender-specific, as you said, in the females, most of the time they improve on the antidepressants. And they never give us the time to think about whether it's thoracic outlet syndrome or something else. So what can we do at that time? And you also already said it is very difficult to diagnose these type of the non-discogenic cervical spinal problems in the females, and there is no any exact investigation.
Well, again, as I said, it's not really true that there's no investigation. I mean, this time, of course, as usual, you know, you always have to try to squeeze a lot in a short time. But I could show you that, for instance, the studies with the dynamic MRI shows very clearly that you can actually develop an algorithm giving you a very significant percentage of positivity that it's a TOS. So personally, what I do is that, first of all, I listen to the patient and I try to identify whether there might be factors in our past medical history that may be consistent with the onset of the symptoms. I had a few cases of women, for instance, that started to have symptoms after they had maybe a pregnancy with significant increase of the breast size because of lactation. The phenotype, as we said, is also an indication. The distribution of pain I showed before, and then a few questions that help you to understand that there is a correlation between what the patient does and the trigger of pain, because they will tell you that they cannot, for instance, dry their hair because this movement prolong causes pain. They have difficulties in talking on the phone for a long time, which is something that all women in the world do. So, they are prevented to be able to do that. They cannot carry the bag on the shoulder, which is painful. They cannot carry bags which are heavy. So this already gives you an indication that, and especially, as I said, the pain is multiradicular. So it's a number of things. And then the MRI, the dynamic study, when it's associated, I can tell you, if I have a patient that I examine and has this kind of medical history and neurological examination with a positivity for the RUS test, the traction test, and the supraclavicular TNL, in 95% of cases, the MRI is consistent with a clear narrowing of the costoclavicular space. So for me, it's a quite a straightforward diagnosis. I can tell you that I work in a hospital where before I joined, they had no cases of thoracic outlet syndrome, and I've now operated in 4 years, I've operated approximately on 40 cases. I mean, it's not the most frequent diagnosis, right? So this is why the series cannot be that big. But I had patients who had been in pain even up to 20 years. And after the surgery, they did well. So it's not just a placebo or whatever. This is also something that I consider. It's there because then I see the compression. And very often, one of the things that I see is that not only it's because the elements of the neurovascular bundle are clustered together, but there is an anomaly of the cervical transverse vessels. There is an accessory artery that runs in between the upper and the middle trunk, or the middle and the lower trunk. And because of the compression due to the thick scalene anterior, I think that probably that actually causes what I would say, as a neurosurgeon, a neurovascular conflict, because it's a presence of an artery pulsating constantly between the two upper trunks. So that's my experience.
Need to understand this subspecialty.
Another question?
My question is, how effective corticosteroids are in decreasing the inflammation and healing of nerve post-injection injuries of nerve? Are they effective?
Sorry, I didn't get it.
Are corticosteroids effective in decreasing the inflammation and nerve healing post-injection injury of nerve?
Well, you mean the administration of steroids?
Yeah. Yes.
But what do you mean by administration of the steroids? Like oral steroids?
Oral steroids.
Well, I don't think there is any role for it because, as I said, it's basically a chemical injury that has destroyed the nerve inside. So I don't even know if in that case there might be a penetration of the effect inside the nerve itself, because the chemical injury occurs intraneurally. So I don't know. Maybe generally speaking, it could reduce it a little bit, but I don't think it should be resolutive.
So is there any other treatment will you recommend if we are not going for the neurolysis during the period?
In terms of medical treatment?
Yes.
No, I think the only thing that might be helpful in these cases would be just to refer the patient for physio as soon as possible, just monitor them, and pay attention that they don't develop any deformity consequent to the wrist drop or the foot drop especially, and then, wait if they can spontaneously recover. That, as I said, happens in approximately 50% of cases, or they have to go for surgery.
I think we are getting late, so we have to proceed for the another presentation.
Well, I'm delighted that there were so many questions. So shall I?
Thank you. So we'd like to invite Dr. Carlos Rodriguez, who's going to be talking about facial nerve injuries as well as the management of benign peripheral nerve tumors. Thank you very much.
Okay. Well, only 100 slides now, don't worry. Okay, well, first of all, I want to thank to the organizing committee because of the invitation, and especially to Dr. Sharif. And I also want to congratulate to Deborah because of her incredible effort leading the PNS committee in this federation. So now I'm going to talk about the facial nerve injuries, okay? All of you know what are the functions of the facial nerve: ocular protection, oral continence, autonomic function, and obviously expression through the innervation of the facial muscles. So as you can imagine, after an injury, several degrees of affections may be developed. So this will have a very negative effect on the quality of patient's life. So some basic information about this type of injury. This is the second cause of facial palsy, okay? The first one is the idiopathic palsy, okay? So many etiologies. The most frequent are iatrogenic injuries, okay? And in this group, CPA surgery is the most common. And then temporal bone fractures, okay? What fractures? Those fractures with a transverse axis or direction in relation with the long axis of the temporal bone that violate the otic capsule and other less common mechanisms. So the management will be determined by several factors, by example, the location, the onset, the mechanism, and the severity. So we can divide the injuries of the facial nerve basically in two locations, intracranial and extracranial. So because of that, it's very important to the school-based surgeons to be aware of the anatomy, the intracranial anatomy during the dissection or the resection of CPA tumors, okay? And for us as nerve surgeons, the knowledge of the extratemporal anatomy of the facial nerve is also very, very important. I mean, in terms of surgical landmarks and also the anatomy for the general surgeons or head and neck surgeons. I mean, in terms of nerve branching, is quite important to avoid or to prevent additional injuries to the nerve. So many strategies to evaluate clinically the facial nerve injuries, but the most common resource is the use of the House-Bragman scale. 1 is normal, 6 is the worst stage, okay? So now here, I'm going to show 3 cases, 3 different cases with 3 different mechanisms, okay? With 3 different degrees of injury, as you can observe. In contrast with other neuropathies, I mean traumatic neuropathies, the use of electrodiagnosis is paramount, okay, to guide any surgical indication, okay? The use of nerve conduction studies, if you find a reduction in the amplitude equal or higher than 90% compared with the contralateral side, well, this is an indication for surgery, as well as signs of denervation on electromyography. The use of imaging studies, well, after the trauma, are not critical for any surgical criteria, okay? But, okay, they provide some information. So, in short, different locations, okay? Then, different mechanisms, the most frequent because of traction or compression. Laceration are less common, but they can exist, okay? And now I'm going to show one suggested algorithm, okay? But what I want to stress here is that, look this, okay? The therapeutic window is very gentle when we compare this injury to other type of nerve injuries. But this does not mean that we need to wait till the last moment to indicate a surgery. And now, referring to the surgical management, there is no technique that restores for completely the facial function, okay? And now, what are our goals? Eye protection and oral competence, functionally speaking, and aesthetically speaking, symmetry and recovery of the smile. So we can divide the techniques used for the management, the surgical management of facial nerve injuries in 2 groups, okay? Those used for the restitution and function, and those used for the substitution of the function. The first group, dynamic procedures. The second group, static procedures. And now I'm going to refer in the rest of the talk to the use of nerve transfers. Why? Because this is the most common resource that we use as nerve surgeons, okay? But first, I would like to show you this reconstruction of a facial nerve with the use of an interposed graph, okay? Here you can observe an neuroma formed exactly at the site of the division of the nerve, okay? Not amenable to be reconstructed through a direct reconstruction. So the use of a graft, and you can observe, well, the results are not bad. But what about the use of nerve transfers, okay? Basically, the use of the hypoglossal nerve and the mesenteric nerve. And the use of hypoglossal nerve can be divided basically in two main techniques, okay? The classic techniques. In this technique, we need to cut the facial nerve as it exits the stylomastoid foramen, and then the hypoglossal nerve is used, okay, the complete nerve to be rerouted proximally and to be anastomosed with the facial nerve. With the hemihypoglossal facial nerve anastomosis, okay, we need to drill the mastoid, and after this we can reroute the facial nerve distally closer to the hypoglossal nerve, and after this we can use only one part of the hypoglossal nerve to be reconnected with the distal stump of the facial nerve, okay? The use of grafts are no longer used, or I mean, they are not common unless you have any contraindication to do the other two procedures, and the use of mesenteric nerve to reconstruct the function. So now I'm going to show you the technique, the classic technique of hypoglossal facial nerve anastomosis, okay? After an intratemporal penetrating trauma, look the time, almost 2 years after the injury. So the hypoglossal nerve has been rerouted proximally, and then it will be connected with microsurgical technique using non-absorbable microsuture with a traumatic needle in an end-to-end fashion with the distal stump of the facial nerve. And after this suture, we can use fibrin glue to reinforce our line of suture. This is the result. After 1.5 years, not bad results. And what about the hemihypoglossal facial nerve anastomosis? Look, drilling the mastoid, then we need to cut as proximal as possible the facial nerve, and then this nerve will be relocated distally near from the hypoglossal nerve. And with a very meticulous maneuver, we need to obtain some part of the hypoglossal nerve, and after this is possible to connect this proximal stump with the distal stump of the facial nerve, also in an end-to-end fashion. And then reinforcement with fibrin glue. The difference, okay, in terms of time and in terms of recovery of function, not bad results. And what about the mesenteric facial nerve anastomosis? Personally, I don't have experience with this technique, but this case was provided by one of my friends, Wilson Faglioni from Brazil, okay? This is the result after the reconstruction of a facial nerve with the use of mesenteric nerve. Also good results. So, the static procedures, we can see a huge list of many options, okay? But as you can see, these are options more related with the skills of a plastic surgeon, okay? And what about the outcomes? As you can observe, the difference of the donor axons is interesting, okay? But with the three techniques, we can do a perfect size match, also performing a direct coaptation, that this is more important than the number of axons in terms of reconstruction. And the results, in general terms, they are very similar. But the main concern or the main issue with the use of the hypoglossal nerve are the expected complications. I mean, tongue atrophy, okay? And this is severe with the use of a classic technique. You can observe the difference between the classic and the hemi-hypoglossal facial nerve anastomosis. But over time, the patient can deal with this expected complication. And what about the spontaneity? Okay, this is not possible with neither of the two nerves or techniques. Okay, so in conclusion, careful clinical evaluation, support your indication for surgery on electrodiagnosis, okay? Don't delay the surgery. Remember that we have many options and many strategies to deal with this type of injuries. And for sure, a multidisciplinary team is paramount to achieve the better outcomes. And this is the facial team in my hospital. And by the way, Christian Heinen asked me to show you this announcement for a couple of meetings that we are going to have in Hamburg on, at the end of March. Okay? Well, now, okay, I don't have any trouble. Any question?
You have the second topic also.
Okay.
और वो चीज़ों से मेडल है उसको ऊपर ही सेट कर दें ये उनका है ये हमारा ये जो ये यहीं का है